Can someone share the
Hey
YouTube?
guys, welcome back. Welcome everyone. So hope you guys completed your first session of NEET PG. So I have very short panel discussion on how the exam was, how to prepare for the future things, and we'll definitely start with the recall soon. We had a little bit pushed it to 7:30 so that the exam gets over, so that everyone who is in the first or second paper can pitch in, right? So I have with me Dr. Sandeep, Dr. Rishabh, and Dr. Hira. So welcome everyone. And just quick question to you guys. I'll go to Dr. Sandeep first. Sandeep, what's your take on how is surgery questions has made any change? Because this was a paper supposed to be made very quickly, and we also sent a notification recently, a couple of days back. They have not yet completed the paper, right? So, what's your take on surgery questions?
Right. So I had the privilege of interacting with all the students at the center. So I could actually get their head, and a lot of people when they came out, no, see, it's an exam session, same thing as it was previously. But when you come down to question paper per se, a lot of students who came down to me were like, sir, question ka topic was known, right? But the depth of the question has become very, very, conceptual. तो जो बच्चा फैक्ट्स रट के गया है या फिर यू हैव टेकन वन लाइनर और जस्ट ओनली प्रीवियस ईयर क्वेश्चंस, उनके लिए बहुत डिफिकल्ट रहा टू आंसर दैट क्वेश्चन बिकॉज अ लॉट ऑफ थिंग हैज गॉन इनटू as a thought process. A simple example, there was a question which was given about the breast. There was a lesion. It was ulcerated lesion. Now the question was, because the lesion was large, was it phylloids or was it is a malignant lesion? There was a liver mets. Again, phylloids can be malignant with liver mets. So again, all these conceptual questions. And the best part here was they didn't ask a diagnosis. They asked the treatment, right? So first you have to emphasize on diagnosis, then come across a standard component, and then to talk about treatment. Same thing with that. There was a question on DJ stent, right? We have seen a DJ stent, but then it was a radiograph. And from a radiograph point of view, they asked you, how do you remove it or insert it, right? So again, it was mostly an internship-based question. So again, it felt a lot of, again, it was a very clinical paper, but then the depth of the question was quite there. Students who had a good sound knowledge, who has, prepared well in terms of, conceptual preparation, they found it's okay, but a lot of students felt it hard. So the word is, the question paper was, if you take the scale from moderate to hard, it was more towards the harder side.
Okay, great. So it's primarily testing the doctor in you, not the student in you. Maybe you're not
Absolutely.
taking more the
They
full and
want you
good
to be clinician
doctor.
from right now itself.
Yeah.
Yeah.
So yeah, they are post MBBS, post internship. They are actually going to face the patients, and they must have face the patients as well, right? So it's not just the theoretical part of the student. Yeah, inculcating that's a good thing. Hopefully, in future, it'll help our entire community grow as well, right? So, Dr. Rishabh, like, what's your take on like? Is there any difference between INACT from NEET PG? Because quite a few students commented that like this paper is like INACT. What is your take on like? Do you feel is there any difference at all between the INACT paper which got over recently and the NEET PG one?
Yeah, so sir, we have over the past few years now consistently seen that the INI-CT and NEET PG overlap is almost close to 90-100%. Earlier in prior 2018 era, it was like NEET PG preparation was different, INI-CT preparation was different. But for the past couple of years, we have seen that there is a lot of overlap between the two. And more importantly, now the emphasis is on clinical-based integrated questions. Now, in this particular session per se, I believe that there were more sort of INICT questions. Why? Because the exam got postponed at the last moment. So, the INICT had just concluded. AIMS already has a very good question bank. The authorities must have approached AIMS to make the question bank, to make the question paper for NEET PG as well. And that is what is being reflected in the exam paper right now. So that is my take on this whole scenario, sir. Whatever may be the scenario, it is good for the country, for the students also, and especially for the well-read students. It's fair to them if the questions are more clinically oriented. I think that is the way forward to go.
Okay, great. Mitali and happy. Yeah, we'll definitely come into those parts and questions on Gisela, atresia, and whatever it is, Dr. Sandeep will definitely take it ahead. And ma'am, question to you, like I've been teaching for quite some years, but I feel that this is the batch which has been tested left, right, and center, right? Back, forth, postponement, preponement, lots of things. And even this time also, there were few people like the center was flooded. They were not able to get access into it. Some of them found it very difficult in the rain to travel to it, right? So what is your take on, like, how should these young students prepare themselves mentally for any of the competitive exams?
I think they're really testing us and they're making us the truest doctors, because our spirit is about curveballs being thrown in our face, and not everything is textbook in life same way. One thing that we should recognize is that maybe for the next few years, this is the pattern that is going to be the 2 batches, right? So the stress was palpable. We were all stressed. They were stressed. I think stress was a common elephant in the room. But we may have to start now studying from the point of morning and evening batch, because some of us are very productive in the morning, some of us are very productive late in the night, but afternoon wala zyada log nahi hote hain. So for the future, we do need to start preparing from the batch sense as well. That is one take. And yes, this time there was a lot of circus, I would say. There was a lot of playing with the students' emotions. Hopefully that will not repeat, and it will not be so chaotic. That's my hope against all hope. So I want to tell students that please prepare to deal with the stress, but hopefully this curveball will not be thrown all over again. That's my wish as a teacher, of course.
Okay, great. So thank you, ma'am. So thank you all. And yes, Mithali will take those questions as well, anterior compartment syndrome soon. And hello, Dr. Bhavya. Good evening. Good evening to everyone. I hope you must be tired. Just put on your headphones, listen to it. Everything is done and dusted. We'll have a quick recall. We'll be starting with Dr. Jagdish. So thank you everyone in the panel, like Dr. Sandeep, Dr. Rishabh, and Dr. Ira. So Dr. Sandeep and Dr. Rishabh will also connect with you guys with a paper analysis on the morning shift and the evening shift, maybe around 9:30, 10 p.m. Right? So stay tuned to that. For all the future aspirants, see how it is compared, and we'll definitely come up with what is normalization score and how it works. Hopefully that won't happen in the future, but still, let's have a look at that also soon. Fine. Thank you, ma'am. Thank you, sir. Bye-bye.
Thank you, guys. Bye.
Jagdish, sir. Okay, over to you.
Hi, everyone. I hope you can hear me. So, looks like this ENT paper, whoever the examiner is, उसने हमारी नाक ऊंची कर दी है, because almost everything is asked from nose and a little bit from head and neck, and only 2 questions from otology. I don't know if we've got all the questions yet or not, but it looks like more nasopharynx, nose, and head and neck dominant paper tha. We won't take too much time. As expected, almost every question was image based, and they have also, given you clinical application based, which is something that I have been personally telling, and many of the faculty members are telling, that the trend is moving towards clinical. The trend is moving, towards image based questions and clinical application. That's why there's some things that but you may have got confused the way they would have positioned it. Now here, there's an X-ray. You can see this is a battery in the esophagus, and we're looking for the double ring sign. Though some students may see that you cannot see that sign very, very clearly, but if you look, then you will see this kind of a, 2-ring, approach. And this is very, very a standard question. And even from answer of exclusion, if these were the options that you were given, steeple sign is seen in laryngeal croup, string sign is seen in Crohn's disease in the small intestine, and thumb sign is seen in epiglottitis. So just by answer of exclusion also, you can get this. If the options were anything different, to mujhe bata dena, and we will then modify and reevaluate. Okay. Now, this is a question which you guys already know the answer for, but I think some of you got confused the way this question was presented, because this is a clinical application based question. Singer is unable to sing high notes. There is bowing and little depressed unilateral vocal cord. Which muscle is affected? The same question olden days was asked, which is the only muscle in the larynx that tenses. Then you would have immediately said cricothyroid. But when the tensing goes away and the vocal cord becomes a little flaccid, you're not able to hit high notes, which is a clinical application. This is how a singer or a patient may present to us in our OPD. And there are many ways that the examiner can play around with presentation, but you have to have that clinical applicability. They're talking about tensing, because to increase the pitch, increase the tone, you need to tense the vocal cords. And what the cricothyroid does is it pulls the thyroid cartilage a little forward. So it pulls the thyroid cartilage in the forward direction, causing the vocal cords to become longer, right? And that is why you're then able to, see able to increase your pitch. Okay, so I think no confusion over here. Cricothyroid muscle should be the answer. It's also covered very well in our lecture series also. Nerve supply of the pinna, you can see over here. I think I'm not very clear ki question exactly kaise pucha gaya tha. Some students are saying that, they were given the nerve and the area which it supplies on an image based. And I think you were supposed to, select the correct one. This is also very straightforward. It's a PYQ. बहुत बार पूछा जा चुका है. Auriculotemporal nerve will supply this upper part. It is this auriculotemporal nerve, supplies a part close to the temple. Over here, it is a branch of the, mandibular branch of trigeminal nerve. Baki vagus nerve and facial nerve, of course, they supply the external auditory canal sensation. Greater auricular nerve comes from the C2 and C3 division, and lesser occipital from the C2. And all of these, I think, were very, very straightforward. Good evening, Dr. Priyanka. So, identify the condition based on these images. So what interestingly they have done this time is जो पहले बहुत theoretically पूछते थे, image डाल दिया है, या they are asking you from a clinical way. Okay, so cartilaginous syndrome, this ciliary dysmotility syndromes have been asked many times in the past, and it is also quite an important thing. Though clinically ये cases हमको बहुत कम दिखते हैं. But here you can see that there is situs inversus. You can see that the heart, the mediastinum is on the other side. You can see some sinusitis or nasal polyposis, and you can see a lot of bronchiectasis. So all of the three go towards cartilaginous syndrome. Very, very straightforward. Young syndrome, you will also see these two, but you will have azoospermia over here. Not in atrophic rhinitis, in Young syndrome. And in cystic fibrosis, basically any duct in the body, from the lungs to the liver to the ureters, everything gets blocked because of wherever there is ciliary dysfunction. So that presents very differently. Cartilaginous syndrome with the situs inversus itself, with this image itself, you can be very, very clear that this was the answer. So it was not a difficult part in terms of ENT. The questions were not difficult, but they were presented a little bit more image-based and more clinical application that may have thrown some of you away who were just probably, learning point to point. All right. Identify this part of the implant. Now, this is an X-ray. The view that we use is called Stenver's view. We covered this in our classes, though they did not ask the view because view is a little outdated, but they asked the parts of the cochlear implant. And I think the part that was asked was the electrode array, the part that goes into the cochlea. Though there are other parts like the speech processor, which is outside, and the transmitter, receiver, and all of that. Lakshmi saying second session ENT was very difficult. Lakshmi, if there's any question that I have not covered, please let me know. And then, I will cover that. And I think tomorrow we're going to have a recall for that aspect as well, which is the investigation of choice for juvenile nasopharyngeal angiofibroma. There is no ENT paper complete without JNA ka ana, juvenile nasopharyngeal angiofibroma, kuch na kuch to aata hai. This was very, very straightforward. Of course, a contrast enhanced CT scan is the best way to see this vascular benign tumor in the nasopharynx. Biopsy hum karte nahi hai. MRI mein ye dhang se dikhega nahi. It is within the bones. And diagnostic nasal endoscopy mein, you can only get a clinical suspicion, but it is not the investigation of choice. So marked structure is not in inner ear by Jagdish Gade. Okay, so what was the marked structure? It was a part outside. Then let me know, maybe in some way, because we were not able to get the exact image and what was being asked. But it was a cochlear implant, or was it a bone anchored hearing aid? That you're able to know. If there was no part going inside the skull, then it is a bone anchored hearing aid. But if there is this wire and all of that going inside, it's a cochlear implant. Option was CT-PNS and CCT, Pranjal is saying. Yeah, so there's a difference there. So if they give an option of CT-PNS and CECT, then that would be contrast enhanced because it's a vascular tumor. So this would be the way. And when we write contrast enhanced CT scan, we write PNS. Nahi to kahan ka contrast lena hai, right? So when it's contrast enhanced CT scan, that is what we need for juvenile nasopharyngeal angiofibroma. Okay, outside, but it's a thin wire. So you're saying It may be appearing outside, Jagdish. I think, outside in a cochlear implant, there is no thin wire. Thin wire is usually going to be there, going inside into the, cochlea. But once we get a sense of kya image dikhaya tha, we will then be able to pick that part properly. Okay. Another question was asked, which is the best stain for biopsy during laryngoscopy for vocal cord carcinoma? Vocal cord carcinomas are usually squamous cell carcinoma, and the H&E stain is one that is used. Supravital stain is used for monocytes. Congo red is used for amyloidosis. And silver nitrate has been used in vocal cord tumors because it picks something called as nucleus organizing regions, but this is super specialty level and it is not considered diagnostic. It is only considered in poorly differentiated carcinoma. So our H&E is the most common one. So Vishal is saying one was inside and one was outside. Okay. So let us go back to this cochlear one. See, sometimes there is a particular thing called as the ball. There is a ball probe, which is a ball ground electrode. And then there is electrode array. If electrode array was given as an option, it is most likely the thing that they will ask when you are pointing at a thin wire. Okay. Yeah, that antenna is a grounding antenna. So that is called as the ball probe or grounded antenna. All right. So this is also very straightforward, ground electrode. Now in Samter's triad, which statement is incorrect? This was also asked here. Basically, this is something that you all already know, but the examiner is asking you to be very sure about, the examiner is asking you about whether you know for sure which part is the person insensitive to. So, in Samter's triad, there are three things. There is hypersensitivity to certain types of painkillers, anti-inflammatory medications. There is chronic rhinosinusitis with polyps, and there is bronchial asthma. Now, here the examiner is asking whether it is sensitivity to aspirin plus its products, sensitivity to aspirin alone, or sensitivity to all NSAIDs. Is asking which is incorrect. And if you ask which is incorrect, it has to be sensitivity to aspirin alone, because it is also, there is hypersensitivity to NSAIDs where there is COX-1, inhibition enzyme. All right. So a lot of people over here, I think on that cochlear question is not clear, and we will be able to have some clarity only when we know what that image was and what it was pointed to. What has been told to us is that the electrode array was the option and then electrode array was pointed to, but we will get back to you on that when we have a formal recall where in detail we will go through the validated questions and its options and its answers. I think this was a question which was very, very straightforward. This is not the image shown. This is just to show you that the osteometal complex, I think, was asked over here in a patient with sinusitis who had probably an osteometal complex block. Maybe they showed you an image of full, sinuses are blocked and the opening is also blocked, or just some mucosal thickening. But I think it would have been a very straightforward question. And as you can see in ENT, very, very clinical shift has happened. Almost everything is image-based. If it is not image-based, it is a clinical-based, application-based. A person is not able to, increase the tone of their voice, then kya hai? What kind of stain would you use if there is a biopsy? So, those kind of basic questions we are moving away from, and this is something we had predicted. So, no, sir, it was maxillary sinus, says Harsh. Either ways, guys, if there is, maxillary sinus, they're asking which is the sinus which is blocked, then it is maxillary sinus. If they're asking which is the area of the blockage, then it would be the osteomeatal complex. Okay. So if there is a sinusitis and this was the area that was pointed to you, if this was the area pointed to you, that is the maxillary sinus that we are talking about. So there was no option like osteomeatal complex, it was maxillary sinus, then it becomes even more easier. मैं बेफालतू में सोच रहा हूँ कम से कम थोड़ा सा लेवल बढ़ा के osteometal complex पूछेंगे. Maxillary sinus is a very clear and then a straightforward thing for you. I don't think you would have had any issues. There's one question which we don't have much clarity on, which procedure is difficult in a patient with shifted trachea. Whether it is tracheostomy, endotracheal tube, or cricothyroidotomy. See, whenever the trachea is shifted, all these procedures will be difficult. Most difficult would be the endotracheal intubation. Putting the ET tube would most likely be the most difficult one. But otherwise, if you're doing tracheostomy or cricothyroidotomy also, it would be. So I think tracheostomy was the option, or endotracheal tube intubation was the option. I don't know. Indirect laryngoscopy would not be difficult, because in indirect laryngoscopy, you're only seeing till the larynx. You're not seeing the rest of the trachea. So that anatomy will not be there. So Shimu, you can give us the correct option. We are also immediately recalling. So not everybody is going to have a very exact recall, but at least the areas that were covered: nasogastric tube, direct laryngoscopy, and laryngeal airway mask. Okay. Endotracheal tube was not the option, basically what you were saying. Indirect laryngoscopy, laryngeal mask. Yeah, laryngeal mask airway also is not going to be, difficult. And nasogastric tube is also not going to be difficult. So, because when the trachea is shifted, it has to be something that is entering the trachea, which is going to be, difficult. But otherwise, the closest would be laryngeal mask airway. Trachea is in place. Esophagus was out of the way. Okay. Laryngeal mask airway. Okay, then the closest we will take is laryngeal mask airway, because it is some form of intubation and airway. All right. If esophagus is shifted, because esophagus is connected to the trachea, then NG tube insertion can be difficult. But let us just revalidate this and get back, because when you're going back into the food pipe, with the swallowing movement, things will go in. How black thing can be esophagus? So we don't have the image over here, but anyway, we will get back to you with a formal recall. This is just an immediate recall. So I think these were the questions asked in ENT. I don't know if anything else was asked that was missed out. But over to Dr. Sudha now to take you through ophthalmology questions.
Thank you, Dr. Jagdish. Hi, everyone. So I hope I'm audible and visible.
Yes, ma'am.
Okay, so the questions that I have got are, yes, it is, you will have to help me along, because the questions are like very, very rudimentary. We have not been able to get all the options, but as Dr. Jagdish has pointed out, the questions turned out to be more clinical than we had. I mean, we were predicting it would be clinical, but probably we didn't think that it would be so much of clinical and so much of 𝐼𝐻 type. So let's just, I think this is one of the questions that we had, where there was an image, I think, and you were asked that what is identify this field defect? What was the question? Was it something like this? This is what I was told, that there was an image of the enlarged blind spot. There was an image of the enlarged blind spot. So you can see that in here, this is where we have the blind spot, which corresponds to the optic disc on the retina. And you can see that here, the size of the blind spot is, it was much larger than normal. Yeah, it was on both sides of the horizontal line. See, I don't know whether, see, if you had something like this, what I was told is there was 𝐒𝐻𝐿 scotoma in the option. Now 𝐒𝐻𝐿 is supposed to look something like this. Then some students said that there was Rohini's nasal step. Now Rohini's nasal step is supposed to look something like this. And the third option was enlarged blind spot. And enlarged blind spot is supposed to look like this. It was on both sides, both temporal and nasal sides. Did you have images of both the right eye and the left eye? It is likely to be, from what I have gathered, it is likely to be this kind of an image where you have an enlargement of the blind spot. That is what was given, because 𝐒𝐻𝐿 scotoma is something which is like this, which is an arch above on one side. And Rohini's nasal step is something which is supposed to be on the nasal side with a small area of blind spot on the temporal side. Okay, so probably they had given an image of both the right eye and the left eye. And in one eye, the blind spot was, last option was altitudinal defect. Altitudinal defect also does not look like this. It does not look like this. So most probably from what I have gathered, this was the image, and it was probably an image of an enlarged blind spot, which is seen in when you have idiopathic intracranial hypertension. Yeah, that this is the, after confirming from a number of students, this is the image that we were able to narrow down, and I think that probably it was enlarged blind spot. Now let me come to this question. This, I think there is no confusion. It was a question about Wuertz-Ford dot test, right? It was a question about Wuertz-Ford dot test, and I think that the patient is able to see 3 green dots. The patient is able to see 3 green dots. Yeah, so if you have, if the question that was given was 3 green dots, see, this test is done with red-green goggles, where red is in front of the right eye. Red is in front of the right eye, and your green is in front of the left eye. So that's why if the red is not there, so in the image, you can see there are 3 green dots, which means that the red is not there, which means that the right eye is suppressed. Right eye suppression. So if you have 3 green dots, that means that it indicates right eye suppression. Yeah, see, in red-green goggles, red is generally in front of right eye. We rarely have something where you put red in front of the left eye. That doesn't happen. Yeah, so red in front of the right eye, Wuertz-Ford dot test, where 3 green dots were shown, it is right eye suppression. Now, the next question, I think everybody would have answered. That is a patient with night blindness or nyctalopia. This was probably mentioned. And you had this image where you can see that there are bony corpuscles or bony spicules. So in the mid periphery, so there should not be any confusion with this. This has been discussed multiple number of times. It is a PYQ which has come multiple number of times. So this is retinitis pigmentosa. So this is a very, 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 very simple question. Retinitis pigmentosa. Now, I don't know what this question was. Did you get an image on a limbal dermoid, or did you get a question on lipodermoid? Was it a limbal dermoid or was it a lipodermoid? So if you got an image like this, which is close to the limbus, circumscribed like this, that's a limbal dermoid. And if you got something here, this is your lipodermoid. Okay, you got a question on limbal dermoid. So what exactly was the question? Was it just an image-based question? Yeah, so it was a question on the limbal dermoid, but what was the question? Did they say that what is the syndrome that is associated with this? So if this was it just an image-based question? A boy with this, yeah. So it was an image-based question. So this is a limbal dermoid. I also think from whatever I have gathered, it is limbal dermoid only. So there was this kind of a circumscribed lesion, which is close to the limbus. Okay, diagnosis. So this is limbal dermoid. So that is also something which I think most of you would have answered. Yeah. So this is a limbal dermoid. Lipodermoid had come previously in some exam. I cannot recall which, but this is limbal dermoid. This one, the second picture that is, it's a limbal dermoid. Now, another question that came is another simple question, I think, was on Horner syndrome. That ptosis in Horner syndrome is because of which muscle? Something like this. So again, simple question. Yeah, it was limbal dermoid. If there was a hair in it, that makes it even better, actually. That makes it even better, the diagnosis. So, yeah, next was the question on ptosis, correct? Yeah, which is the muscle that is affected. I think this everybody should have been able to answer. It is the Mueller's muscle. The Mueller's muscle, because Horner syndrome, this is oculosympathetic palsy. So it is the sympathetic nerve supply which is affected, and therefore the Mueller's muscle is affected. And so we have a mild ptosis. Yeah, I think ye bhi sabne answer kiya hoga. There would not have been anybody who would not have probably answered this. Now I come to the difficult questions. There was this question on PCO. That is the 𝐒𝐿-Schnick's pulse, a proliferative PCO showing 𝐒𝐿-Schnick's pulse. Some image like this was given, but I do not know what is the question. Was it just the diagnosis? What is the PCO? Or did they ask what is the treatment for this? Yeah, if the dermoid had some hair on it, that makes it better. That just tells you that it is a dermoid. It is a limbal dermoid. Yeah, there was a question on PCO. That is what I was told. But I could not exactly recall what is the question. So this 𝐒𝐿-Schnick's pulse. What is the diagnosis? That was the question. So if that is the question, then that's really easy. Depends on what is given in the option. So either they would have given PCO, or they would have given 𝐒𝐿-Schnick's pulse, or they would have given after cataract. Any of these? Okay, a patient after 3 years of cataract surgery presents with this condition and decrease in vision. Yeah, so this is the image. I mean, an image which is similar to this, or this is an image I just put up, but it said that okay, so I don't know. See, you are saying that there was option of pseudophakic bullous keratopathy also. But see, pseudophakic bullous keratopathy will have an image of the cornea. It is not going to have an image of the lens in the capsular bag. It is most probably PCO only. That is what I can guess, because this is the image that most students are able to identify with. But see, if it is patient presents 2 to 3 years after cataract surgery with decrease in vision and the slit lamp image is given, the likelihood of it being PCO or after cataract is very high. Now, of course, other options like pseudophakic bullous keratopathy is possible after cataract surgery, but then in PBK, you would not have this image. Now, you would have an image of the cornea. It's an image of a hazy cornea. Yeah, so I think it is probably this only PCO. It's unlikely that they would have given something on PBK. Now, another question that came to me was this one. See, this is, I don't know whether we should call this as an ophthalmology question or we should call this as a medicine question. Probably there was an image of a KF ring on the cornea like this, which, and maybe some other things, other information about the patient was given, which makes us understand that the diagnosis is of Wilson's disease, right? And the test, what is the test for diagnosis? Something like this was given. What is the diagnosis? So I don't know whether 24-hour urine copper estimation was there in the option. 24-hour urine copper estimation was there in the option. This is more a medicine question, so probably the medicine faculty will be able to answer it better. Yeah, I do not know what options were there. This is an integrated medicine question, actually. So probably the medicine faculty will be able to take it up. I just wanted to tell you that it's a question probably integrated between medicine and ophthal. So this greenish ring that you can see, that is the KF ring, which gives us a diagnosis of Wilson's disease. Yeah, I don't know what options were there, actually. This is one test that is... Yeah, I would request the medicine faculty to take this up and they'll probably give you a better answer as to what is the best test that is to be given. Yeah. This will be discussed in medicine in detail so that you know that. There was another question in ophthal. See, this is the question that there was a picture of thyroid ophthalmopathy, right? There was a picture of thyroid ophthalmopathy and it was apparently a difficult question with confusing options. Right? Yeah, it was a difficult question with confusing options. I think the question was, which of the following is false? Right? So one of the options was no specs classification is used. That is correct. And it improves in thyroid status. This also is correct. Improves after improvement in thyroid status. Now, the other two options are not very clear as to what they were. Now, I think another option was 90% of this are have hyperthyroidism on diagnosis. Was this the option? 90% are hyperthyroid on diagnosis. No specs classification is used. That is correct. It improves after improvement in thyroid status is also correct to a certain extent. And yeah, now 90% tend to be hyperthyroid at the time of diagnosis. This was there, or it was, no, this was not. 10% tend to be asymptomatic. 10% people may have it as a normal finding. Or did they say 10% may have maybe euthyroid on diagnosis? Was the option 10% are euthyroid on diagnosis? 10% are euthyroid on diagnosis. See, the truth is 90% of them are hyperthyroid on diagnosis, and 10% may not be hyperthyroid on diagnosis. So इसमें से कुछ था शायद. And the other option which students are saying that vision loss may be seen in some cases. Now see, vision loss may be seen in some cases if it is a severe proptosis. A severe proptosis is associated with optic neuropathy, and it is also associated with exposure keratopathy. So vision loss may be seen in some cases is actually correct only, because vision loss may be associated with exposure keratopathy as well as optic neuropathy. In severe cases of proptosis, you can have vision loss. So now I don't know exactly what were the options. I can tell you that, see, 90% patients with thyroid ophthalmopathy tend to have hyperthyroidism. If you do their thyroid status, it will be hyperthyroid. No specs is used. It improves after improvement in thyroid status, and vision loss may be seen in severe cases due to exposure keratopathy and optic neuropathy. It improves generally to a certain extent after improvement in thyroid status. To a certain extent, it will improve. Now, whether the improvement is parallel to treatment, we cannot say that how much thyroid has improved, that much this was improved. No, but it improves to a certain extent after the thyrotoxicosis improves. Now, these options were also not clear as to what it was. Probably it is either the first one or the first one, I think, that because that option is not being properly recalled. This is one. And the last one was a question on an optokinetic drum. Always was there in the option. It always improves after improvement in thyrotoxicosis. Then it's not correct, of course. If it always does not improve. Always improves, that is not correct. If they say always, then maybe we could take that as the option, because always it will not improve. It always may not show a significant improvement rather. So we have to actually look at the options correctly to be able to come down to the answer. And I think there was a question on the optokinetic drum. Now in the optokinetic drum, see, the fast phase will be opposite to the direction. It is opposite to the stimulus, and the slow phase will be in the direction of the stimulus. And the slow phase is in the direction of stimulus. There was no drum, or was it optokinetic nystagmus? Optokinetic nystagmus. Yeah. Was the question on optokinetic nystagmus? Okay, so that means it was not there. So this is not a question there. Yeah, so that means this was not the question. So these are therefore of the questions. See, the Horner one was easy. The PCO one was easy. The limbal dermoid was easy. Retinitis pigmentosa was very easy. Even Wirtz 4-dot test was doable. And this enlarged blind spot also, I think it was, according to me, it was probably enlarged blind spot. So at least most of the questions were doable in Ophthal, but they were clinical. It was not like it was not a typical one-liner kind of question, a little more towards the INI-CT side than probably expected. That is the verdict of the paper. Yeah, we'll come back with a proper recall for all of you. This is just very, very basic, collected from most of you, and most of you are tired and not able to recall. So we'll come back with a proper recall soon. So I would request the next faculty to please take over.
Thank you, ma'am. Thank you guys for your constant inputs, and I welcome Dr. Pradeep, sir. Next will be anatomy. So let's go ahead and quickly see. I think sir said that he'll be completing every recall question in 10 minutes. Pradeep, sir, over to you. Hey guys, so how was the exam?
No
So I think
specs is used. It improves after improvement in thyroid status, and vision loss may be seen in
think it'll take a couple of minutes for Pradeep sir to join. Okay, sir, here. Vivek sir, you are ready? I think Pradeep sir is finding some difficulty in joining. Okay. So what is it?
that because that option is not being properly recalled. This is
Pradeep sir, you can start. You're on mute, sir.
So, hello students. Let us begin with anatomy. Okay, a superficial recall. बाद में we'll just pile up together and give a complete recall to you. Let us begin. Okay, I'm audible. Fine. Let us begin with the first question. Have a look at this. Okay, this was the question. Location of myenteric plexus in Hirschsprung's disease. Students, we know there are two plexus. One is Meissner's plexus, which is located in the submucosa, and the second one is this myenteric plexus, also known as Auerbach's plexus, which is located in the muscularis externa. Now we know this Hirschsprung's disease, that is a congenital megacolon, and this is due to absence of ganglionic cells, right? So this ganglionic cells would be absent in this myenteric plexus, which is located in the muscularis externa, right? So Meissner's plexus in the submucosa and myenteric plexus or the Auerbach's plexus in the muscularis externa. So answer would be muscularis externa here. Both plexus locations were asked. Okay, that's fine. So Meissner's is in submucosa and Auerbach's is in muscularis externa between the longitudinal and the circular muscles of the GIT. Clear? Fine. Very good. Very good. So you've answered this. Coming to the next question. This has already been discussed by Sudha Madam. Ptosis and Horner syndrome. Yes, that is due to involvement of cervical sympathetics. And this leads to Horner syndrome. The muscle affected, yes, is the Muller's muscle, right? Muller's muscle affected. Fine, this was just discussed now.
So molars muscle, easy question. I mean, all of you must have answered this, right? Coming to the next question, I'm very fast. Umbilical discharge of fecal matter. Bacho, can you answer this? Okay, that's the umbilicus. This is the yolk sac, and there's a communication between the midgut loop and the yolk sac. What is this communication known as? The vitelline duct or the vitello-intestinal duct, right? Normally, this entire duct is going to obliterate off. हाँ, ठीक है ना? Both the plexus, तो दोनों हो गए ना बच्चा? दोनों हो गए ना? Right. So this duct is known as the vitelline duct or the vitello-intestinal duct, which connects the midgut to the yolk sac. Normally, this entire loop disappears off. If this entire tract disappears off, if this entire tract remains persistent, this is what we call as the fecal fistula, right? Fecal fistula, or this is what we call as, yes, the complete patent vitello-intestinal duct. Most of the times what happens, the distal part of this duct obliterates off. The distal part goes off and the proximal part remains here. The persistent proximal part of this vitelline duct or the vitello-intestinal duct is known as the Meckel's diverticulum. Meckel's diverticulum, right? Yes. Between the circular and longitudinal layers is the barabar hai wo. Urachal sinus. Urachal sinus kya tha? Urachus, what is urachus? It's a connection between the urinary bladder and the umbilicus. This also we have discussed it many times. Between the urinary bladder and the umbilicus, there's a connection, there's a communication which is known as urachus or allantois. After birth, this communication obliterates off. If it persists, there will be a communication between the urinary bladder and the umbilicus, and the child will be passing urine through the umbilicus, right? I've told you this many times in the lecture. What is this known as? This is what we call as a weeping umbilicus, or this is what we call as a urinary fistula. Urinary fistula. ठीक है? Meckel's diverticulum clear है ना? ये vitello-intestinal duct है, and urinary fistula is due to persistence of urachus or allantois. ठीक है? Okay, fine. Yes, बच्चों. Ileal diverticulum. Fine. Okay, whatever I've got, I'm telling you. The rest will then compile for you. Okay, Brodmann's area. Yes, students, this you must have answered, all of you. Was this question there? Brodmann's area number 22. What is this? That's the Wernicke's area, right? Wernicke's area, also known as the sensory speech area. This is located in the superior temporal gyrus. And what is it concerned with? What is it concerned with? Just one moment. Yes, bolo. What is this concerned with? This is concerned with receptive speech. Receptive speech. Okay, understanding what we are going to hear, that is receptive speech. What is expressive speech? That is the Broca's area located in the superior frontal gyrus. That's Broca's area, right? So this is receptive, correct? I think this must be easy question. Sabne answer kiya hi hoga. Wernicke's area, Broca's area. We have been discussing this always in the lectures. Okay. Sensory nerve supply of pinna. Yes, this is a previous year MCQ, PYQ hai ye. This also most of you must have answered. Sensory nerve supply of the pinna. I've drawn this for you. The view from the outside, the external view, this part is supplied by the auriculotemporal nerve. The lower part of the pinna is supplied by the greater auricular nerve, and the external acoustic meatus is supplied by the auricular branch of vagus along with the facial nerve, correct? So auriculotemporal nerve, greater auricular nerve, and the external acoustic meatus is supplied by the auricular branch of vagus and the facial nerve, correct? Yes. And this is the medial aspect. When you reflect the pinna, the upper part is supplied by lesser occipital, the lower part is supplied by the greater auricular, and the medial most part of the pinna is supplied by the vagus and the facial nerve. Expressive speech deficit. Expressive speech will be Broca's area, bacha. Harsh. Expressive speech jo hai na, that will be damage to the Broca's area. 22 is Wernicke's area, that will be receptive speech damage. ठीक है? Okay. Okay, omphalocele. Bacho, this you must be knowing. The midgut loop, when does it herniate outside the umbilicus? Herniation of the midgut loop occurs at 6 weeks and it comes back by 10th week. If this midgut loop doesn't come back into the abdominal cavity, Yes, if the midgut loop is covered by amniotic covering, what do you call this as? Omphalocele. And if it is exposed without any covering, this is what we call as gastrochysis. So omphalocele contains what? Options the ectoderm, endoderm, amnion, chorion. So the answer for that would be amnion. So omphalocele, wherein the outermost covering is the amnion, the next covering would be the Wharton's jelly, and the innermost covering would be the peritoneum. Peritoneum. Right. So answer for this is amnion. Very, very good. Very good. So I'm just looking at the comments, what you're answering. Contents nahi bacha, I'm just telling you. I'm just telling you. So it would be lined by peritoneum innermost, followed by Wharton's jelly, and the most outer covering would be amnion, right? So omphalocele contains the covering would be amnion. Fine, students. Chorion nahi hai bacha. Chorion is something different. Okay, so this were the anatomy questions that I've got for you. The other questions which are left, we'll compile it for you and then we'll discuss it together. Okay, I hope most of the questions you must have answered. Thank you for your patient listening. Chorion kya hai bacha? Chorion. What is chorion? The extramyonic mesoderm. Extramyonic mesoderm, pata hai na? And the cytotrophoblast. The syncytiotrophoblast, the cytotrophoblast, and the extramyonic somatopluric mesoderm, that is chorion. Right? And amnion is the extramyonic somatopluric mesoderm and the epiblast. Right? Thank you for your patient listening. Thank you. Ranjit sir, take over.
Thank you, sir. Thank you, sir, once again. Next will be Dr. Vivek.
Amnion
Sir.
pe option.
Vivek, sir, over to you.
Can you hear me? Hello?
Yes, sir. Yes, sir.
Yes, sir.
Okay, okay. First of all, students, take a bow. Really. मतलब इतना आप एफर्ट्स कर रहे हो, इतने टाइम से कर रहे हो, फिर एग्जाम और उसके बाद फिर आप डिस्कशन को आके बैठे हो. क्या बात है यार. मतलब सच में मैं सोच रहा था अभी कि मैं एफर्ट्स करता हूँ इतने, लेकिन आपका तो टेक अ बाव. चलो, तो फिजियो के क्वेश्चंस देखते हैं. अक्सर ये होता है एंड इट ऑलवेज हैपेंस कि फिजियो की स्ट्रेंथ क्या है कि हर सब्जेक्ट में आता है, और फिजियो की वीकनेस क्या है, हर सब्जेक्ट में आता है. तो the questions which I think are physio questions, I'll discuss, and then you can prompt me wherever you can add more. Okay, chalo, तो let's start. ये एक routine question always asked in every exam, but I think this time it was in the garb of some clinical question. A case of diabetes mellitus, hyperglycemia, and insulin resistance is suspected. So which transporter is downregulated? Basically, they are asking which GLUT is insulin-dependent glucose transporter. Yeah. What was the question? I mean, I got this question in this form, diabetes mellitus patient, etc. So Ajay is saying, but anyways, all of you have marked GLUT4, and I think that was the answer. So only thing, it was in the garb of some kind of clinical question related to diabetes. Okay, so nothing to discuss here. It was well by hearted, all the GLUTs, and even for future reference, if you are going to appear anytime later, GLUTs and SGLTs are always asked in every exam. Okay, then okay. They had asked about post-exercise. DM patient was asked to exercise. Which GLUT will be activated with exercise? And there is increased insulin resistance. Okay, so DM patient, insulin resistance, these were the kind of giveaways that you were supposed to mark. I mean, insulin-dependent glucose transporter was being asked. And of course, you know, with exercise, the insulin requirement is less. So everything, I mean, whether it was diabetes mellitus or whether it was exercise, it was boiling down to only one GLUT, and that was GLUT4. So all of you have marked it. Thank you. I mean, that was a very low-hanging fruit, I guess. Everybody marked it. Okay, this is the next question that I got. Select the correct match. Merkel disc, slow vibration, Pacinian corpuscle, fast vibration, Meissner's corpuscle, deep pressure, and Ruffini's corpuscle, fine touch. Was that the question? I mean, it was in the form of match the correct pair or match the following or something like that. But just to give you a quick idea, most superficial is Merkel disc, and it's a mechanoreceptor. There are 4 mechanoreceptors: Merkel disc, Meissner corpuscle, Pacinian corpuscle, and Ruffini's corpuscle. 4 from superficial to deep: Merkel disc, Meissner corpuscle, Pacinian corpuscle, and Ruffini's corpuscle. So Merkel disc for location of touch, Meissner corpuscle, rapidly adopting touch receptor. Pacinian corpuscle was the answer, I think, for the question for this particular MCQ. Most rapidly adapting mechanoreceptor, and therefore it is a receptor for sense of vibration. So anybody on this question? Can you recall this question? Was it there? I mean, it must have been there because many of you said something like this. Yes, yes, Pradyot. Yes, yes, yes. Oh, again, it was a case question, was it, Soumya? Or it was match the following. But anyways, the term vibration was used, and what you were supposed to remember was a very rapidly adapting mechanoreceptor means it detects the vibration sense, and the obvious choice was Pacinian corpuscle. Okay, not case question, just match the following. Okay, people are saying different things, but anyways, all of you might have seen vibration word in it. If it was a case or it was match the following, vibration term must have been there, and vibration receptor, Pacinian corpuscle. No two ways about it. In the frequency of 200 Hertz, Pacinian is the best to detect that vibration. Right. Okay, okay. So half are saying case, half are saying it was match the following. Remember like this: Merkel disc, slowly adapting, Meissner corpuscle, rapidly adapting touch receptor, Pacinian corpuscle, most rapidly adapting, and Ruffini's सबसे deep and slow adapting for deep pressure, massage, etc. Okay. Meissner's for skin stretching was the option. Okay. Meissner was for stretch. Well, stretch is for the deep pressure, stretch, etc. are detected better by Ruffini's corpuscle. Slowly adapting, it will detect the stretch. Okay, okay, okay. So I'll just make that correction over here. Then there was one question related to sour taste. Question related to sour taste. What was it? Meissner was for stretch and Merkel was for slow vibration. Okay, Hamid, noted. Thank you very much. I'm really amazed at your energies, यार. मतलब आप लोग इतना मैं एक्सपेक्ट नहीं कर रहा था, क्योंकि एग्जाम इतना सारा स्ट्रेस और उसके बाद आप रिकॉल कर पा रहे हो, बैठे हो डिस्कशन के लिए. ग्रेट, रियली. सावर टेस्ट के ऊपर कोई क्वेश्चन नहीं था. जीवा इज सेइंग a few students said there was something related to the sour taste. Different receptors. It was a difficult question. Which one, Pradyot? The sour taste wala question. Many students could recall and say that receptor for sour taste was asked. Okay. There was, yes. But it was salty. Taste receptor name. It was, they asked sour taste receptor name. Yes. So just to recall and just to remember the receptors, salty and sour, ENaC. Remember like this, epithelial sodium channel. Obviously salty, sodium, so you can remember like that. Plus additionally for sour, HCN, hyperpolarization activated cyclic nucleotide gated. And then for bitter and sweet, Please remember receptor linked to G protein gustadeucin. Was it there? Different taste buds given and names of the receptors. Okay, correct. So taste buds, fine. They will say salty or sour, bitter, sweet. Does anyone remember this particular option? Receptor linked to the G protein gustadeucin. GPCR options were there. So what were the options? GPCR. This is a GPCR, G protein linked receptor, but the protein name is gustadeucin. Okay, so if it was these options, or let's say they asked about the sour taste, go with G protein coupled receptor linked to the protein gustadeucin. Could anyone see this particular word gustadeucin? You know, gustatory sense means taste sensation. So gustadeucin is the one which causes the transduction from the chemosensation of taste into the impulses. Oh, so you all skipped it. Yeah, this question used to come in the INI CETs, and this time it came in the NEET PG. So fine. Okay. T2R GPCR, and many of you have probably skipped it. Okay, anyways, just remember it for now. Salty and sour, ENaC. Bitter and sweet, GPCR. And umami, mGlu-R4. Umami taste, you know, in that Ajinomoto and Chinese foods, which contains monosodium glutamate, and there is a glutamate receptor mGlu-R4. Okay, Satyam is saying T1RQ, T2R1, GP40. These were the options. Okay, I have noted down the options, and let's we will, when we have a proper session once again, that time we will have a question frame properly with the options. Let's go to the next one. There was an injury and amputation of the right limb, I think, was asked, and then more pain is felt even after 4 years after the amputation. So and the student said even phantom pain was mentioned in the question, and they were asking what is the reason for that extra pain in the neighboring region. Was that the question? Was this the question? Like right lower limb was amputated, and even after 4 years the person feels pain in the neighboring, excess pain, extra pain in the neighboring region. Right limb, okay. So right limb amputation, whether the excess pain was due to enlargement of the nearby region in the cortex on the left hemisphere, or enlargement in the right hemisphere. These were the options. Okay, progressive fibers, which cause the encroachment of the cortex. Question was related to the cortex. Was there a mention of cortex in this? Because till you recall, let me just say something about this. If there is an amputation of the right limb, let's say below the knee, then the area that represents right limb below the knee in the cortex is in the left side, on the left side. That area will slowly will get smaller over a period of time, and the neighboring region, which is represented by some other body part, that neighboring area will enlarge. Okay, projection of right limb fibers in the left somatosensory. Projection fiber, okay. Okay, I'll just speed up, yes, sure. Effect of caffeine on sleep-wake cycle. Was that the question? It will be taken by pharmacology once again, because it was pharmacology-based question. But caffeine on sleep-wake cycle, it blocks the adenosine receptors. Many people only remember the option, a correct answer, that was blocks the adenosine receptor. All right, these were the physiology questions, physio questions that I could get. If you find time after a proper sleep, you may just again tell us the correct questions and correct options. Thank you very much. Over to you, Ranjit sir.
Thank you, sir. Thank you once again. So next we'll be having Dr. 𝐒𝐿𝐴𝐀𝐄𝐝. Dr. 𝐒𝐿𝐴𝐀𝐄𝐝 will be okay if she's here. Thank you, 𝐒𝐿𝐴𝐀𝐄𝐝. Over to you.
Hello everyone, can you hear me?
Yeah, all good.
Yes, thank you. So, hope you're all taking good rest after recovering from the very important exam of yours. So I'll quickly review the orthopedics part. So this was the first question, and I actually feel very happy because this is a basic question which we keep repeating in every revision session we have done. And if you have attended our last session of NEET PG, where we have done in the just few weeks ago. So this was exactly given the sunburst appearance and the Codman's triangle. These two are usually seen in osteosarcoma, if you remember, in the osteosarcoma. But the question was, it is also mentioned that tumor mimics osteomyelitis. So in every session of mine, whenever I explain regarding tumors, I always say that one tumor which mimics infection is Ewing's sarcoma. And you might be wondering that the sunburn appearance is seen in this sunburst appearance is also seen in Ewing's sarcoma. So Ewing's sarcoma, it is usually called as hair on end appearance. And what is the important clue which you have to remember is, yes, the diaphysis. Very good. I'm so happy. So whenever you see the word diaphysis, yes, this is not the image. Yeah, I am also very pretty sure this is not the image, but I'm very happy that you have identified that was the diaphysis, and the answer here would be Ewing's sarcoma. So two important clues was, one is the diaphysis, and second one is mimicking the osteomyelitis. So the periosteal reactions sometimes can be misleading. So, but we also know that the hair on appearance or the sunburst appearance is seen in Ewing's sarcoma too. Right? So that is the first question. Hope you all have done it right. And next, going to the next one. So this was the image which was put up in the exam. Is that true? So if this is the image which was put up in the exam, so the answer here would be, this is an horizontal fracture which you can see on the spine. That is the vertebra. So the horizontal fracture which is extending the three columns, the anterior column, the medial column, and the posterior column. If you see, this is nothing but your chance fracture. So this is called your chance fracture, which is nothing but your flexion distraction injury, or it is also called the seat belt injury, right? So seat belt injury or the chance fracture. Yes, exactly the same image. Okay, thank you. So this is the answer here would be chance fracture. Hope you have all done it right. We have discussed this n number of times even in the revision session, right? So the other type of injuries like the compression, burst, yeah, compression was an option. So compression would be an option, but this is not related to compression. So the answer either would be a chance fracture or a seat belt injury or a flexion distraction injury. So any of these three options you can opt, right? This is not burst fracture. Okay, Ajay, if you have marked it compression, probably that's wrong. It is a flexion distraction injury. It is also called the chance or the seat belt. Okay, next, this was also repeatedly, I have told you that as now they're asking image-based questions more in terms of orthopedics. So this is a dynamic hip screw. And if you remember, we have dealt with this in detail, telling that the screw will be in the head and there is a plate attached to it. So whenever you see a plate and a screw which is going into the head, this is called as a dynamic hip screw system. And this system is usually used in case of treating your intertrochanteric fractures. So IT fractures, the extra capsular fractures. So any of these answers could be right. So if they have given you to identify the implant, so this is the dynamic hip screw. So you can see that there is a screw which is placed into the head, and now there is a barrel plate which is attached, taking care of your IT fracture, right? So the answer here would be dynamic hip screw. Fine. So the options are dynamic condylar screw, condylar plate were also the hip plate was also the options. So it is not dynamic condylar screw DCS. And then what was the condylar plate? Yeah. condylar plate, and then hip plate. So this is this is everything together. There is a screw, there is a plate, right? So this is a dynamic hip screw. So the answer here would be the dynamic hip screw system, right? Next one. What is the duration? What is the duration for cast of the fifth metatarsal fracture? So if you see, the metatarsal fracture are usually the Jones fracture, which we usually deal with it. And the immediate option is the casing, right? We give the below knee casing. And if you go back to the basics, when we go back to how remembering that when the callus is formed, so if you remember, usually we give this to 6 to 8 weeks. So usually we give the cast duration would be 6 to 8 weeks. 3 weeks is the where you usually see the soft callus, right? So this is the time where the soft callus is formed, and you continue it up to 6 weeks so that the hard callus start forming, and now you can ask the patient to remove the cast and start partial weight bearing. So the answer here would be okay, for that chance fracture, Angana, you're talking about the chance fracture. So it need not mention that it is a seat belt type of injury, but usually it is the mechanism of injury would be because of the seat belt, but not necessary that every time it is because of the seat belt, right? So here, the answer of this particular question, that is the metatarsal fracture. In case any metatarsal fracture, we deal with putting the casing, that we usually put the case up to 6 to 8 weeks. Right? So that would be the answer, right? Yes, very good, Alok. If you have answered 6 to 8 weeks, that is exactly true. Now, there was a question on this Gatland classification. I could not exactly get the question, the frame or the stem of the question, but as you all know, we usually deal with the fracture names, right? So one of the most important fracture is your supracondylar fracture, and Gatland is supposed to be an important question too. And what are the types of Gatland? We have 4 types, as you all know, 1, 2, 3, 4. The first one is this is an undisplaced fracture. The first is undisplaced. The second one, if you see, there is a posterior hinge. There is a posterior hinge, right? And the third one here is completely displaced. And fourth one is with multidirectional instability. The second picture was the image. Okay, you are telling that is the B. So if the picture A, it is there, it is simply undisplaced. And if you can see, there is some attachment on the posterior cortex, that becomes type 2. And this is the completely type 3. That is your multidirectional instability. The C is completely type 4, where you see the medial column is also damaged. And it is a very violent fracture, right? Yeah, multidirectional image is that C is your type 4, right? Salter-Harris classification, what was the question which they asked about your Salter-Harris? Okay, first of all, I want to clear it. The supracondylar fracture is not a physeal injury. There is no physis involved in it. It is an extra-articular fracture. It is above the physis, above the condyles. So it is not related with your Salter-Harris. In supracondylar fracture, the ulna was dislocated. So this could be a little complicated version. Okay, so please remember, let's get this clear. First of all, remove that this is nothing related to Salter-Harris classification. What you have seen is if this options were Gatland type 3, 4, Salter-Harris 3 and 4. So Salter-Harris 3 and 4 you have to remove. And you have to just check for Gatland type 3 and type 4. Type 3 is just a displaced type of fracture. So you can see that there is a complete displacement. And if there is something abnormality with the radius and ulna, if there is any other related to it, then it is type 4. As you're telling that radius is dislocated, ulna is seen on something all. If something is there related other than your supracondylar, then you can go for type 4. But if it is a clearly type 3 fracture, just completely displaced, and there is no other thing which you can see, then it is type 3. Hope this makes you clear. So if it is a lateral condylar fracture, then there are 2 types of lateral condylar fracture. Then it could be Salter-Harris type 3 or type 4. So that you have to make me clear whether it was a lateral condylar fracture or supracondylar fracture. So most of them have told me that it is a supracondylar fracture. And depending upon the displacement, like if it is completely displaced, then you have to go for type 3. And if there is any other abnormality, then your supracondylar fracture, like if it is unstable or depending upon that, then you can mark it as type 4. Fine. Yeah, if it is C, then type 4. Okay, fine. Let's close this now. And I want one more question. That is, there was some question related to back pain, and then they have asked you the compression of nerve L3, L4, and L5. Did they mention anything about the disc prolapse? Yeah, compression level. So what was the question? What was the question asked? So if the disc was somewhere around L4 and L5, then what would be the nerve root which is getting compressed here? The lower nerve root, that is the L5 nerve root, right? Yes, if there is one MRI image was there, pain radiating thigh, history of weightlifting, yes. Pain of the posterior aspect, everything is related to your disc prolapse, that is nothing but your sciatica. Yes, whenever there is a back pain which is radiating to the thigh and leg, that is sciatica, and this is associated with your prolapsed intervertebral disc, and we have already discussed in detail whenever we spoke about this. So if there is a disc prolapse between L4 and L5, the traversing nerve root will be compressed, that is the L5. Okay, so depending upon the disc level, if it was L3 and L4, then the L4 nerve get compressed. So I hope this makes you clear regarding your question. Okay, then if it was L5, then you have to have L4, L5 disc, right? So L4, L5 disc prolapse, which will compress your L5 nerve root. Right? So these are the questions which we have got from orthopedics. So I hope we have little come to in terms with the orthopedic questions. Meet you all again for session 2. Thank you. Over to Rishabh sir now.
Thank you, ma'am. Thank you.
Yeah.
Thank you. So, Ranjit sir, should I start?
Yeah, please.
So we had a lot of questions in radiology, and as compared to last NEET PG, this year's radiology questions were a little tougher. And I would like to say that the radiology questions were at par with the INI-CT pattern. And in fact, the whole paper was on a slightly tougher level and in the lines of an INI-CT, as we previously discussed. Now, the first question that I think it will be covered in medicine as well. But this was a question which was given a very good question, and I mean, not a very hard question if you know the basics, but it can be solved even if you don't know anything about the image. So as far as I know, just give me a quick confirmation whether this image was given and what was the exact question that was asked. What was the exact question? So the question that was given to me, which I have picked up from a lot of online sources, is that of a 45-year-old female of a known myasthenia gravis patient, and he had come with proptosis. So yes, myasthenia gravis was mentioned. MG is myasthenia gravis only, and female, and on a chest CT, you are given a anterior mediastinal mass. So this is the mass that is given, right? And so myasthenia gravis, ptosis, any chest mass that you see, what will you mark? It is most likely a thymoma, even if you don't know the anterior mediastinal masses. So basically the question is anterior mediastinal masses, mass, DDs. So the mnemonic for this is 4 T's. Okay, because I think in the paper 2 as well, similar question has been asked regarding an anterior mediastinal mass, and there I think the answer is teratoma. So just tell me in the comment section what were the options that were given to you in this question. So I was talking about the 4 T's. So the 4 T's represent the anterior mediastinal mass is differential diagnosis. So number 1 is thymoma. Then number 2 is teratoma. 3 is thyroid, meaning retrosternal thyroid. And number 4 is terrible lymphoma. terrible lymphoma, meaning a high-grade lymphoma. These are usually the differential diagnosis of an anterior mediastinal mass. And if a history of myasthenia gravis is given with ptosis, you know that 40% of myasthenia gravis have associated thymoma. So the answer here was a thymoma. Okay. Now let's go to the next question. An easy question. Just tell me in the comment section if this was the image which was given. As far as I can see from the online resources, the question was a 6-week-old infant with recurrent vomiting. So a 6-week-old, okay, after a month, not a neonate, recurrent vomiting. In an infant which is not a neonate, first DD has to be pyloric stenosis. If an ultrasound is given along with recurrent vomiting in an infant, it is more sure of it being a pyloric stenosis. So even if the image was not so clear, the answer here most likely is the IHPS. Just please give a quick confirmation in the live chat, which is very, very, very important for us. It is you students who will tell what the question and the options were. Now let's go to the next image. I think this has already been covered by Alekia ma'am in detail. So a question was, as far as I remember, from the resources, the age given was 18-year-old boy. And I think that is what caused a lot of confusion among students. So an 18-year-old boy with a lesion in the femur, in the thigh, right? And the lesion, as far as everybody is saying, was in the diaphysis. And it showed the sunburst appearance, or maybe uplifting of the periosteum like this. Okay, and I have already told you in the classes that Codman's triangle sunburst appearance is not specific for osteosarcoma. Ewing's, osteomyelitis, all can have, but diaphysis looking like a mass, okay, no sequestrum, no involucrum, most likely the answer is definitely Ewing's sarcoma. Now, tell me this question. What was the exact question in this scenario? Okay, this is very, very important. A question related to subarachnoid hemorrhage was asked. What was the exact question? Okay, direct CT, NCCT was given, or a CT angio was given, SH was already mentioned. What were the options? Please tell me in the comment section. Yeah, okay. So Bolini is saying that the exact image was given, and Shashank is saying the question was asking, yes, so there was an NCCT, this is an NCCT, this is a CT angio. So if the diagnosis and cause was asked, yes, the answer is this is a subarachnoid hemorrhage, and this image is showing a saccular aneurysm, also known as a berry aneurysm. But other causes of SH can also be there. So I am saying that if in the question SH was the image which was given, SH due to aneurysm, yes. Just these two exact picks. Okay. So thank you. If SH was given, most likely the most common cause of SH is a saccular aneurysm or a berry aneurysm like this. Other causes like AVMs or AVF, pile AV fistulas can also be there, but they're rare causes. I don't think they'll ask you that. Okay, SH had only one option. Okay, okay. So mostly the answer is SH with saccular aneurysm. Thank you. Now the next question, this is an exact repeat. Of an INI-CT, this is an exact repeat. The last time the question was asked which foreign body, coin and button battery both were given. The button battery was the answer. This time they've asked the name of the sign that you see in the button battery. So I think all of you must have gotten this correct by now. The answer is double ring sign. These two rings, one is an outer ring and another inner one is this halo ring, which is nothing but a step off. ठीक है, बटन बैटरी में स्टेप ऑफ होता है, उसका रिंग है ये. अब I know the image in the exam would not have been so clear, but nevertheless the answer here is a button battery, a double ring sign. Now a Carter-Jenner syndrome question was also given. I am not really sure if the answer was Carter-Jenner or cystic fibrosis, because a lot of students are saying different things. So tell me, was situs inversus given in the question? Because as far as I know, the students are saying that it was a recurrent infection, recurrent LRTI was given, and nasal discharge, mild dyspnea was given. Okay, so polyps can happen in cystic fibrosis. Nasal discharge can happen there as well. So tell me whether dextrocardia was there or not. So if dextrocardia was also there, then definitely the answer is Carter-Jenner syndrome, sinusitis, nasal discharge, dextrocardia. Yes, the answer will be Carter-Jenner in that case. Okay. Now, pulmonary infiltrates can also happen. So, Vamshi, pulmonary infiltrates can happen in Carter-Jenner because Carter-Jenner leads to bronchiectasis. So, bronchiectasis can cause pulmonary infiltrates as well. Chalo, theek hai. Now, I think a question regarding hydrated cyst was asked and a WHO stage was asked. So I teach this in, main videos, revision videos, rapid revision, one-shot revision. Hydrated cyst is a BTR, is a very, very important topic. Is a very, very important topic. Okay. So the answer according to WHO stage is a WHO CE3A. Yes, I think a lot of you would have gotten this question correct. Garby stage पूछा था तो Garby stage is stage 2. ठीक है, Garby stage 2. Now, next question. This is a very, very important question, which I want all of you to tell me what was the question, what was the image like. So, most of the students are saying that the question had history of a 3-year-old, बहुत छोटी बच्ची थी, 3 year, with recurrent respiratory infections. Recurrent respiratory infections, 3-year-old. Okay, what were the options? Tell me what were the options. This image was present, 1, 2, 3. Which image was present, 1, 2, or 3? What kind of image? So in a young child, not an infant, 3-year-old, recurrent respiratory tract infections. Okay, what are you suggesting? One of the DDs can be, an immunodeficiency, which can lead to recurrent RTI. I don't think that was in the options. Another is a congenital pulmonary malformation, CPAM, congenital pulmonary airway malformation. That can be one of the differentials for a recurrent respiratory infection. But tell me whether any plural line was given in the image or not. Any plural line given? Plural line? Okay, so definitely not one. Shashank, so Jagdish is saying definitely not one. GY saying similar to 3, but not exactly. Okay, so tell me whether any plural line was given because congenital lobar. Also, what were the options? Tell me the options. Tell me the options at least. What were the options? X-ray suggested, okay, pneumothorax. Options were pneumothorax, pleural effusion, congenital pulmonary malformation. Okay. So for pneumothorax to happen, you should not see any of these vessels. Some vessels you can see going through this black space. For pneumothorax to happen, this should not happen. Okay. Fever tha. Sharp dense line in right lung. Pleural line was there. No, it looked like pneumothorax. चलो if अगर बच्चे को अगर वेसल प्लूरल लाइन अगर दिख रही थी, if you were able to see plural line, no vessels, then yes, a pneumothorax will be a differential. But it is the answer is very, very much dependent upon what was the exact image. I think with passage of time, when we come up with an exact recall, I think I'll get more clarity on this. What will be the exact recall? But definitely CDH, I don't think will be an answer. Congenital diaphragmatic hernia. CDH, first of all, question what is usually asked is in a neonate. It presents with a neonatal respiratory distress syndrome. ठीक है, so CDH is unlikely. In adults, it presents with causes of pulmonary hypoplasia. ठीक है, तो CDH unlikely, lung abscess, isolated lung abscess, recurrent infection unlikely. ठीक है, if somebody is saying with any fluid filled lesions, whether any air fluid level was present, air fluid level. See, अगर many fluid fill lesions दिख रहे हैं, अगर आपको एक ऐसा CT दिख रहा है जिसमें मल्टीपल ऐसे सिस्टिक एरियाज दिख रहे हैं आपको, was this the CT, multiple cystic areas, and within the cystic areas you could see air fluid levels? Okay, no air fluid level. This is very, very clear for from everybody. No air fluid levels. Ultrasound was also there, was posterior acoustic shadow. So I think mostly, the question is, the answer is between whether a pyonemo or a congenital pulmonary airway malformation. I think we need to get the exact question and the image, only then, I'll be able to tell you the answer. Pyoneumothorax में air fluid level 100% मिलेगा. You will get air fluid levels here. In pyoneumothorax, you will get air fluid level because there is pus and air, right? So that will form an air fluid level. Pyoneumothorax will get an air fluid level. If there was no air fluid levels, most likely the answer is a CPAM. Okay. Now, I think this question has been covered in ENT by Jagdish sir. So there was a CT scan in which a mass was protruding from the left nasal cavity, and the sinus, which most likely was blocked, was asked. So I think this has been covered in the ENT. Maxillary sinus is the most common sinus which was involved. Now, a question already covered by Alekhya ma'am previously. I think history of low back ache and history suggestive of sciatica was asked. And tell me if this was the image which was given in that sciatica patient. Okay, S1 was not the answer. ठीक है, so F1 what? ठीक है, तो इसका आंसर है if the herniation is at the level of L3 L4 disc. If the herniation is at the level of L4 L5 disc, and this is the herniation, then which nerve is involved? It is the L5 nerve. The L5 nerve is involved. ठीक है, traversing nerve root is involved. The traversing nerve root comes out from here. This is the nerve root which is involved L5. L5 is the answer. Chalo, tell me if this was any question related to aortic arch aneurysm. I think I read some of the comments. They were suggesting a question which had come in which the patient had chest pain and hoarseness for 1 month. And what was the diagnosis? What was the question that came? तो रिगार्डिंग द प्रीवियस क्वेश्चन, इट डजेंट मैटर. चलो मान लो अगर यहाँ पे हर्निएशन है, ठीक है, यहाँ पे हर्निएशन बाहर आ रहा है, ठीक है, कौन से 5/4, दिस इज L3, दिस इज L2. तो इन दिस केस कौन सी नर्व रूट इन्वॉल्व होगी? द L3 नर्व विल बी इन्वॉल्व. ठीक है, द लोअर डिस्क level nerve, that is the traversing nerve root, no, that is involved in any disc herniation. Acha, image was given. The students are saying aortic angiography was shown and an image was given. Saccular aneurysm distal to arch of aorta was option tha sir. Acha, so tell me, what was the image like? Was the image like this? इमेज देख लेते हैं कैसी इमेज थी, ऐसी कोई इमेज आई थी क्या? Any image like this? Okay, coronal image was given. Coronal नहीं है, ये वाली तो sagittal image है. Coronal image was given. Anything like this? चलो ठीक है. Basically, in between dissection and saccular aneurysm, how will you differentiate? For a dissection to happen, you know, dissection can also lead to saccular aneurysmal dilatation. But the hallmark of a dissection is a intimal flap. If you know an intimal flap was present, how does an intimal flap looks like? Now, this is how an intimal flap looks like. Okay, intimal flap has a straight line within the lumen. That is the true lumen and false lumen ka differentiation. Na? So if you were seeing an intimal flap, then the answer is dissection. If no intimal flap, then the answer is saccular aneurysm. ठीक है, चलो next question. I am almost done with this paper 1 radiology recall. So there were few questions which came from imaged radiology images related to JNA, which has been already covered by Jagdish sir. Stenver's view cochlear implant ka part पूछा गया था, that has also been covered by Jagdish sir. So 3-year-old child का ये वाला हमारा question रह गया है कि pyoneumothorax है कि CPAM है. Now, tell me any question regarding cerebral toxoplasmosis was asked in radiology. Any image which was asked or only clinical triad was asked? You know, chorioretinitis, hydrocephalus, and cerebral calcification. Any question? Image-based question on cerebral toxoplasma or only clinical base? Chalo, theek hai, no image. I think only it was a clinical question regarding the triad of cerebral toxoplasma. So that is all from radiology side. We'll move on to the next faculty. Thank you, ma'am. Over to you, Ira ma'am.
So how was psychiatry for everybody? Kaisa raha psychiatry? I have managed to get only 2 or 3 questions. So I'd love to hear from you if there were any that I have missed. Off the top, obviously, we keep saying addiction, substance is very, very important. Sometimes it's alcohol, sometimes this time it was opioid, correct? So it changes, but addiction or substance remains important, correct? Another thing is obviously psychopharmacology. These are 2 things when people ask कि क्या कुछ 2-3 टॉपिक हैं मैम जो मैं जरूर पढ़ लूं if I haven't studied anything in psychiatry. These 2 are literally the topics that we always say. Read substance, read psychopharmac. What were the 2-3 questions that you saw? And please comments में डालिएगा because मुझे मिले हैं, but I'd definitely like to double check with you all. And there was another question that as per the recall, of course, it'll improve with time, but I think somatic symptoms से related था, if I'm not wrong. Okay, so let's dig in. तो पहला question था about ADHD medication. And if the question was particularly framed around SNRI used in ADHD, was that right? Was the question which SNRI is used in ADHD? Now, obviously, methylphenidate is the drug of choice. It is a stimulant and it is the drug of choice. But अगर ये option नहीं था, now अब आपके पास आ गया modafinil और reboxetine के बीच में option. Now, remember, atomoxetine, if you have read, is a non-stimulant SNRI. So even if you went by the logic moxetine, then reboxetine is the right answer. Did you mark reboxetine? Because modafinil is not the right answer. Modafinil is actually used in narcolepsy. And it definitely is not a stimulant or it is not an SNRI, sorry. Now, even when it comes to reboxetine, actually it is not FDA approved. It is not FDA approved for ADHD. but we use it sometimes for depression, for ADHD. So yes, the answer was reboxetine. Okay, I'm glad a lot of you got it right. Great, that's good to know. Okay, next, there was a question on opioid drug, and the question was framed around methylphenidate was also there, but the question was around SNRI, right? So the SNRI had to be reboxetine. Now, opioid drug, which is used for maintenance for abstinence. Was this question there? Please give me a thumbs up first. ये question था क्या? Was it there? Disulfiram and buprenorphine being the two main options which were there. Now, disulfiram, as you know, very, very much is for alcohol abstinence के लिए use होता है, right? Okay. So, what were the other options? I know buprenorphine आप लोगों को काफी सारे लोगों को पता है. This is the right answer. And this is good that you knew the answer. Naltrexone, naloxone कुछ था. अच्छा, clonidine भी था. Right. But this is for maintenance for abstinence. Clonidine अगर था, it is used in detoxification. It is used during the period of detoxification, not for abstinence. Okay. So clonidine was an option. So paper 1 में evening में कुछ और था. अच्छा, similar topic पे, excellent. So you can see addiction is such an important topic, right, guys? कभी नहीं छोड़ना है. Substance अच्छे से चाट के जाना है कि ये you should know like the back of your hand. So everybody got this right. I'm so happy. Psychiatry आपने कितना बहुत सही से manage किया है. So definitely buprenorphine is the right answer here. क्या ट्रांसवेस्टिज्म पे कोई क्वेश्चन था? सॉरी मुझे रिकॉल में अच्छे से नहीं समझ आ रहा है कि ट्रांसवेस्टिज्म पे क्वेश्चन था क्या? Was it there or was it not there? If it wasn't there, then I'll move on to the next question that I have. If it is there, then please drop it and I'll definitely like to take it up. क्या क्वेश्चन था इसके ऊपर बताइए प्लीज. What was the question on transvestism? I only have the topic. मेरे रिकॉल में नहीं, मुझको नहीं से मिल पाया. Anybody who can help me with the question? Yes, it was in first paper. Yes, we are doing paper 1, guys. हम सिर्फ paper 1 की ही बात कर रहे हैं फिलहाल. So, a question on somatoform disorder. We are coming to it. Transvestism, fetishism, option था, question था. Dr. Naveen Sharma, क्या था? आप recall करिए तब तक मैं आगे बढ़ती हूँ. And we'll come back. Boy wearing bra. Okay, that was the person gets sexual pleasure wearing female heels in clothes. अच्छा. Person wearing heels and female clothes, sexual pleasure. अगर ये question था, a man gets gratification by wearing female lingerie. Yes. Transvestic fetishism. Fetishism इसलिए है because fetishism means to have sexual pleasure from things which are not normally considered normal. And transvestism because it's almost like a vest that you put on and take off. Dress also. ठीक है. Thank you for that recall, guys. एक और question था. ये question मेरे लिए please complete करिए. Female is nervous and has heartburn since 20 years. क्या 20 years था? Was it that long? 20 years. And the family members are also tensed and nervous. What else can be seen? Now, obviously, it's a very somatic presentation. You can see that somatic presentation दे रहा है patient, right? You already, I think somatoform presentation थी. कहाँ? PDF मिलेगा आपको बाद में. You will definitely, and you can watch the video as well. Now, जो somatoform presentation होती हैं, these are usually vague physical symptoms. Okay. With family history of generalized anxiety disorder. Extremity tingling is the most common. Yes, extremity tingle. That you're right, Dr. Ranbir. Is the most common right answer, not hallucination, not neologisms. Because this could be the another presentation that could be present along with heartburn, nervousness, idea of reference. Acha, third last option tha idea of reference. नहीं, बाकी सारे psychotic symptoms हैं. Neologism, hallucination. And ideas of reference, while it's not psychosis, but it's a thought disorder. But here it is extreme tingling, a physical symptom. So, मेरे हिसाब से यही था psych paper 1 में. Anybody who can share any other questions which I may have not covered? One option through implant. क्या था implant पे? बताइए please question. Because as per me, definitely we've already talked about substance. Psychopharmacology किया, somatic किया. She feels family members are tensed. And 25 was her age. Acha, okay. But yeah, the tingling is the most appropriate answer. The other option was idea of reference. No, please, that was wrong. I hope आपने नहीं mark किया होगा. Tingling extremities is the right answer. All right. Any other question जो मेरे recall में नहीं हुआ? Of course, our recall will improve and paper 2 का हम करने वाले हैं कल. Please, we'll definitely bring the other questions from the second paper. But फिलहाल paper 1 के लिए, this was only for paper 1. Anything else that I missed in psychiatry? Not understanding meaning of 2 words. अब आप question को बढ़ा रहे हैं. Was it not understanding meaning of 2 words and फिर tingling extremity तो नहीं सही बनेगा. What? IUDs timings. Less than 48 hours, IUDs used? No. मेरे को ये रिकॉल में मैं फिर से इम्प्रूव करके आपको दूंगी ये क्वेश्चन once I get it. Linguistic barrier, idea of reference. Another question was dhatura poisoning. So again, you can see pharmac and psychiatry में बहुत overlap होता है, right? धतूरा से related होता है. There's also questions from like, you know, opioid पे भी question आ गया. So definitely pharmac में भी इनमें से कुछ cover किए जाएंगे. But that's it in the recall in psychiatry from my side. These were the 3 or 4, sorry, main things that came. So you can see very much what we covered in all of our classes. Sexual disorders, very important. Somatic, substance, all are very, very important. Okay. All right. Slit lamp wala ophthalm mein madam lengi, definitely. Thank you. Thank you so much. Over to the next. Thank you. We'll improve and we'll get back.
You are live, you can start.
Hi everyone, good evening. So I heard paper 1 microbiology section was pretty easy and doable. कुछ ऐसा touchwood आज bouncer नहीं आया है. And many PYQs and PYTs I should say were repeated. So let's start quickly. So पहला question इस तरह से है. A farmer presented with fever, retroorbital pain, painful joints, jaundice, splenomegaly, calf tenderness and conjunctival suffusion. What can be the likely infection? अब this is on leptospirosis, ये पढ़ना ही होता है. And I have highlighted calf tenderness. I'm not sure whether this was mentioned in आज का paper or not. Good evening, Titan. And a humble request to all of you. This very session is just to take help from you to be able to recall the questions and the options. A detailed recall will be put up later on. And tomorrow we are going to discuss paper 2. So guys, please correct me if I'm wrong. यही question था इसमें. Have I missed something? Answer इसका straightforward leptospirosis है. और calf tenderness अगर नहीं भी लिखा हो ना यहाँ पे let me point out. NEET PG 2019 में भी ये आया था question leptospirosis पे. ठीक है. और उसमें see this is straight from Harrison's textbook of infectious diseases. Calf tenderness हो सकती है leptospirosis में, not a very common symptom though. ठीक है. So why am I emphasizing upon this is because उस question में again dengue एक option था जो कई लोग गलत करके आ गए थे. ठीक है. तो leptospirosis is the most common zoonotic disease on mother earth. ये तो पढ़ के जाना ही जाना है. ठीक है. तो इसमें कोई दो राय नहीं है. दिस इज अ प्रीटी सिंपल क्वेश्चन. आंसर इसका लेप्टोस्पायरोसिस है. ठीक है. अच्छा, ये दिस वाज नॉट मेंशन्ड राइट और मेंशन्ड? ओके सो दिस वाज मेंशन्ड. ठीक है. Okay, thank you everyone. Moving on. A patient ended up with the aplastic crisis following a viral infection. What is the likely virus? I could not gather the options, and the answer I was told by the students, ये straightforward parvovirus पे ही question था. aplastic crisis दे रखा है. Again देखो parvovirus as a topic पढ़ना ही होता है, बहुत इंपॉर्टेंट है और छोटा सा ही वायरस है, इसमें ज्यादा ओवरऑल ऑल्सो इट्स द स्मॉलेस्ट वायरस, तो ज्यादा इन्फॉर्मेशन इसकी है भी नहीं, तो बहुत छोटी सी इसकी थ्योरी है. लास्ट टाइम आई रिमेम्बर इसके रैश पे क्वेश्चन आया था, है ना. अच्छा, जॉन्डिस वाज नॉट देयर. ओके ओके, थैंक यू. चलो इसमें कैन यू गाइस प्लीज रिकॉल द अदर ऑप्शंस इन दिस क्वेश्चन पार्वोवायरस वाला में. ओके, थैंक यू सो मच जीवा. CMV, Epstein-Barr virus and yellow fever virus. Yes, Dr. Medico Plus, I'll quickly take a screenshot, but I will discuss it tomorrow because the faculties are also waiting after me. तो हम session 2 के आप यहाँ पे mention कर दो ताकि आप बाद में भूल ना जाओ. I'll quickly take a screenshot. ठीक है? Okay guys, so we have got the options and parvovirus जैसे मैंने बोला काफी important है. Next question. A patient presented with features of meningitis and a rash on the body. He hails from military background. What can be the likely cause? Again, इसमें मैंने बार बार पूछा, so everybody could recall, meningococcus only. होता ही है ना कि जब हमें पता होता है कि किसी क्वेश्चन का यही आंसर है, तो बाकी ऑप्शंस वैसे भी एक यूजुअली याद नहीं आते हैं. So I think that is probably the reason why the options were not recalled. If anyone by any chance is able to recall the options in this question, please help me out. तो आंसर इसका भी मेनिंगोकोकस था. मेनिंजाइटिस दे रखा है, रैश दे रखा है, मिलिट्री बैकग्राउंड. यू ऑल नो मेनिंगोकोकस का रेजिडेंस कहाँ पे होता है? ह्यूमन नेजोफैरिंग्स. इट्स अ स्ट्रिक्ट या ऑब्लिगेट ह्यूमन पैरासाइट. ठीक है, रेस्पिरेटरी रूट से ये ट्रांसमिट होता है. वी ओनली, आई मीन ह्यूमंस आर देमसेल्व्स द केसेस एज वेल एज द कैरियर्स. कोई एनिमल रिजर्वोयर भी नहीं है. अच्छा, ग्राम नेगेटिव डिप्लोकोकस मेंशन्ड. इसका मतलब उन्होंने आपको ग्राम स्टेन्ड फाइंडिंग्स भी दी थी क्वेश्चन में, राइट? Nujat, are these the options in this question, Klebsiella and CMV? Okay, so I will modify later on this question stating कि भाई gram stain findings also were mentioned, right? Correct me if I'm wrong. Okay, thank you Jiva, noted. True false भी आए थे आज. Which one are you saying कि true false वाला question था Aborti? Yes, there was some question on Haemophilus, but I could not get the question. Haemophilus, are you saying इसमें option था क्या? Option D, shall I mention Haemophilus? तो जो pending options हैं Klebsiella, CMV, Haemophilus. Is it? Okay, thank you Shraddha. चलो अगर word gram stain mention नहीं भी दिया है, maybe they just commented कि mentioned in the question कि gram negative diplodocus था. Okay, somebody saying E. coli also as one of the options. Chalo, nevertheless, okay, this was there. Haemophilus was mentioned in the options. Okay, guys. तो ये पता ही है कि मेनिंजाइटिस के कॉजेटिव ऑर्गेनिजम्स आपको पता होने चाहिए. प्रोफाइल ऑफ मेनिंजाइटिस इन पायोजेनिक मेनिंजाइटिस, एसेप्टिक मेनिंजाइटिस, टीबी मेनिंजाइटिस, तो ये बहुत कॉमन क्वेश्चन है. ठीक है, सो ये काफी एक्सपेक्टेड था. आगे बढ़ते हैं. A sexually active female presented with an abnormal vaginal discharge. अब इसका I was told कि आंसर trichomoniasis था, and I asked a leading question to the students also कि color of discharge was mentioned or not, and I was told by few students that color was not mentioned, and ये question मेरे हिसाब से obviously अभी incomplete है. If you can please help me complete this question. आंसर इसका मुझे बोला गया है कि ट्राइकोमोनियासिस ही था, तो इसका मतलब कुछ बात क्वेश्चन में ऐसी है जो यहाँ पे नहीं लिखी हुई है. व्हाट वाज दैट क्लिंचर मेंशन्ड इन द क्वेश्चन व्हिच पॉइंटेड आउट टुवर्ड्स ट्राइकोमोनियासिस? ओके, pelvic pain and dysuria mentioned. Clue cells, so that would point towards bacterial vaginosis. Are you sure clue cells were mentioned in this question only? Clue cells were seen. Image of clue cells. Okay, no color but foul smelling word was mentioned. या इवन आई फील कि ये ना फ्लू सेल वाला आई थिंक किसी इसमें शायद नहीं मेंशन था, अगर बार बार इसका आंसर ट्राइकोमोनियासिस हर कोई कह रहा था. ओके ओके, सो abnormal foul smelling vaginal discharge, pelvic pain, dysuria was there. What else was mentioned in the question? Pradyot, could you please recall anything else in the question? Hamid, are you sure वो इसी क्वेश्चन की आप बात कर रहे हो? MNGs. Okay, one option was HPV. मुझे लगता है इसी in all the regarding all these topics, bacterial vaginosis, trichomoniasis etc. मुझे ऐसे लग रहा है आपके सबके कमेंट्स पढ़ के कि शायद 3-4 इस तरह के थे क्वेश्चंस और फिर अभी सब कुछ खिचड़ी ही पक रही है. ओके, हम्बल रिक्वेस्ट, अगर ऐसा कुछ आपको याद आता है ना, यू कैन प्लीज DM मी ऑन माय इंस्टा हैंडल mj.micro, और यू कैन इवन कमेंट इन द कमेंट सेक्शन ऑन दिस वीडियो. आई चेक द कमेंट्स आल्सो लेटर ऑन. नो HSV का क्वेश्चन आगे है, बोली नैनी यामिनी चौधरी. ठीक है, वो एक अलग क्वेश्चन था. Okay guys, I think I'll have to dive deep into this question maybe from more places. आगे बढ़ते हैं. What is the function of interleukin 8? अब देखो इम्यूनोलॉजी से ये आ गया. हमेशा ऑलवेज एम्फसाइज की साइटोकाइंस तो पढ़ के जाने ही होते हैं और सिंपल हैं, कोई ऐसा बाउंसर नहीं है, मुश्किल भी नहीं है. दो ऑप्शंस मुझे मिले, न्यूट्रोफिल रिक्रूटमेंट, एंडोथेलियल सेल एक्टिवेशन. न्यूट्रोफिल रिक्रूटमेंट स्ट्रेट अवे इज द आंसर. ओके, डिसयूरिया, क्वेरी, सर्वाइकल इरोजन्स. Any other options can you please recall in this question, interleukin 8 वाले में? Okay, fourth option is HSV. We are on this question now. Acha, macrophage activation also was mentioned. Okay, Hamid, if it was trichomoniasis वाला image based, तो क्या image दे रखी थी? Please share the image with me later on अगर आपको मिलती है closest image from the Google. ठीक है, तो इसका आंसर न्यूट्रोफिल रिक्रूटमेंट है. नेक्स्ट क्वेश्चन, अब एक बैट की इमेज थी एंड आई वाज टोल्ड कि यही एग्जैक्ट इमेज आई थी, और एक फिर बैट सुन के मुझे तो निपा वायरस ही ध्यान आया और ऑप्शंस वर नॉट रिकॉल्ड. निपा वायरस का अभी जैसे रिसेंटली अनफॉर्चुनेटली एक डेथ भी हो गई थी केरला में. केस वाज रिपोर्टेड इन जुलाई, अ टीनेजर डाइड. You all know fruit bats are the reservoirs of this virus, Nipah and Hendra viruses. They are zoonotic paramyxoviruses. ठीक है, और कोई और ऑप्शंस याद है इसके? And I was just told कि image दे रखी थी. Probably the question was कि अच्छा what is this bat is the reservoir of which virus? इस तरह से पूछा था. Okay, other options: Ebola, dengue, malaria. Question क्या था? How is bat is related to which of these viruses? इस तरह का question. Pro-democracy. A student only had shared this image when I requested the student to share the closest image from Google. Okay, so this was the exactly image Sameer is mentioning. चलो ठीक है, आगे बढ़ते हैं. फंगस कॉजिंग डेजर्ट रूमेटिज्म, तो इसमें आई थिंक ये 3 ऑप्शंस तो थे ही थे. कॉक्सीडियोइडिस इमिडिस व्हिच बाय द वे इज द आंसर. पैराकॉक्सीडियोइड्स था, हिस्टोप्लाज्मा था. लास्ट ऑप्शन वाज नॉट रिकॉल्ड. ठीक है, यही क्वेश्चन था जो फंगस कॉजिंग डेजर्ट रूमेटिज्म पे आया है. क्या ये स्ट्रेट फॉरवर्ड क्वेश्चन था या कुछ हिस्ट्री दे रखी थी? अच्छा, पहले वाले क्वेश्चन में साउथ एशिया की हिस्ट्री, कोई क्लिनिकल सिनेरियो था एनकेफेलाइटिस. चलो अगर क्लिनिकल सिनेरियो था भी सही तो और अच्छी बात है ना. जो स्ट्रेट फॉरवर्ड क्वेश्चंस होते हैं उनसे बेटर मैं मानती हूँ क्लिनिकल क्वेश्चंस रहते हैं, बिकॉज उसमें आपको हिंट दे रखे होते हैं. अच्छा, इन्फेक्टिव आर्थ्रोस्पोर्स. ओके, ब्लास्टोमाइसिस वाज द लास्ट ऑप्शन. थैंक यू सो मच. हमीद, you can please DM me on my Insta handle. mj.micro is my Insta handle. आप मुझे please DM कर दीजिएगा whenever you have time. रोजा, infective arthrospores question में mention कर रखा था कि which of these fungi has got infective forms as arthrospores and causes desert rheumatism, इस प्रकार से कुछ दे रखा था. Okay, Yamini is mentioning it was straightforward. तो चलो, I think I am assuming कि भाई ये दोनों चीजें क्वेश्चन में मेंशन थी, तो इस प्रकार से straightforward मानेंगे इसे. ठीक है. Okay, thank you so much, Akash. Meningitis का case, it was asked which PCR is the best for it. Options, if you can please recall. I'll add that question later on. आगे बढ़ते हैं. A patient presented with perianal. अच्छा, मुझे पूछना था ये पेरीएनल इचिंग, मुझे बाद में किसी स्टूडेंट ने बोला पेरीएनल इचिंग मेंशन था भी या नहीं. इतना तो पक्का है कि ये इमेज आई थी, एग की इमेज थी, और ये स्ट्रेट फॉरवर्ड एंटेरोबियस वर्मिकुलरिस विच इज अ लार्ज इंटेस्टाइनल नेमेटोड का एग है. और देखो वही एग्स की इमेजेस कितनी ज्यादा इंपॉर्टेंट है इसमें, और क्या ही घुमा फिर आगे पूछेंगे, तो एग्स की इमेजेस तो आनी ही आनी चाहिए. ओके, वन ऑप्शन वाज एच नाना. अच्छा, मेंशन. ओके, थैंक यू सो मच. ओके, वन ऑप्शन वाज एंकाइलोस्टोमा डुओडेनल. ठीक है, एक कोई और लास्ट ऑप्शन बचा है. पेरिनेल इचिंग 3 टाइम्स. ठीक है, बच्चा था एडल्ट था कुछ मेंशन है, क्योंकि ये वाला जो इन्फेक्शन होता है एंटेरोबियस वर्मिकुलरिस यूजुअली बच्चों में होता है, और इसके बारे में कहावत भी बुक्स में लिख रखी है कि यू आर इन्फेक्टेड एज अ चाइल्ड, यू विल बी इन्फेक्टेड व्हेन यू बिकम एडल्ट एंड योर चिल्ड्रन विल आल्सो गेट द इन्फेक्शन, क्योंकि ऑटो इन्फेक्शन इज वेरी कॉमन इन दिस पैरासाइट. ठीक है, ऑटो इन्फेक्शन कराने वाले पैरासाइट्स के नाम भी पता होने चाहिए. अच्छा, चाइल्ड, अब पेशेंट की जगह चलो चाइल्ड कर देते हैं. एक्सपेक्टेड. ओके, नेगेटर अमेरिकानस वाज देयर. ओके, सो थैंक यू सो मच. तो चलो, एक ये क्वेश्चन बढ़िया से रिकॉल हो गया, इसमें यही सब पूछा था और ऑप्शंस भी इसके आ गए हमारे पास. अच्छा, ये भी मेंशन था जीवा, वाइट थ्रेड लाइक थिंग्स वर सीन ऑन स्टूल एग्जामिनेशन, क्योंकि स्टूल्स में एग तो दिखेंगे नहीं, वो तो पेरियनल रीजन में होते हैं. The parasites are pretty small and they could be attached to the diapers of the kids or the clothes or sometimes in feces. Okay, white thread like structures on stool. स्मार्ट कनपी, इसी क्वेश्चन में आप कह रहे हो कि पिनवर्म की इमेज भी थी. एंटेरोबियस इज ऑल्सो नोन एज पिनवर्म और सीटवर्म और थ्रेडवर्म. ठीक है, PEST पेस्ट से याद करो, P से पिनवर्म, E से एंटेरोबियस, S से सीटवर्म, T से थ्रेडवर्म. और फीमेल चाइल्ड. ओके ओके ओके, आगे बढ़ते हैं. थैंक यू सो मच. A guy who was working outside started eating non-home food for the past week, started to develop abdominal pain and developed spots on his trunk along with relapsing fever. ठीक है, ये स्टार मार्क मैंने इसलिए कर दिया कि आई वॉज नॉट श्योर कि वेदर यही शब्द फीवर के विवरण के लिए मेंशन थे या नहीं थे. व्हाट इज द नेक्स्ट स्टेप इन मैनेजमेंट? ये क्या लग रहा है? बाहर से इसने बाहर का खाना खाना शुरू किया, पेट में दर्द, स्पॉट्स ऑन द ट्रंक. ठीक है, आई थिंक द पैटर्न ऑफ द फीवर वॉज रेमिटिंग. तो ये है तो टाइफॉइड. ठीक है, अब ये पेशेंट बुखार के साथ आया है, तो विडाल तो बहुत नॉन स्पेसिफिक एंड नॉट इवन रिकमेंडेड बाय WHO दीस डेज. तो यू ऑल नो द गोल्ड स्टैंडर्ड फॉर डायग्नोसिस ऑफ टाइफॉइड. द नेक्स्ट स्टेप क्या होना चाहिए? ब्लड कल्चर करना चाहिए, बिकॉज व्हाई इट इज गोल्ड स्टैंडर्ड? क्योंकि इट हैज गॉट 100% स्पेसिफिसिटी. द सेंसिटिविटी वेरीज विद द ड्यूरेशन ऑफ फीवर. ठीक है, तो चलो, रिलैप्सिंग नहीं था ना, मुझे भी ऐसे लगा, बट आई थिंक द स्टूडेंट हु हैड शेयर्ड दिस मेंशनड रिलैप्सिंग, सो दैट इज व्हाई मैंने इसको मार्क कर लिया था. ओके, 4th डे ऑफ फीवर, तो ऑब्वियसली फर्स्ट वीक ऑफ फीवर में तो वैसे ही ब्लड कल्चर ही करते हैं ना, क्योंकि 90% सेंसिटिविटी होती है ब्लड कल्चर की फर्स्ट वीक ऑफ फीवर में, फिर वो डिक्लाइन करती जाती है एज द फीवर प्रोग्रेसेस. ओके, फैंटास्टिक. तो चलो, ये भी लगभग हमारा ढंग से रिकॉल हो गया. ठीक है, आगे बढ़ते हैं. एक क्वेश्चन आया था, अब ये दिस इज अ पुअरली रिकॉल्ड क्वेश्चन. क्वेश्चन आया था, आई वाज टोल्ड कि बायोफिल्म पे था ये क्वेश्चन, एंड द पेशेंट हैड सम प्रोस्थेटिक डिवाइस इन प्लेस, probably a catheter, I don't know, and the proper treatment was asked. See, ये मैंने जो भी मुझे वर्ड्स स्टूडेंट्स ने बताए हैं, मैंने वही वर्ड्स यूज करे हैं, अपनी तरफ से कुछ नहीं है. प्लीज हेल्प मी आउट विद दिस क्वेश्चन. अगर प्रॉपर ट्रीटमेंट पूछा है तो आई वाज टोल्ड कि एक ऑप्शन ऐसे था कि डिवाइस को ही रिमूव कर दोगे, तो बेसिकली प्रॉब्लम की जड़ को मतलब रूट से ही निकाल दो. तो यहाँ पे आपको पता ही है कि अगर ये बायोफिल्म बनती कैसे है प्रोस्थेटिक डिवाइसेस पे, वन नोटोरियस ऑर्गेनिज्म इज स्टेफाइलोकोकस एपिडर्मिडिस, ठीक है. The biofilm is nothing but polysaccharide material in which the organism becomes enmeshed, multiplies, and इतना sticky होता है ये, so that it becomes impenetrable by antibodies, antibiotics, etc. तभी these infections are much difficult to treat. नोवोबाइसिन वाला क्वेश्चन रीमा अभी आगे आएगा, वो मैंने डाला हुआ है. Okay, thank you so much. Bradycardia, yes, I forgot to add it. Even I was told later on कि bradycardia was mentioned. टाइफॉइड वाले क्वेश्चन में, ठीक है. Lovish, yes, soon the new batch for first year MBBS students is going to commence. You will get details shortly. ठीक है. I am not sure whether the few classes, initial classes will be there on YouTube or not, but don't worry, you will be notified. Keep following PW for the notifications. अच्छा, इस क्वेश्चन पे जरा फोकस करते हैं जो अभी आपकी स्क्रीन पे है. इसमें कैन यू प्लीज टेल मी क्या क्या मेंशन था? ये ऑप्शंस बता दो प्लीज, इफ यू कैन रिकॉल. एपिडर्मिडिस था मेंशन क्या? ये पेशेंट वाज ऑन टीपीएन, वाज दिस मेंशन? प्रद्युत, विच ऑप्शन? अच्छा, so patient was on TPN. Staphylococcus epidermidis found in multiple samples. Okay, one option was biofilm antibiotic penetration bad, hence removal need to be done. Okay, this is what I just said. Works best because देखो दूसरा ऑप्शन जो आप हमीद ने मेंशन किया है चैट बॉक्स में, वो तो ऑब्वियसली नहीं है. बायोफिल्म एंटीबायोटिक वर्क्स बेस्ट, बिल्कुल ही उल्टा. तो व्हाट आई जस्ट सेड कि ये स्लाइमी मटेरियल होता है पॉलीसैकेराइड व्हिच इज इम्पेनेट्रेबल बाय एंटीबायोटिक्स वगैरह वगैरह. सो दैट इज व्हाई दीस इन्फेक्शंस आर सो डिफिकल्ट टू ट्रीट. चलो कोई नहीं, कम से कम दो ऑप्शंस तो हमारे ध्यान में आ गए. सो आई हैव टेकन अ स्क्रीनशॉट, आई विल ऐड इट लेटर. अच्छा ललित, फ्लेबाइटिस रिलेटेड आप इसी क्वेश्चन के बारे में कह रहे हो? कॉम्प्लेक्स माइक्रोस्ट्रक्चर, ओके. सो बेसिकली अगर तो क्वेश्चन में चाहे कुछ भी लिखा हो, कम से कम इतनी इन्फॉर्मेशन है कि पेशेंट टीपीएन पे था और स्टैफ एपिडर्मिडिस वाज आइडेंटिफाइड, ठीक है, और बायोफिल्म फॉर्म हो गई थी, तो बेस्ट ट्रीटमेंट इज रिमूवल ऑफ बायोफिल्म. और आपको पता ही है कि द बेस्ट ट्रीटमेंट जो है रिमूवल ऑफ डिवाइस है. अदरवाइज एंटीबायोटिक्स दोगे तो कोई नई एंटीबायोटिक्स तो आ नहीं जाएंगी, वही एंटीबायोटिक्स को लंबे ड्यूरेशन के लिए देना पड़ता है. बट अगेन द बेस्ट ट्रीटमेंट एट द एंड ऑफ द डे इज प्रॉब्लम को हटा ही दो, मतलब डिवाइस को ही हटा दो. बट ऑब्वियसली इट इज नॉट feasible all the times because आप prosthetic heart valves को remove नहीं कर पाओगे. That is why these kind of infections which are characterized by biofilm formation are such a nuisance for clinicians. Okay, आगे बढ़ते हैं. Okay, pro democracy TPN was different question. चलो, I've taken a screenshot. I will analyze these questions later on, hopefully from more students के input से. चलो आगे बढ़ते हैं. A patient presented with burning micturition. Urine culture revealed an isolate which was coagulase negative and novobicin resistant. Was this the language of the question? Please correct me if I'm wrong. What can it be? अगर तो भाई ऐसे लिखा था coagulase negative novobicin resistant, तो सीधा सीधा क्या हो जाता है? Staph saprophyticus. Okay, I think the undisputed view मुझे लग रहा है TPN उसमें मेंशन नहीं था पहले वाले क्वेश्चन में ना, तो I'll just remove it. ठीक है, चलो टीपीएन वाला कुछ सेपरेट क्वेश्चन था. ओके, दिस क्वेश्चन गाइस, प्लीज हेल्प मी आउट विद दिस. यही मेंशन था क्वेश्चन में कोएगुलेज नेगेटिव और नोवोबाइसिन रेजिस्टेंट. कोएगुलेज नेगेटिव स्टैफ को कैसे क्लासिफाई करते हो? कोएगुलेज पॉजिटिव जिसमें एक ही पढ़ना होता है डिटेल में, स्टैफ ऑरियस, ए फॉर नंबर वन पैथोजन. कोएगुलेज नेगेटिव में आते हैं इंपॉर्टेंट वंस, एपिडर्मिडिस जिसके बारे में एक क्वेश्चन आ गया. तो दूसरा क्वेश्चन इस पे आ गया सैप्रोफिटिकस पे, ठीक है, जो कि यूटीआई कॉज करता है. अच्छा, दिस आई रियली वांट टू नो यामिनी. जो ये 10⁴ कॉलोनी फॉर्मिंग यूनिट्स मैं भी आज देख रही हूँ कई सारे ग्रुप्स पर भी, ये इसी क्वेश्चन में था या कोई सेपरेट क्वेश्चन आया इसके ऊपर? ऑर्गेनिज्म वाज नॉट आस्क्ड इन दिस क्वेश्चन एट ऑल। फिर पूछा क्या था? ओके, थैंक यू प्लूरीपोटेंट फॉर द बायोफिल्म क्वेश्चन वाला ऑप्शन। ओके, डिसयूरिया, चलो ये तो लिख लिया। बर्निंग मिक्चरेशन हो गया। फीवर, सो क्वेश्चन था वेदर यूटीआई और नॉट। तो इसका मतलब जो काउंट उन्होंने दिया होगा वो क्वेश्चन में दिया होगा ना। Is this the value given was this the value given for the colony forming units 10⁴ colony forming units per ml? Anything else? Always remember, always symptomatic significant bacteriuria should be treated. अगर तो क्वेश्चन में ऐसी कोई हिस्ट्री नहीं दे रखी है कि पेशेंट एंटीबायोटिक्स ले रहा था या कोई और रीजन है जिसकी वजह से काउंट कम आ सकता है, कैस कॉन्सेप्ट ऑफ सिग्निफिकेंट बैक्टीरिया आप सबको पता है, मोर देन और इक्वल टू 10⁵ कॉलोनी फॉर्मिंग यूनिट्स पर ml इज सेड टू बी सिग्निफिकेंट बैक्टीरिया। लेकिन यहाँ पे काउंट कम है, ठीक है, तो रीटेस्ट करेंगे। अगर तो रीटेस्ट दे रखा है, अभी डायरेक्टली इसका ट्रीटमेंट नहीं कमेंस करेंगे। There are only 3 exceptions where, asymptomatic significant bacteriuria should be treated. Asymptomatic significant bacteriuria should be treated in cases of PUN, pregnancy, urinary tract obstruction because of calculi, that is stones या फिर urinary tract का tumor and neutropenia, है ना। तो अगर यही मेंशन था, इतना ही कि पेशेंट के पास यूटीआई के फीचर्स तो हैं, कॉलोनी काउंट कम है, लेकिन कुछ प्रीडिस्पोजिंग फैक्टर ऐसा नहीं मेंशन था क्वेश्चन में, जैसे कि वो एंटीबायोटिक्स ले रहा था या कोई और चीज, देन रिपीट सैंपल। 3 consecutive samples was ये जो आप कह रहे हो ये क्वेश्चन की स्टेम में था, और was this one of the options? Okay, it was one of the options. एंड आर यू श्योर ये नोवोबाइसिन, ये कोएगुलेस नेगेटिव चीज की हम बात कर रहे हैं, ये यही क्वेश्चन था या ये इसके ऊपर सेपरेट क्वेश्चन था? हाउ मेनी क्वेश्चंस ऑन यूटीआई वर देयर टुडे? आर वी मिक्सिंग द 2 questions or we are talking about the same question? Simple drawings, okay. So you're saying we are discussing the same question, na? Okay. ओके, इसको भी जरा ढंग से देखना पड़ेगा, रिकॉल मतलब और अगर कुछ और मेंशन था, एनीथिंग एल्स वी आर मिसिंग इन दिस क्वेश्चन, सो प्लीज लेट मी नो। आगे बढ़ते हैं। कानागावा फिनोमिनन इज सीन इन, अब ये डायरेक्ट क्वेश्चन था इसी तरह से या कुछ और था, और इसके ऑप्शन इफ यू कैन प्लीज रिकॉल। आंसर तो इसका विब्रियो पैराहीमोलाइटिकस है और हैलोफिलिक विब्रियो। कानागावा फिनोमिनन क्या होता है? एक ब्लड अगार होता है स्पेशल टाइप का, स्पेशल उसमें ये होता है कि इट इज मेड यूजिंग ह्यूमन ब्लड। तो विब्रियो पैराहीमोलाइटिकस के वो वाले स्ट्रेन्स जो हीमोलाइसिस कर लेंगे इस तरह के ब्लड अगार पर, उसे वागड़सुमा अगार कहते हैं। Those strains which are beta hemolytic on this agar, वागड़सुमा agar, they are said to be pathogenic for humans. Non-hemolytic strains are non-pathogenic. So non से non याद करो. Non-hemolytic strains are said to be non-pathogenic. That is what is Kanagawa phenomenon all about. Good evening, Ruhi. Okay, thank you so much for your inputs. हम इसका detailed recall करेंगे, ठीक है? अच्छा, इस पे जरा चर्चा कर लेते हैं. और कोई बाकी ऑप्शंस? एनीवन इन दिस क्वेश्चन? यही ऐसे ही पूछा था, ये कानागावा फिनोमिनन इज सीन इन, या कोई क्लिनिकल हिस्ट्री थी? लेजेंडरी ऋत्विक, फिश पॉइजनिंग इसी क्वेश्चन के लिए आप कह रहे हो? So some food item was there क्या? And Vibrio was isolated, या Kanagawa phenomenon is seen in which मतलब this organism shows which phenomenon, ऐसे पूछा था. Okay, so oyster intake की history, hemolysis was present. So basically a clinical question ही आया आज. Vibrio cholerae was given. Parahemolyticus था ही नहीं. इवन विब्रियो कॉलेरे भी कर सकता है बीटा हेमोलाइसिस ऐसे तो, बट आई वाज टोल्ड कि कानागावा स्पेसिफिकली ये वर्ड मेंशन था. ओके, एस टाइफी वाज वन ऑफ द ऑप्शंस. ओके, बोथ वर देयर. तो इसका सीधा सीधा आंसर विब्रियो पैराहेमोलाइटिकस ही है. ओके, थैंक यू समीर. हिस्ट्री ऑफ ऑयस्टर इनटेक विद हेमोलाइसिस एंड कानागावा फेनोमेनन, तो ये सीधा सीधा पैराहेमोलाइटिकस हो गया. कानागावा वाज डेफिनेटली मेंशन्ड, राइट? कानागावा वर्ड था क्वेश्चन में या नहीं था? Please help with this question. Kanagawa was mentioned or not? Some are saying tha, some are saying nahi tha. Tha. Okay. Word was written. I think majority is going with Kanagawa mentioned था. तो चलो इसको हम ले लेते हैं कि था. फिर तो without any debate इसका आंसर पैराहीमोलाइटिकस ही है. ठीक है, चलो आगे बढ़ते हैं. ये भी poorly recalled question है. अब patient presented a patient presented with genital ulcers, and this kind of an image was there, and जेनाइटल अल्सर्स की हिस्ट्री एंड वेसिकुलर लीजन्स की कोई इमेज थी. तो अगर जेनाइटल अल्सर्स और वेसिकुलर लीजन्स मेंशन्ड की इमेज दे रखी है तो स्ट्रेट अवे ये क्या हो जाएगा? HSV2. अच्छा, ऑप्शन में HSV2 की जगह जेनाइटल हर्पीज मेंशन था क्या? ओके, पेनफुल जेनाइटल अल्सर्स की हिस्ट्री, टेंडर विद एलेनपैथी. ओके, सिर्फ HSV भी लिखा हो, HSV2 ना भी लिखा हो तो अंडरस्टूड ही है, तो तभी HSV ही मार्क करेंगे. ओके, वन ऑप्शन वाज शैंक्रॉइड और बाकी ऑप्शन सही है. स्क्रीन पे जो आप देख रहे हो, CMV, शैंक्रॉइड, HPV, HSV. ओके, शैंक्रॉइड था, HSV था. इमेज यही थी जो आप स्क्रीन पे देख रहे हो, कुछ ऐसी ऐसी मिलती जुलती. सो बेसिकली गाइस, ऑप्शंस चाहे कुछ भी रही हो, आंसर इसका HSV है. ठीक है, हिस्ट्री ऑफ पेनफुल जेनाइटल अल्सर्स विद लिम्फेडेनोपैथी और वेसिकुलर लीजन्स की फोटो दे दी, तो क्या डायग्नोसिस बनता है? जेनाइटल हर्पीज. ठीक है, आगे बढ़ते हैं. अच्छा, I think these were the questions which I could gather, and please correct me if I'm wrong. There was one question on SCID today, severe combined immunodeficiency disorder. Yes or no? क्योंकि इसके बारे में बस इतना ही I just happened to see on a group and nothing else was recalled, nothing. So I'm not really sure whether this came today or not. Okay, चलो बहुत बहुत धन्यवाद. यही इमेज आई थी. This image came. ठीक है. Yes, answer is genital herpes, RK. Question on SCID आया था क्या? क्या क्वेश्चन था? इफ एनीवन कैन प्लीज रिकॉल, हेल्प मी रिकॉल. क्या पूछा था इसके ऊपर? व्हाट वर द ऑप्शंस? ओके, समर सिंह आया था, समर सिंह नहीं आया था. लेट मी ऑल्सो एक्सप्लोर मोर ऑन दिस टॉपिक, क्योंकि मुझे भी इसके ऊपर कुछ ज्यादा इन्फॉर्मेशन मिली नहीं है आज के पेपर के बाद, एंड आप लोगों में से कई लोग कह रहे हो कि ये नहीं आया था. तो चलो फिर इसको रहने देते हैं राइट नाउ. एंड let me know if any kind of question with these words was there today. कोई baby born in Maharashtra had a bath in hot water, बस मुझे इतना ही मिला. कोई था ऐसा कुछ क्वेश्चन आज या नहीं? And also probably there was some question on neurocysticercosis. Yes or no? ये था कोई इसी तरह का क्वेश्चन किसी? समीर, पेशेंट केम टू न्यूरो ओपीडी, आप किसके बारे में कह रहे हो? Okay. Okay, then I think it will be covered in pediatrics. ठीक है, और कोई माइक्रो के questions, if anyone can please recall. Maybe not right now. As I said, please, my Insta handle pe you can DM me the questions, and we will be back soon with a detailed recall of today's video. And please tune into this YouTube channel tomorrow for discussion on paper 2. Also, of all the 19 subjects, the timings will be released shortly. Stay tuned on the Instagram handle of PW MedEd. Thank you so much, everyone, for your time. And you all are champions. आज आराम करो, ठीक है? And don't bother about the result right now. Just take a break. Thank you, everyone.
Rajesh, you can start.
Okay, sir. Hello, everyone. So there were total 18 to 20 questions from the Biochem, and this is paper 1, session 1 recall of this 2024. The questions were integrated and previous year topic based. Okay. And these are repeated topics from our ASAP session and revision session on our app, also on the YouTube channel. So we'll quickly revise these questions because my colleagues are waiting there. Also, you are means आप सुबह से लगे हुए हो. सुबह से क्यों? आप एक साल से लगे हुए हो. Marathon race आप दौड़ रहे हो. Now see, this is the virtual thali for you. And this was the question. This is integrated question. We also with the PSM. What is source of vitamin B1? So here answer is it is present in outer alluron layer of cereal. Whole grain is the answer here for the thiamine. And remember, beriberi is there when there is thiamine deficiency, when we consume polished rice as a staple diet. So here answer is B, that is rice and chapati. This is the answer. So this is virtual dinner for all of you. Okay, so just wait. Okay, now moving to the second question. Patient came to emergency room with severe pain in the abdomen. Serum TG level was 1500 milligram per deciliter. Identify the defect. Now this topic, that is Fredrickson classification, that is type 1 and type 2A hyperlipoproteinemia, is gaining too much importance, and repeatedly there is question on this topic. So there is increase in the triglyceride level 1500, and the pain in abdomen, that indicates the risk of pancreatitis or pancreatitis. So whenever there is pancreatitis, increased TG level, so it indicates whenever there is increased TG level and risk of pancreatitis, it indicates the type 1 hyperchylomicronemia. Type 1 hyperchylomicronemia. There is increase in the chylomicron. there is increase in the TG level. So what is defect in the type 1 hyperchylomicronemia? So it is lipoprotein lipase defect or ApoC2 defect. Remember this, it is lipoprotein lipase defect or ApoC2 defect here. So this is type 1. And there is increased risk of pancreatitis. Now see, there is another question on this topic on the same paper, that is type 2A. So just wait. Okay, two questions on the same topic. A patient has multiple tendon xanthomas. Serum cholesterol level is high, that is 398 milligram per deciliter, and LDL level is also raised, were found to be raised. What is the defect? And this is exact line from the Harper's Illustrated Biochemistry. So here defect is, so this is not there in the option. So LDL is not clear. It is not cleared, and LDL receptor defect. So there is increase in the LDL level, there is increase in the cholesterol level, there is risk of coronary artery diseases. In this patient, the statins were given to reduce the cholesterol level, and there is multiple tendon xanthoma. So if there is increase, means if there is tendon xanthoma, it is type 2A. If there is eruptive xanthoma, it is an increased TG level, it is type 1. So type 1 and 2, these are the most important hyperlipoproteinemias, and they are frequently asked in the entrance examination. Just wait. So दोनों क्वेश्चन थे, टाइप 1 भी क्वेश्चन था और टाइप 2A भी क्वेश्चन था से पेपर 1 में. Okay, now this is again repeated question or PYT topic on the copper. See, 13-year-old boy reported with jaundice, fatigue, muscle stiffness, tremor, and behavioral changes. Examination revealed an enlarged liver and spleen, and KF ring image was there. KF ring image was there. KF ring, golden brown ring or golden brown ring around the cornea, that is in the decimate membrane of the cornea. So presence of KF ring indicates it is present in 99% cases of the Wilson's disease, but if it is not there, it does not exclude the Wilson's disease. So this is, in this disease, there is ATP7B mutation and there is copper excess. So this is definitive test for the, ये बहुत सारे लोगों का मिस हो सकता है क्योंकि सेरुलोप्लाज्मिन लेवल डिक्रीजेस इन द विल्सन्स डिसीज. यूरिनरी कॉपर लेवल इज द स्क्रीनिंग टेस्ट फॉर द विल्सन डिसीज. 24-hour urinary copper level, and this liver biopsy and the copper content of the liver per gram of liver tissue, this is the important and diagnostic test for the Wilson's disease. So this is very, very important. This is PYT, previous year topic, important topic. Lot of questions are there on this topic, copper. Okay, so just wait. Last option, MRI brain. Thank you. MRI brain, but the answer here is this. This is gold standard test. It is more than 200 microgram per gram of liver tissue for the diagnosis of Wilson's disease. XYZ patient's relatives sent message on social media, मतलब WhatsApp पे भेजा होगा, to the consulting doctor. He is unaware about other investigations. बाकी कुछ नहीं पता है, आधा अधूरा information है उसके पास. But he mentioned that urinary coproporphyrin is positive. What may be the probable cause? So occupational hazards यहाँ पे mention थे. So lead poisoning is answer here. Lead inhibit the two steps of the heme synthesis pathway. First one is the ALA dehydratase, and lower in the pathway it inhibits the heme synthase enzyme, or other name is ferrochelatase. ये दोनों enzyme को ये inhibit करता है, and there is increased excretion of coproporphyrin 3 and coproporphyrin 1 in the urine in the lead poisoning. और बाकी के जो options थे, these options they are related to the गोल्ड स्टैंडर्ड नहीं पूछा था, लेकिन डेफिनेटिव डायग्नोसिस पूछा था शायद से. इन्वेस्टिगेशन ऑफ चॉइस वो सेम ही हो गया. इन्वेस्टिगेशन ऑफ चॉइस इज liver biopsy in the Wilson's disease. Okay, so here lead poisoning is the answer because it inhibits the ferrochelatase or heme synthase enzyme, and there is excretion of coproporphyrin 3 or coproporphyrin 1. कोल वर्कर न्यूमोकोनियासिस, फोर्थ ऑप्शन. थैंक यू. ये बाद में भूल जाते. Okay, so this was image based question. Patient was brought to the emergency department with colic abdominal pain in the left flank. What is probable defect? इसके ये options थोड़े से मुझे recollect मतलब ये मैं gather नहीं कर सका. So here the hexagonal shaped, these are the crystals, these are the cystine crystals, hexagonal shape. So cystinuria that causes ureteric colic is the answer here. So just wait. How was the paper? पूरा PYT बेस्ड था. 18-20 क्वेश्चन. लोग बोलते थे बेसिक सब्जेक्ट को निकाल देंगे लेकिन और इंपॉर्टेंस बढ़ते जा रहा है. A neonate was brought to the hospital with chief complaint of poor feeding and vomiting. ये repeat question है वैसे का वैसा. Benedict test on urine was positive. See, Benedict test on urine was positive means test is positive for reducing sugar and urinary glucose was negative. What is defective enzyme in above mentioned disorder? So this is galactosemia, classical galactosemia. In this disorder, there is defect in the galactose 1-phosphate uridyl transferase और galactose 1-phosphate accumulate होने की वजह से बाकी सारे symptoms होते हैं. Mental retardation, then the jaundice is there, and hepatomegaly is there, and the cataract because of accumulation of dulcitor or galactitol in the lens. So this was the first session, not second session. और इससे मिलते जुलते क्वेश्चन ही सेकंड इसमें आते. सपोज यहाँ पे थायमिन आया तो अगले सेशन में नियासिन पूछेंगे और अगला कोई विटामिन पूछेंगे. ये तो सबका मतलब स्टार रेटेड क्वेश्चन है. ये पैथोलॉजी में भी आता है, ओवरलैपिंग टॉपिक विद द रंजीत सर भी लेंगे शायद से ये क्वेश्चन. सी क्रम्पल टिश्यू पेपर अपीयरेंस मैंने क्यों लिया, क्योंकि यहाँ पे एंजाइम पूछा है. Crumpled tissue paper appearance and pancytopenia, refractory anemia is there, is seen in which of the following enzyme defect? Here answer is, this is Gaucher's disease, this is Gaucher's cell, this is intracytoplasmic inclusion due to accumulation of glucocerebrosidase or also known as glucosyl ceramide. And because of this enzyme defect, there is accumulation of glucosyl ceramide in the macrophages, and this is the picture, crumpled tissue paper or wrinkled paper appearance. ये बहुत बार पूछा जाता है. पूरा मतलब ये इजी क्वेश्चन है. ये क्वेश्चन मैं थोड़ा सा संतोष सर के लिए छोड़ दूंगा, थोड़ा मैं कंप्लीट करता हूँ. ए पेशेंट विथ हिस्ट्री ऑफ binge अल्कोहल इंटेक presented to emergency department with convulsion, altered sensorium and plasma glucose level 45 milligram per deciliter. What treatment is needed? So there is inhibition of gluconeogenesis by the alcohol it favors the NADH production. So in this, as this is a treatment part, ये मैं संतोष सर मेरे नेक्स्ट संतोष सर लेने वाले थे उनके लिए छोड़ता हूँ. बट हियर आंसर इज थायमिन फॉलोड बाय डेक्सट्रोज. अगर सिर्फ डेक्सट्रोज देंगे तो डिटोरिएट हो जाएगा, इसलिए वो थायमिन फॉलोड बाय द डेक्सट्रोज इज द आंसर हियर. A mother came to OPD with 14-year-old mentally retarded boy. See, mentally retarded boy complaining of joint pain, irresistible urge to bite his finger and lips. This is characteristic symptom, neurological symptoms because of decreased production of nucleotides in the brain and RBCs. Decreased production of nucleotide in the brain. So the serum uric acid level was found to be elevated. Mention the disorder. So this is self-mutilating activity, disorder of purine salvage pathway. That is, and it is due to defect in the enzyme HGPRTase, hypoxanthine guanine phosphoribosyl transferase. Answer is Lesch-Nyhan syndrome. Skin rash which get exaggerated on sun exposure. ये भी PYT है. Repair mechanism involved in the above condition. This is nucleotide excision repair because of UV light induced thymine covalent cross linking. So adjacent thymine molecule, there is formation of bulky lesion which is repaired by the nucleotide excision repair mechanism. If there is fault in the nucleotide excision repair, it causes the disease that is known as xeroderma pigmentosum. It is xeroderma pigmentosum, blistering skin lesion on sun exposed part of the body, 1000 times risk of getting cancer. Okay, so this is xeroderma pigmentosum. ये जो पूरा टॉपिक पूरा टेबल दिया है रिपेयर मैकेनिज्म का, उसमें जो 5 इंपॉर्टेंट रिपेयर मैकेनिज्म है वो इंपॉर्टेंट है यहाँ पे. A 45-year-old patient presented with joint pain, weakness. पेशेंट इज नोन केस ऑफ होमोसिस्टीन यूरिया। अभी यहाँ पे होमोसिस्टीन यूरिया था या होमोसिस्टीनेमिया था, इसका प्रेजेंटेशन थोड़ा भी चेंज हो गया तो इसका आंसर चेंज होता है, बिकॉज there are two homocystinuria. One is classical and one is non-classical homocystinuria. In non-classical homocystinuria, it helps in the synthesis of methyl B12. Okay, but the considering it is classical homocystinuria, it is because of defect in the enzyme that is cystathionine beta synthase. Cystathionine beta synthase, and this is pyridoxal phosphate dependent enzyme transsulfuration reaction. By this enzyme, homocysteine and serine, it is converted into cystathionine. Cystathionine वो जाके आगे जाके cysteine बनता है. So there is elevated homocysteine level and excretion of homocysteine in urine, also associated with the heart diseases, cardiovascular abnormality because of homocysteine level. So in the treatment, vitamin B6 is given in the classical homocysteine urea. Okay. मैं बोला इसका थोड़ा सा भी प्रेजेंटेशन चेंज हो गया तो आंसर B12 पे भी जा सकता है। ये प्रेजेंटेशन के लिए इसका आंसर पायरिडॉक्सिल फॉस्फेट है। Patient presented with follicular hyperkeratosis. See, follicular hyperkeratosis on extensor aspect of forearm, and patient is having dietary history of vitamin A and vitamin C deficiency. So this is multi-nutrient deficient condition principally caused by deficiency of vitamin A and the essential fatty acid. This deficiency causes the follicular hyperkeratosis on the extensor aspect of the forearm, toad-like skin, that is known as phrinoderma. Okay. Next question, just wait. B12 was not given, biotin was given. Okay. फिर तो इजी हो जाता है आंसर अगर B12 ऑप्शन में नहीं है तो। पेशेंट केम टू हॉस्पिटल विथ सीवियर एब्डोमिनल पेन, सीरम अमाइलेज एंड लाइपेज लेवल्स एलिवेटेड, दोनों पहले से ही दिया है, सो इट इज ए केस ऑफ पैनक्रेटाइटिस। ओके, सो lipase is specific for the pancreatitis. On imaging, there is stone in the CBD, stone in the common bile duct, which enzyme is elevated in this condition. So यहाँ पे फोर्थ ऑप्शन कौन सा था पता नहीं, अगर अल्कलाइन फॉस्फेटेज फोर्थ ऑप्शन है तो थोड़ा सा कंफ्यूजिंग हो जाता, अदरवाइज this GGT is the answer here, gamma glutamyl transferase, GGT 5' nucleotidase and alkaline phosphatase. This indicates the obstructive pathology. These are the obstructive enzyme. So here answer is GGT, gamma glutamyl transpeptidase or transferase. Last option homologous repair. Okay, thank you Lekha. Essential fatty acid deficiency mention था वहां पे, निखिल राज, हेलो। उसके डेफिशिएंसी से भी फ्राइनोडर्मा होता है, essential fatty. It is multi-nutrient deficient condition principally because of vitamin A deficiency and essential fatty acid deficiency. No ALP, not there. Okay, thank you Arjun. Thank you Pradyot. Patient underwent gastrectomy. Which of the following deficiency may occur? इसके लिए जो आप लोग जो repeatedly topic देखते हो, जैसे ये न्यूमोनिक है, याद रखने के लिए आयरन, फोलिक एसिड एंड B12. So this is duodenum, this is jejunum and this is ileum. ओके, डिओडेनम, जेजुनम, आइलियम। अभी इसने क्या निकाला, गैस्ट्रेक्टोमी, ये इसमें नहीं आता, बट इन द parietal cell, gastric parietal cell, there is synthesis of intrinsic factor which is required for absorption of B12. So here answer is B12, क्योंकि सब total gastrectomy or partial gastrectomy, there is decreased synthesis of intrinsic factor which is required for absorption of B12. So here answer is B12. Okay, क्वेश्चन था कि नहीं पहले, वो तो पूछा ही नहीं मैंने, जस्ट वेट। नॉन अल्कोहलिक फीमेल पेशेंट वाज गिवन, यहाँ पे कि इसके पहले क्वेश्चन में? ALP वाज लास्ट ऑप्शन, ALP वाज देयर। कुछ लोग बोल रहे कि ALP ऑप्शन में ही नहीं था। सी, ALP 5' न्यूक्लियोटाइडेज एंड गामा ग्लूटामिल ट्रांसफरेज, दीज ऑल आर द ऑब्स्ट्रक्टिव एंजाइम, मतलब ऑब्स्ट्रक्शन में बढ़ते हैं। अगर ALP क्वेश्चन आंसर में था तो इट क्रिएट्स कंफ्यूजन. ओके, फिर भी गामा ग्लूटामिल ट्रांसफरेज इज द आंसर. नाउ सी, ये भी PYT है, रिकेट्स पे क्वेश्चन है. दिस इज विंड स्वेप्ट डिफॉर्मिटी, इधर से हवा आ रही और ये मतलब हवा से नहीं चेंज होता, लेकिन दिस इज डिफॉर्मिटी, दैट इज नोन एज विंड स्वेप्ट डिफॉर्मिटी. Now see, child presented with following deformity, biochemical investigation as given below. Serum calcium normal serum calcium. अगर normal है, so there is less possibility of nutritional ricket. Now parathyroid is normal. Normally in most of the rickets condition, there is increase in the parathyroid hormone level. Parathyroid hormone normal, that indicates the hypophosphatemic rickets. This is hypophosphatemic ricket. There is decrease in the phosphate. Calcium is normal and parathyroid is also normal. So this is ALP तो सभी में बढ़ता है. What would be the probable defect here? Hypophosphatemic ricket is the answer. Okay. क्योंकि ये PTH लेवल बाकी सब में बढ़ता है, लगभग सभी में पैराथायरॉयड हार्मोन लेवल बढ़ता है. फॉस्फोरस लेवल सभी में लो रहता है, सिर्फ रीनल फेल्यूर में फॉस्फोरस लेवल ज्यादा रहता है इन रिकेट्स, कंसिडरिंग द रिकेट्स. एंड न्यूट्रिशनल रिकेट्स में मेनली सीरम कैल्शियम लेवल लो रहता है एंड PTH लेवल इज हाई. सो दिस इज हाइपोफॉस्फेटेमिक रिकेट. उसमें भी दो टाइप है, एक्सलिंग और दूसरा कोई तो भी डोमिनेंट है. ऐसे दो टाइप है हाइपोफॉस्फेटेमिक रिकेट्स में. नाउ ये क्वेश्चन मुझे बड़ा प्रॉपर से रिकॉल नहीं मिला इसका. ALT अगर है तो कोई प्रॉब्लम नहीं, ठीक है. न्यूट्रिशनल रिकेट ऑप्शन में अगर है फिर भी वो आंसर नहीं है, ठीक है. यहाँ पे आंसर वही है, हाइपोफॉस्फेटेमिक रिकेट. इसका रिव्यू दो मुझे. ये आई थिंक दिस इज लास्ट है शायद से. इनकरेक्ट स्टेटमेंट अबाउट आयरन एब्सॉर्प्शन इज, तो यहाँ पे ये एक ऑप्शन मिला, that is conversion of ferrous to ferric by the ferric reductase. It is not by the ferric reductase, it is by the peroxidase activity of ceruloplasmin. There is conversion of ferrous into ferric. Also vitamin C for the absorption, they convert the ferric into ferrous form. Here this is ferric reductase. This is ferric reductase causes the reaction in opposite direction. So if it is incorrect statement, this is answer. If it is incorrect statement, this is answer. तो इसके प्रॉपर 4 ऑप्शन आप इसमें डाल दो. फेरस टू फेरिक, यस, फेरस टू फेरिक. सो दिस इज करेक्ट. थैंक यू. सो थैंक यू ऑल ऑफ यू. 2 क्वेश्चन मैंने छोड़ दिए जो कवर किए जाएंगे. रंजित सर एक क्वेश्चन कवर करेंगे और एक संतोष सर कवर करेंगे. वन इज द हाई आयन गैप मेटाबॉलिक एसिडोसिस, अनदर वन इज द Prader-Willi syndrome. So there were a lot of questions in this NEET PG entrance examination. Over to you, Santosh sir, please.
Thank you, sir. Thank you, Ranjit sir. So guys, I hope I am audible and loud and clear to all of you. So this is medicine recall. Not many questions have been recalled so far. I have around 7 or 8 questions and I won't take much time. I'll quickly give you the answer and then I will pass on the baton to the next faculty. So this is going to be our first question. Which of the following is the preferred drug in treatment with patients having dementia as well as stress incontinence? I'm very sure this question will also be taken by my dear friend for pharmacology, but we'll address from the perspective of medicine. Okay. So first, can you help me recall the options? Can you help me recall the options for this question where a patient has dementia as well as stress incontinence? Okay. Even if you are not able to get the options right, I will tell you basically how do we treat patient with dementia. What is the most common cause for dementia? The most common cause for dementia is Alzheimer's disease. Okay, so tolterodine was one of the option. Good. Tropicamide was one of the option. Okay. So Alzheimer's disease is the most common cause. In Alzheimer's disease, it is a neurodegenerative disorder and we lose neurons which primarily use acetylcholine as the neurotransmitter. So to improve the memory, we try to enhance the quantity of acetylcholine in these neurons. So how do we achieve that? By inhibiting the acetylcholine esterase. So the drugs that used for the treatment of Alzheimer's disease, which is the most common cause for dementia, is nothing but acetylcholine esterase inhibitors. And as you know, the drug of choice is donepezil. So we use that. Okay, now How do you treat a patient with stress incontinence? Mostly you treat them with anti-muscarinic agents, right? You treat them with anti-muscarinic agents. So if I give anti-muscarinic agents, they will block the muscarinic receptors. If I give donepezil, it is increasing the acetylcholine, but it is not going to work because we are blocking the receptors. So when we treat stress and incontinence, you have different categories of anti-muscarinic agents, which are categorized into selective and non-selective. Non-selective का मतलब क्या है? They primarily target most of your types of muscarinic receptors. Muscarinic receptors have M1, M2, M3 types. हमको किसको टारगेट करना है? M3. In the bladder we have M3. In the brain we have M1, M2. तो अगर नॉन सेलेक्टिव यूज करेंगे तो वो डिमेंशिया वर्सन करेंगे. Selective we have drugs like solifenacin, which is reasonably good, but it is not hyper selective. It is selective, but it still acts on M1, M2 to some extent. So वो dementia worsen कर सकता है, but it is better than non-selective. But we have a new drug called as mirabegron, which is not an anti-muscarinic agent. It works by acting as an agonist. It is an agonist of beta-3 receptors. So it gives you the same result of stress incontinence treatment that we get with antimuscarinics, but without fiddling with the acetylcholine esterase activity or without fiddling with the acetylcholine activity in the brain. So if they ask you what is the choice, it would be mirabegron. It would be mirabegron. Arnab, we are discussing the morning shift itself. Okay. Then there was one question on the JVP. JVP, as you know, is a standard question. And in the recent 2-3 exams, the JVP is revolving around the Y descent. I don't know for what reason, but they're mostly focusing on Y descent. So in the cardiac cycle, what Y descent represents? The Y descent of the JVP represents the passive filling phase of ventricles. Passive filling phase. It represents the passive filling phase. So there are two important points to note about the Y descent. There are conditions where the Y descent becomes more prominent, rapid, or deep. So what are the conditions? These are the conditions. The constrictive pericarditis, severe right heart failure, tricuspid regurgitation, and atrial septal defect. What I want you to remember is primarily the constrictive pericarditis. So in that case, you should choose the selective M3 antimuscarinic agents, whichever was the option. Whichever was like solifenacin, dorifenacin, whichever was the selective M3 option, that would be the right answer. Okay. Why I'm stressing on the constrictive pericarditis? Because we have two conditions which have similar presentation. One is cardiac tamponade. The second one is constrictive pericarditis. So in cardiac tamponade, passive filling almost is obscured. Passive filling नहीं हो रहा है, सिर्फ active filling होता है, तो Y descent will be absent. So in cardiac tamponade, you will have absent Y descent, and in constrictive pericarditis you have prominent Y descent, which is a differentiating point. Okay, so if the question is about rapid Y descent is seen in, I believe that there was an option on chronic constrictive pericarditis, and that would be the answer. अगर ये option नहीं था तो the rest of the options that I mentioned, one of them will be the answer. अगर क्वेश्चन ये पूछा गया था कि in which of the following condition rapid Y descent is not seen, तो आंसर होगा cardiac tamponade. So if you Subhara Chakravarti, let me know the options. We will definitely address that. Yeah. If it was not the option, that's what I told you, right? See, in a quick recall, we will not be able to gather all the options. So it is basically, you should give me the inputs. We will rectify the question. So what was the question? Dementia and the stress incontinence. So our aim is to give antimuscarinic agent. That is the standard treatment for stress incontinence. But वो dementia के medications के साथ fiddle करेगा, it will worsen the dementia. So first step is use the drugs which do not fiddle with the dementia. That will be a beta-3 agonist like mirabegron. That is the best choice. अगर नहीं है, तो then use the antimuscarinic agent which is selective for M3 receptors. That's the take-home message. Okay. So can anybody help me with the rapid Y descent options? I believe chronic constrictive pericarditis was there, and if it is there, then definitely that will be the answer. We will get that prominent Y descent in the JVP. Okay. Then there was one more question on the most common cause for death in idiopathic pulmonary fibrosis. Okay, so what is idiopathic pulmonary fibrosis? It is the most common interstitial lung disease, right? Age is an important risk factor, and certain genetic mutations increase the risk. idiopathic pulmonary fibrosis does carry a very high mortality in comparison to other interstitial lung diseases like idiopathic non-specific interstitial pneumonia. Okay, now why do these people die? It's a chronic lung disorder. So obviously, when you have a chronic lung disorder, it does increase the risk of developing pulmonary hypertension, thus right heart failure. But is that the cause of death? No. Most of these patients die primarily because of the disease itself. How do they die? Obviously, interstitium is getting affected. Eventually, respiratory failure will set in. So the most common cause for death in idiopathic pulmonary fibrosis is respiratory failure. That is the most common cause. Pulmonary hypertension and its consequences are the second most common cause. Is the second most common cause. It is the second most common cause. Nitin Banwani, what is the question about bicuspid aortic valve and stenosis or mitral stenosis and RHD? Can you help me with the stem of the question? I will frame it and get back to you on that. Like, was the clinical picture of someone with angina, dyspnea on exertion was given? Okay, Miss Invincible. Okay, then that is a straightforward answer. If constrictive pericarditis is mentioned, we'll definitely go ahead with that. Actually, that is the single thing that you need to remember, that in constrictive pericarditis, Y descent rapid होता है, in cardiac tamponade, Y descent absent होता है. Last NEET PG में भी यही क्वेश्चन था. That time the answer was cardiac tamponade because उस क्वेश्चन में Y descent absent पूछा गया था. That's it. Okay. So IPF question, you're saying that it was not there in the exam. So fair enough. Anyway, we have learned two important points. Idiopathic pulmonary fibrosis has high mortality. Mostly death happens because of respiratory failure. Yeah, second most common cause for death is pulmonary hypertension and its consequences. Matlab development of right ventricular hypertrophy and right heart failure. Okay, Samir, I will take a screenshot of that and I will frame that question. So it was about a cardiac failure who was stable on anti-anginal drugs. So can you reframe it better? Like what had they mentioned the anti-anginal drugs that the patient was taking? So students did tell me that there was match the following type of question where ECG images were given and the diagnosis was given and we had to match. I guess most of you got it right because this is the standard template that has been asked. पहले एक image देके directly diagnosis पूछते थे या management पूछते थे, अब match में आ गए हैं. But ultimately all these images are familiar with us. Okay. So what do you think is the first image here? Whenever you think of arrhythmias, especially tachyarrhythmias, all you have to do is first look at the QRS complexes. वो wide है या narrow है? So in this image, we have wide QRS complexes. QRS complexes more than 3 small squares on the ECG. If it is wide, what is the differential diagnosis? Ventricular tachycardia, ventricular fibrillation, and maybe supraventricular arrhythmias with aberrant conduction. If it is narrow, you should think of atrial fibrillation, then PSVT, atrial flutter, and other supraventricular arrhythmias. So in this image, we can see that the QRS complexes are wide. So it has to be VT or VF. VT and VF mein, most important thing is VT has two types. One is monomorphic VT where you see wide QRS complexes with all of them looking, all the QRS complexes looking same. Similar morphology, we call it as monomorphic VT, mono VT. And then you can have another VT where QRS complexes look different. They are wide, but they look different. And such VT is called as polymorphic VT. Now this image may make you think like this is looking like polymorphic VT, but this is not polymorphic VT because when you look at the amplitude of this QRS complexes, which is small. Fibrillation मतलब ventricle बस सिर्फ shake हो रहा है, मतलब उसको shake होने जितना ही voltage मिल रहा है, not sufficient enough to cause the contraction. So if it is not sufficient enough, obviously you will not have normal looking amplitude. यही ECG amplitude normal जैसे दिख रहा है, then it will be counted as polymorphic VT. So what is this then? This will be ventricular fibrillation. Was there an image of monomorphic VT also? This will be ventricular fibrillation. Okay. In the second image, what do you notice? You have narrow QRS complexes. So you are thinking about supraventricular arrhythmias, including atrial fibrillation, atrial flutter and all. If you have a narrow QRS complexes, next step is to see P waves hai ya nahi. Here, I don't get any identifiable P waves. I do some basic undulations of the baseline, which are called as F waves or fibrillatory waves. So if P waves are not clearly identifiable, then we can take it as absent P waves. In that case, what is the next step? See what is happening to the RR interval. वो constant है या vary कर रहा है? So in this ECG, it is clearly varying. एक beat से दूसरे beat में RR interval vary कर रहा है. So if such is the case, it is nothing but atrial fibrillation. Okay. Then in the next image, what do we have? We have narrow QRS complexes with absent P waves. जो दिख रहे हैं ये तो T wave हैं, P waves कुछ नहीं मिल रहा है, and RR interval is constant. That is a very typical picture that all of us know. It is suggestive of paroxysmal supraventricular tachycardia. And the last image, okay, VT was there, not fibrillation, very good. So in that case, you would have matched it with the ventricular tachycardia. अगर monomorphic था and option में specifically monomorphic बताया गया था तो well and good. नहीं बताया गया था, just VT था, still well and good. Okay. Now in this image, what do we notice? We see that there are QRS complexes, but when you look at the ECG closely, you will notice that there are more than usual number of P waves, right? So there are multiple P waves in comparison to the R waves. So this is typically a feature of atrial tachycardias and a subtype of atrial tachycardia called as atrial flutter, where multiple P waves, one QRS complex, multiple P waves, one QRS complex. And because of multiple Q waves, multiple P waves, the baseline looks like the sawtooth. This is what you call as sawtooth appearance. And when you see sawtooth appearance, you don't need to really break your head much. You know directly it is atrial flutter. Atrial flutter. Okay, so if VF was not there, if it is VTAC, very good. I mean, it is much more easier to identify. Anyway, I am very sure that you would have matched the right options. Okay. Now, there was a question on the ABG. I need your help to construct it further. Is this the values that you were seeing? pH was 7.2, bicarb 14, and PCO2 23. And can you help me with other electrolyte details? Because Rajesh sir was telling me that it was about high anion gap metabolic acidosis. Miss Invincible, yes. Sawtooth appearance, that is typical atrial flutter. Yes, sir. Okay, so sodium was how much? 127. Good. 127. So can you help me with the bicarb as well as the chloride values? Okay, bicarb is already there. Okay, chloride values. Bicarb was 6.7. Okay, so I will revise it to 6.7. PCO2 was 16. Okay. Chloride was 110. 110 millimoles per liter. Okay, so step number one, we have to identify what is the ABG abnormality. So when we look at the pH, we know that it is acidosis. pH is less than 7.45, 7.35. So it is acidosis. Second thing, you know the Rome criteria. So you will see whether it is metabolic or respiratory. So PCO2 is decreased, pH is decreased, both are in the same direction. So it is metabolic. So whatever we have is metabolic acidosis. So whenever we have a metabolic acidosis, step number 2 is to calculate the anion gap. So what is the formula for anion gap? Measurable cations minus measurable anions. What are the major measurable cations? Sodium and potassium. So anion gap ke liye you can have two formulas. In one formula, you can use sodium as well as potassium, or because potassium is a small contributor, you can ignore it and you can only concentrate on sodium. So जैसे आपने सिर्फ sodium बताया है, so we will use the formula for sodium. So if I have to calculate it, sodium minus chloride plus bicarbonate. So यहाँ पे sodium is 127 as you said, and bicarb is 6.7. So the chloride is 110. So 110 plus 6.7, I will take it as like rough calculation. I will convert it to 7. So it will be like 127 minus 7, that will become 20, right? Am I right? Oh, sorry, 117 minus, like 127 minus 17. So that will turn out to be 10. That will turn out to be 10. Is that the exact numbers we had? So you're telling gap was around 20. So do you mean sodium was more than what I have got here? Sodium was more than what has been mentioned to me. Was sodium more than this? So if you have to get the anion gap of 20, either I should have more sodium or less chloride. Either I should have more sodium or less chloride. Then only I will land up with this. Sodium was 137. Okay. So if it is 137, then clearly it becomes 20. अब recall में numbers थोड़े बहुत vary हो सकते हैं because decimal points को कौन याद रखता है भाई. But at least you guys know कि high था, right? Because if you are not using the potassium in the formula, then the normal range is 8 to 12. When it is more than 12, it is high. If you're using the potassium, then हमको यहाँ पे 4 add करना पड़ेगा for potassium. So if it is more than 16, then it will be counted as high. So if it is more than 20, if it is 20, it is definitely high. So we have high anion gap metabolic acidosis. And I presume that the question was asking you which of the following can be a cause, right? Okay, so you can use the potassium also. See, formula mein you can comfortably ignore even when they have given the potassium, or you can use it also because its contribution is minimal. So अगर आप potassium use करते हो तो then it is more than 16. तो इसमें मैं potassium add कर लूंगा तब भी it will come more than 16. Then also it is high anion gap metabolic acidosis. So what were the options there? Okay, so some of you say that you calculated it to be exactly 23. Okay, precise number examination hall में don't waste your time on the precise number until and unless वो पूछ रहे हैं कि precisely कितना है calculate करके बताओ. If they're asking you कि हाँ diagnosis क्या है and all, quickly get a rough number. आपको decide करने में आसान हो कि high है या normal anion gap metabolic acidosis है. Move to the options. Exam में time waste बिल्कुल नहीं करना है. So if diagnosis itself is asked, then it is high anion gap metabolic acidosis. अगर scenario दिया है and they are asking you what could be the cause, right? They might have mentioned all of your options. You know the mud piles pneumonic. उनमें से कोई भी एक option हो सकता है. Okay, so if high anion gap metabolic acidosis was the option, that would be the answer. Okay. Okay, high anion gap metabolic acidosis with compensation partial है या complete है, वो अगर पूछ रहे हैं तो simple trick है. So अगर compensation की बात है, you will call it as fully compensated only when जो corrective measures हैं, मतलब metabolic acidosis में bicarbonate कम होता है, as a compensation हम कार्बन डाइऑक्साइड भी कम करते हैं, राइट? सो अगर ये कॉम्पेंसेटरी मैकेनिज्म पीएच को वापस नॉर्मल रेंज के अंदर पहुंचा देता है, मतलब 7.3 टू 7.45 के अंदर वापस आ जाता है बिकॉज ऑफ द कॉम्पेंसेटरी एफर्ट, देन वी कॉल इट एज फुल्ली कॉम्पेंसेटेड. वापस नहीं आता है, अभी भी नीचे ही है, तो देन इट इज पार्शियली कॉम्पेंसेटेड. सिंपल है. अगर कॉम्पेंसेटरी मैकेनिज्म में कोई चेंज ही नहीं आ रहा है, द कार्बन डाइऑक्साइड इज नॉट डिक्रीजिंग एट ऑल, देन यू कैन से अनकॉम्पेंसेटेड. यहाँ तो डिक्रीज है, तो कॉम्पेंसेशन हुआ है, पूरा नहीं हुआ है क्योंकि पीएच को हमने करेक्ट नहीं किया है. सो दिस विल बी काउंटेड एज पार्शियली कॉम्पेंसेटेड high anion gap metabolic acidosis. I think most of you got that. Good. Okay, this I think the question will also be taken by Siraj Ahmed sir, but because I could gather it quickly from the students, I have mentioned it here. Which of the multiple myeloma treatment drug causes reactivation of herpes zoster? So I had recently read plenty of articles about bortezomib use and the risk of reactivation of herpes zoster, because bortezomib does interfere with immune function. And और भी studies हैं which shows that even multiple myeloma itself can cause reactivation of herpes zoster. अगर option में था तो that will be the answer. Okay, Niti Banwani, very good. So if two options were about the respiratory, anyway you clearly know that it is metabolic acidosis, high anion gap है and partially compensated. So I think you got the answer right. Fair enough. Okay. So there was one question on the ECG hyperkalemia. Can anybody help me to address this? This would be the last question from my side. Medicine this time probably had less questions in comparison to surgery or OBG. But still, whatever questions that we have missed, please do share it with me on the Telegram. I will compile with more proper STEM and we will share it with all of you in a PDF. Okay, so Miss Invisible, what is the story of that? I will take that question and then I'll come back to hyperkalemia. Hyperkalemia तो एक standard template है, हमेशा we have been answering it from years. So we have a patient with stable angina. Okay. Stable angina from 3 years and no other complications. Which drug will be useful for patient? Propranolol, bisoprolol or pindolol? Okay. So see, what is the drug of choice for treatment of, or how do we treat a patient with stable angina? What is the problem in stable angina? You have a coronary narrowing. So blood flow to your myocardium is reduced. बट इतना भी reduce नहीं हुआ कि रेस्ट के टाइम पे जितना चाहिए वो नहीं मिल रहा है, उतना reduce नहीं हुआ है. रेस्ट के टाइम पे मसल को जितना चाहिए उतना मिलता है, तो चेस्ट पेन नहीं है. बट व्हेन आई स्टार्ट डूइंग एक्सर्शन, कार्डियक मसल का ऑक्सीजन डिमांड बढ़ता है, उतना सप्लाई इंक्रीज नहीं हो पाएगा बिकॉज ऑफ द ब्लॉक्ड ब्लड वेसल, तब मुझे पेन आता है. सो व्हेन आई रिलैक्स अगेन, the blood supply and the demand match हो जाएगा and the pain will disappear. That is the typical story of stable angina. So how do we treat it? By giving the vasodilators, right? By giving the vasodilators. What are the vasodilators? You can think of beta blockers or the calcium channel blockers. दोनों में कौन सा चूज करना है? No specific recommendations. Either you can choose beta blockers or calcium channel blockers because दोनों vasodilators हैं. इन दोनों में से पेशेंट फैक्टर्स के बेसिस में डिसाइड करते हैं. मतलब क्या? अगर कोई पेशेंट आस्थमेटिक है तो ऑब्वियसली आई कांट यूज बीटा ब्लॉकर्स, आई विल चूज द कैल्शियम चैनल ब्लॉकर्स, राइट? अगर नहीं है तो यू आर फ्री टू चूज वन ऑफ देम. सो व्हेन यू आर चूजिंग द beta blockers, it is good to choose a cardioselective beta blocker so that you are not causing the beta blockade elsewhere. That's the basic principle. Okay, so the question was about which can decrease the mortality. Was that the question? So ECG had tall T only in V1 to V3, not in V4, V6. Okay, very detailed observation. Separate V1 lead showed not much of tall T waves. In V4 to V6, height of T wave was less than QRS complexes. Okay. So the heart failure and stable angina, let me construct the stem again in detail. Let me understand whether it was a patient of ischemic heart disease, that is stable angina, now developing heart failure and asking what drugs reduce the mortality or what drugs have prognostic implication, or was it like what will you choose to treat the patient stable angina? So let me understand that and then I will compile that. Then potassium, I think this was a pretty straightforward question as I believe. So generally what happens, what ECG changes we get when we have hyperkalemia? The earliest ECG change when we have hyperkalemia is going to be tall T waves, right? T waves start becoming tall. But as the time progresses, then you will have PR interval prolongation. Eventually you will have QT prolongation. QT interval also starts getting prolongation. Then you will have disappearance of P waves. And the last thing you get is something called as sine wave. So if you can share me the closest image that you got in the exam from Google, it will help me to compile it in the PDF. Meanwhile, be aware of these and you should be able to pick up all these changes in the ECG based question for hyperkalemia. Okay, so I'm going to leave a small table in the PDF, which will have the relative values of potassium and what ECG changes, corresponding ECG changes we can expect. We'll continue to discuss more to evolve more questions. Okay, Nitin Banwani, can you DM me on the Telegram the two questions? I will construct the stem and then I'll come back again to share in the tomorrow session or through the PDF. I will now pass on the baton to my next faculty because they're also waiting with the recalls. Medicine will take a lot more time for a complete evolution of the stem because many factors, many small pointers would be there. So I'll pass on the baton to the next faculty and they will take on with the next subject. Dr. Ranjit, over to you.
Yes, give me a second. Hey guys, can you see me? Okay, if you can see me and hear me, just tell me hello. We'll have a very quick recall. There are a good number of questions in pathology. What I'm going to do is, I just want you guys to have the fingers on your keyboard and comment yes or no. That's more than enough for me. Fine. Okay, let's start. So easiest question, which of the following tumors will be positive for TTF1 or napsin A? Be it an image-based question or non-image-based question, the answer is very, very simple. Answer has to be an adenocarcinoma of lung, right? Your adenocarcinoma of lung is obviously positive for your TTF1 and napsin A, squamous cell carcinoma of P40, P63, and carcinoma neuroendocrine, whatever the other options are, is positive for neuroendocrine markers, right? If it is right question and the right answer, tell me yes, that's more than enough. We need not create the stem now. I have created quite a few good stems of the questions and also the options as well. Fine. Okay, next question. This was an appropriate recall. 45-year-old present with the pain in the flank region or abdomen pain on surgical excision had a tumor, the central scar. Some of the students say that the tumor also had one of the image, the gross image, but it's a microscopic image. Is going to tell me the answer, right? So when you have clear halo like this, be it a plant cell-like appearance, plant cell might not be the right terminology. Perinuclear halo. If you have perinuclear halo, perfect. That's your chromophobasticity. Clear cell, renal cell carcinoma will have completely clear cells. Oncocytoma will be completely pink, no halo. This will not have halo. And obviously, papillary tumors will have definitely papillary nephritis, right? Perfect, Nitin. I hope this also was the right answer. Maybe an appropriate recall. I hope that should serve the purpose for us as of now, right? Next, some of the things. Perfect, Nitin. Some of the students said that this was a karyotyping or this was an image, but what was clear is it was a deletion of paternal chromosome. If there's a paternal chromosome deletion of the imprinting disorders, the right answer will be Prader-Willi syndrome, because Prader-Willi will have paternal chromosome deletion and your maternal chromosome deletion will be in Angelman syndrome. Downs and Wagner is not. I just added two more options. Doesn't matter. If you know the right answer, that's more than enough. If it's a paternal chromosome deletion, it has to be a Prader-Willi syndrome. That will be the right answer here, right? Is this question clear? No controversy still now, as of now? Okay, it's a deletion, right? So this kind of, I put a representative image with it. It's a deletion of the paternal chromosome. That should be enough for us to call it as Prader-Willi, fine? Okay, got it, Nitin, got it, fine? Okay, this might be a very simple karyotypic image. Nitin, the primary thing is 1 is getting deleted. So 1, 2, and 3, 2, 1, and 2. The primary information to be conveyed is paternal chromosome deletion. The answer has to be Prader-Willi in chromosome 15, right? Perfect. This I just cooked up the history. 16-year-old person with amenorrhea came to the clinic for evaluation. It is a very simple karyotyping. I'm sure you guys must have noted there is only one X chromosome and it was a girl child. A girl child with a 1X chromosome, it's not a difficult thing at all. It's very, very simple. It has to be Turner syndrome, right? Path was simple, at least till so far, right? So I think path was doable. I hope you guys have done a very good job. Fine, perfect. Next question. This was a question which was taken by ENT also. Just give me one information. Was this a gross staining while biopsy or a staining after biopsy? If it was, the question was this, which is a stain is used to take a suspicious biopsy from a vocal cord or from a larynx or from an oral cavity, whatever it is, the answer is to be your Toledan blue. Or if Toledan blue is not there, a supravital stain also will be good enough. Okay, this also will be good enough thing for us to pick up an biopsy, because any of the Toledan blue, this was a PYQ previously asked in 2015 or 16. Toledan blue will increase, go and bind to the more of nuclear and annular proteins, right? The DNA and RNA. So more amount of Toledan blue or more amount of supravital stain is there. Obviously the thing means the tissue has more nuclear burden. If there's no nuclear burden, most likely dysplastic tissue, right? That's how the answer is. Yeah, this option is not there or not there, doesn't matter. Anything here will stain the cells with more amount of DNA and RNA. So obviously you'll have more DNA and RNA in tissues with tumor or dysplastic tissue. That is the basic concept of using to use Toledan blue to take a biopsy. Similar concept of using acetic acid for your cervical biopsies. Fine, perfect. Okay, this was primarily regarding with the treatment, right? Okay, with Stacraside, which is after biopsy, there's only one stain after biopsy, which has to be H&E, right? So I'll leave it to you guys. If it's before biopsy, go with the supravital thing. After biopsy, go with an H&E stain, fine? Okay, this was the question. So the diagnosis was not the doubt here. You guys know by default, it's an acute myeloid leukemia because you have an OR rod. So option was treatment. I am not sure about the options. I'm sure Dr. Siraj sir in pharmacology will definitely take up with that. So you go with prednisolone and vincristine, fine? Okay, if it's after biopsy, it's H&E. If it's before biopsy, it's supravital stain. That's all, fine. Okay, let's go to the rest. Perfect. Okay, next. Okay, this, I'm not sure if there is a question. If it's not there, tell me it's not there. That's more than enough. A person with a vague abdomen pain with a massive spleen. That's a first clue here. Found to have a finding of translocation between 9th and 20th chromosome, 45XS or 45XY, fine. So if this was there, okay, Nitin, like I said, the treatment aspect, I'll leave it to Dr. Siraj to take it up whenever it's possible, fine. So this is a very simple thing. Translocation 922, say Philadelphia translocation, has to be a CML patient, right? Massive spleen has two options. Both hairy cell and CML will have massive splenomegaly. Hairy cell will have pancytopenia, and your CML will have leukocytosis, fine. Okay, let's go to the next question. This is a simple one as well. Okay, got it, Nitin. So the option was the translocations, fine. So there's a history of CML and the option is translocation. I'll rearrange it and definitely re-record it once again, fine. Okay. Okay. So papillary carcinoma thyroid, what's a mutation? Generally, cancers of thyroid mutation has not been asked till now because we don't use it as a diagnostic protocol, right? So they have included the new endocrine WHOs. There are also modifications in thyroid molecular genetics as well. BRAF 600E is the commonest mutation we've seen in papillary carcinoma thyroid, where you can give a targeted therapy as well. Fine. Okay, this question is right. This I have added up to make it 4 options. The right answer is BRAF 600E. KRAS and HRAS are seen in follicular carcinoma of thyroid. RET is seen in medullary carcinoma of thyroid. Fine. Perfect. Okay. So this I have two queries here. Some of them say it is DLBCL as well. I'll come into it one by one. First thing, please verify whether it's a child or not a child. That's the only one thing which I want you to verify. And I have two versions of the question. I'll put both the versions of the question. Was it a child or not a child? If it's a child, I can easily rule out most of the lymphomas and leukemias, right? Because if it's a child, I don't worry about it at all. Okay, perfect. If it's a child, it cannot be DLBCL. DLBCL is not seen in children, right? So if it's a child, I have only two possibilities. Keep this in mind forever throughout the exam. If it's a leukemia, I'll think of an ALL. If it's a lymphoma, I'll think of an bucket. Because these are only two things which can happen in children, right? We'll ignore that CD markers at all, right? These are the only things which can happen in a child. If it's a child, this is the answer, fine. So here, how do I differentiate it? This is TDT positive. This is TDT negative, fine. So I'll leave it to you guys because I had lots of different options here. Some of them said they saw a lymphoblast like this. Some students said they were blast with vacuolations. Blast with vacuolations, TDT negative, I'll go for Burkitt's lymphoma if it's a child. DLBCL will not be seen in children. It's a tumor seen in elderly age group only, right? It's very, very unlikely for a DLBCL to be seen in a child, fine. If it's TDT positive and it's a child and it's a lymphoblast, I'll go with ALL. In either scenario, DLBCL is not the first option to think of if it's a child. Even an 18-year-old person, I won't think of a DLBCL at the first insight, fine. Okay, perfect. If it's TDT negative, I'll go with Burkitt's lymphoma. If TDT is positive, I'll go with the ALL. This is the easiest way you can differentiate them, right? Since we're not in the exams, this is based on your recall. Child is the clue first of all. Please, whenever you have a pathology question or any clinical question, don't ignore the patient. Because patient, gender, age, clinical symptoms gives the first history, first diagnosis, then only investigation, then only image, then only markers. That's very, very important. This is the order I want you to follow in an exam as well as in a real life, right? Okay. 23 will be negative in both DLBCL, your Burkitt lymphoma. So 23 negative is not important for me here, right? It's a negative finding. That's all. 23 is positive in your CLL and your CLL, right? Okay. Perfect. 19, 10, 20, all will be positive both in Burkitt's and ALL, Abhishek. Okay. Okay. The thing is children and TDT negative for Burkitt's, children TDT positive for ALL. Fine. That's all. Okay. This was already discussed multiple times. Wilson's disease. Most of the students said it's best. Best has to be copper estimation in the liver biopsy. Those ceruloplasmin and your urinary copper used for diagnosis. If it's the best investigation, you have to go for the copper estimation, dry weight of copper in the liver biopsy. Fine. Nitin, that's just my concern, right? So the wordings, what they use, best or the gold standard, is with the examiner. So if I say the best, this is the one which is available for me for the best. That's the perfect sensitivity, perfect specificity, right? The rest of them will have here and there few false positive, few false negative. I'll have to go for copper estimation in liver biopsy if it is there. Fine. Okay. Okay. Urine crystals. You had one more urine crystal in your ionized CT as well. This was in cysteine stones, hexagonal shaped crystals. Fine. Okay. Another, like I said, best investigation choice or best thing, I would prefer it to be urinary copper, or copper estimation liver biopsy because the term is there and they have given that in the option. If it's not given that in the option, obviously I'll go for diagnostics ones, fine. Okay. This had someone said there is a MOT cell or there's a plasma cell, like a plasma cell, fine. Skeletal fluorosis amongst these options, which one? Okay. So here, patient with an elderly person has a renal failure, history of backache, has to be only one thing, is multiple myeloma. Rest of things I have added up to fill up the 4 options. MOT cell was diagnostic. You have MOT cell and a backache, and that's more than enough for us to call it a multiple myeloma patient. Fine. Okay. This history, I'm not sure. They said there's a sexual history was there. There was a dysuria, there's an UTI, multiple things. But you had similar image in pap smear, right? So when you have 3 things, multinucleation, margination, the nuclear chromatin goes to the corners, and molding. See, normally a nuclei looks like this. When a nuclei molds, this word is molding, right? So molding, multinucleation, and margination are classical 3 things for herpes virus. Painful blisters also, herpes simplex. Painful blisters also will indicate your herpes simplex only, fine. Okay. Next, box-like appearance of dermis. Dr. Jasir will also definitely talk about this. Multiple skin pathology options here. Box-like appearance is completely collagen without any of the adnexal glands. This is a classical finding seen in morphia or systemic sclerosis, right? Lichen nitidus will have a claw-like inflammation. Between 2 retipex, you'll have inflammation in lichen nitidus. lichen planus will have band-like your inflammatory infiltrate. Okay. Fine. Fine. Nucleotide exchange repair was also discussed by Dr. Jambulkar. It is your xeroderma pigmentosa, very high increase in levels of skin cancers because they are very sensitive to UV rays, and the double standard breaks. Fine. Okay, then what was the question, Aditya? If diagnosis of multiple myeloma was given in the thing, can you tell me the options in the comment box? We'll definitely take care of it soon. Fine. Aplastic crisis, in whatever may be the hemolytic anemia, it is linked to only one thing. It's parvovirus B19. That's the one which causes aplastic crisis. Fine. Okay, let's go to the next. This is a pedigree given. It's a very simple pedigree, right? All generation not affected, I think of a recessive inheritance. And if only men is affected, I am going to think of an X-linked recessive inheritance, right? So if it's an X-linked recessive inheritance of this option, Marfan syndrome is X-linked recessive. Other options, the first two are autosomal dominant and phenylketonuria is autosomal recessive, right? So it has to be an X-linked recessive inheritance. Pedigree is always simple if you follow the rules. If you missed it, please go and follow the rules of pedigree, which are taken in your live classes as well as in the record lectures. That's very, very simple to solve a pedigree, fine? So very simple. Please do remember, microscopy should not be your strongest point in exam. Helter-skelter pattern, I'm more than happy. But when you have a young athlete suddenly collapse, died during sports activity, answer is HOCM. I don't care about what looks in the cardiac biopsy at all, right? Please be strong in clinical medicine because ultimately, be it a pathologist or be it an internal medicine person, we are going to be oriented only towards the patient. That history is suggestive of HOCM, nothing else required. Even I don't require an ECG, even I don't require an autopsy or a gross or a microscopy. It has to be HOCM. Just to talk about it, it's in helter-skelter pattern or called as a myocardial disarray. So disarray is an abnormal arrangement here and there. That's what helter-skelter means, as classically in case of an HOCM, right? Just one question for you guys. Where do you see ninja star appearance? Comment in the section below, right? 25-year-old person, respiratory distress diagnosed of pan-ulnar emphysema. Pan-ulnar has to be linked with only one guy, alpha-1 antitrypsin deficiency, fine? Yeah, like it's an alpha-1 antitrypsin deficiency. It's a pan-ulnar emphysema. That's classical for an alpha-1 antitrypsin deficiency, right? Perfect. DCM and what mutation? Anyone? Okay. So this was a question on von Willebrand factor. I'm not sure if these options were right, but I'll give you things about the types of von Willebrand disorder. Type 1 von Willebrand disorder will have less number of or amount of von Willebrand factor. Okay, this is autosomal dominant inheritance. Type 2 is qualitative, which means the amount of functional von Willebrand factor will be less, but the number will be normal. It's normal number, but it's not functional. Type 3 is almost zero, right? Type 3 is almost zero, so that's a most severe thing. Type 1 is not most severe. Type 3 is definitely most severe. Type 2 is in qualitative defect. Type 3 has very low levels of von Willebrand factor. That's why type 3 kind of mimics your hemophilia, right? So looking at these options, if these were the options, I would say not true will be option 1. Type 1 is not very severe. Type 1 is very, very decent amount of disease which you can treat. And your intranasal, what's the drug you give? Okay, what's the drug you will give? So that, okay, bleeding in infants, fine. Okay, I'll correct it, Arjun. So bleeding in infants kind of, they don't present in infants because, like I said, it's autosomal dominant inheritance. None of the autosomal dominant inheritance will have a very severe disease in infancy. It will be seen in adolescent or adult age group only, fine. Okay, that's more present, perfect. Okay, this again is a very repeated question. I'm sure next time you crumple a tissue paper, you'll just remember the Gaucher's disease or a glucocerebrosidase defect, right? I'm not going to spend time on it. Whatever history it is, you look at a crumpled tissue paper appearance, you write as a Gaucher's disease, right? Okay, we'll go with that first option of bleeding in infants as the right answer, fine. Last but not least, might be a history of ARDS or not, whatever, whenever there's interleukin 8, it's a chemoattractant for neutrophil. It's one of the prominent chemokines. It's a definitely chemoattractant for a neutrophils, fine. Okay, got it. That will end pathology. I hope it is a very quick recall because I want you to just know the right answer and appropriate recollection of it. So if you are attempting any of the forthcoming INST, because this paper looks like it's been taken by AIMS. So you might get repeats from this in the next upcoming INST also. So all the very best for you guys. Yes. Yes, Kanwarpal, neutrophilic recruitment is interleukin 8, fine. So next will be dermatology to Dr. Jazzy. Jazzy, thank you. Bye-bye.
Thank you so much, sir. I hope the entire session is going fine. So myself, I'm Dr. Jazir. So I'll be discussing the dermatology questions with all of you. I hope I'm audible and visible. So I'll just check the chat box as well. Yeah. So regarding dermatology, basically I've collected a few questions which I have got from the recall from all the students. So we got almost 4 to 5 questions, and I'll be talking about all of them. I hope the dermatology questions were easy, not very difficult, I guess. Anyway, let's see one by one. The first one that I would like to discuss here is going to be this one. So just a minute. Yeah. So this is going to be the first question that we'll be discussing. I guess all of you got an image like this, right? Where you could see multiple patchy alopecia, isn't it? So whenever you find multiple patchy alopecia, the first thing that comes to your mind is it associated with any STIs? So see the question. I guess this is the question that was asked, the following type of alopecia, along with some gray patches over the trunk and groin area. So when you get something like this with a gray patches over the trunk and all, then this should raise a suspicion of which disease. So this is something that we may call as moth-eaten alopecia, isn't it? It is called as moth-eaten alopecia, and moth-eaten alopecia is associated with secondary syphilis. Secondary syphilis. So please confirm in the chat box as well if this was something that was asked, because I just got an image. I got to know that there is a mention of some lesions over the trunk as well. So the lesions over the trunk, as all of you know, in syphilis, we would be expecting some maculopapular rash, pigmented rashes over the palms and soles. All those things are expected in secondary syphilis. So in secondary syphilis, yeah. So in secondary syphilis, we can see this kind of an alopecia. So this is called as moth-eaten alopecia as well. Okay. So a few of you are messaging malassezia fur scarring was given. So where was the scarring given? Harshul and all, just a message in the chat box so that I can just collect those messages, because anyway we'll be coming up with a very detailed recall later, isn't it? Yeah, regarding trichophyton anonymous, I have another question, because this one is like moth-eaten alopecia, or that is seen in syphilis. Regarding the species that causes tinea capitis, I have framed one more question. So let us see. Yeah, secondary syphilis would be the answer. Yeah, microsporum, I'm coming to it. Okay, I'm just going to the next question now. So thank you for responding. Okay, thank you. So there was one question regarding the unit, right? Pilosebaceous unit. And I guess they have asked you like marking all those things, like whether it is an eccrine gland, whether it is an apocrine gland, sebaceous gland and all. So here, this is an image of the normal pilosebaceous unit. And in case they have also labeled regarding the muscle. So the muscle would be somewhere here, and the muscle should have been called as the arrector pili muscle, isn't it? Arrector pili muscle. I guess it was something like a match the following. So you have clearly seen that this is the image here. So out of which the gland that directly opens to the surface of the skin, this is going to be the eccrine gland. So when we talk about a hair follicle, you can see that the entire hair follicle that we have, it is supported by the arrector pili muscle, and there is a sebaceous gland. So there is a sebaceous gland that opens into the hair follicle. So this is going to be the sebaceous gland. And also in the areas like axilla, groin, etc., what happens? There would be this apocrine gland as well. So this is the kind of match the following thing that was asked. Kindly confirm in the chat box if there is any changes, any corrections. Please do inform me in the chat box as well. Okay, clear. So now let me just talk about the one more question. Now, did you get this right or not? Because in case you got a question which mentions about a orange colored skin. So along with this orange colored skin, if there is a mention about follicular hyperkeratosis, and many of the students said that there is an image of a hair follicles. So where some folliculitis kind of an image where there is some erythema around each of the follicle as well. So if the image was something similar, please let me know in the chat box. Now here, yeah, Anonymous, I'm coming to that question. So we'll come to that question in a while. I have framed that question also. Now here, what is the correct answer? When you see a orange colored skin with some areas, you can see that there is some area here where you can find a normal skin. So there are some areas of uninvolved skin. So these are areas of uninvolved skin as well. So here in such a case, the diagnosis should be pityriasis rubra pilaris. Pityriasis rubra pilaris. The name says rubra, red, but actually the skin color is going to be a orange colored plaques, a plaque lesion or a patch lesion. That is what can be seen in pityriasis rubra pilaris. Along with that, you can see that there is a follicular hyperkeratosis. So in this follicular hyperkeratosis, what is happening? Once you try to palpate over these lesions, you'll be getting that rough feeling, right? So here what we find is a nutmeg grater sign. Nutmeg grater sign. So all of you know that in the kitchen, we will be using a grater. So this grater has a very rough surface. So similarly, in follicular hyperkeratosis also, there is something very rough. Hence the sign nutmeg grater sign. Okay, so here the right answer should have been pityriasis rubra pilaris. So in this disease, we also find one more finding over the palms and soles. I guess this was also mentioned in the MCQ. So what is the finding in the palms that you can get in pityriasis rubra pilaris? So this is called as palmoplantar keratoderma. Keratoderma can also be seen. So the skin of the palms and soles, they become thick, isn't it? Scaly, dry, etc. So this is called as palmoplantar keratoderma. So that is about this question about pityriasis rubra pilaris. I guess this next question, I guess this is already discussed in microbiology, as well as I saw just now, I saw Ranjit sir also discussing about it. A patient with multiple sexual partners presents with painful lesions over the genitalia. So here in this painful lesion, so whenever we talk about any painful genital ulcer, you always know there are two options. The first option should be either a chancroid or it should be herpes genitalis. Herpes genitalis. So I did not get the second part of this question. So if you just mention that there is painful lesions over the genitalia, it can be either chancroid or it can be herpes genitalis. There should be some differentiating feature as well. So whatever is a differentiating feature, for example, if they have mentioned about multinucleated giant cells, then the answer could have been herpes genitalis. In case they mentioned about this term along with buboes, that is suppurative lymphadenopathy. So in case a suppurative lymphadenopathy was mentioned, then the answer should have been chancroid. But whoever shared the question, they were saying that there was a genital painful lesions, which is consistent with HSV. Okay. So if it is HSV, then it should have been, if there is a mention about painful lesions, and if these lesions were mentioned as vesicles, then the answer here should be going for herpes genitalis. Okay. Thank you, Nitin, for confirming. So now let's see one more, because many of you said that there is one moth-eaten alopecia of syphilis that was mentioned. There was also a question which many of them have recalled, that there is something given about a tinea capitis. So tinea capitis, we all know that this is going to be the fungal infection or the dermatophytosis of the scalp. So in the scalp, if the answer... Thank you, Anonymous. It's okay. You have just completed your exam. If at all you recall these many, that still it is good. Okay, thank you so much. So now here, yes, image was given. So there is an image of a tinea capitis. Now they were asking regarding the species. So we all know that trichophyton, epidermophyton, and microsporon. These three are the species of fungus which would be causing tinea capitis, right? Now here, if you remember, we have discussed that M does not cause infection of N. Matlab, microsporum does not cause infection of the nails, and epidermophyton does not cause infection of the hair, isn't it? So the least likely should always be epidermophyton, because epidermophyton is not going to cause an infection of the hair. So just let me know about this one also. So Ashwini is saying not there, but many of them had a discussion in the beginning of the session regarding the three species of tinea capitis. Now let's see. So this is the last one which I have gathered. I think there was one more question where multiple images were given and you were asked to link the programs and all. I'm sure that Murugan sir will be discussing about it later as well. Now, what is this? This is the logo of National Leprosy Eradication Program, right? So the logo of this thing was asked. So can anybody confirm in the chat box if this was asked like a match the following, or it was an independent question about leprosy itself, where the logo of the NLEP was asked. So if it was asked, then this is the logo of NLEP. So that is it. Yes, thank you, Dr. Ashwin, for confirming. And these are mostly the questions which, okay, it was an independent picture. Matlab, it was a separate question on this logo itself. So these are basically the questions which I have gathered from dermatology in this short time. So thank you so much for sharing all those things. And I think there was a question about phrinoderma, which is associated with vitamin A deficiency, and the box-shaped histopathology finding. I just saw that Ranjit sir has also discussed. So that is it. Thank you so much. So I hope all of you come up with great results. All the best. Over to the next faculty.
Hello everyone, am I audible? Am I audible? Hello everyone, am I audible? Okay. Okay, let's discuss forensic medicine and toxicology questions asked in your paper 1. There were around 12 to 13 questions asked from forensic medicine. The first question was from asphyxial death. Okay. As we discussed in asphyxia, suffocation, very important topic. So here is the question asked. You can correct me if I'm wrong. During postmortem examination of suspected case of asphyxial death, forensic surgeon noted circumoral pale area around the mouth and the nose and crescentic nail marks with the contusion laceration of the lips. The probable type of asphyxial death is. Options are throttling, smothering, leg edge strangulation, hanging. Yes, Sriya Sharma, can you correct me if I'm wrong? So here, circumoral pale area, nail marks around the face, and image was given. Okay, okay, Yamini Chaudhary, yes, image was given and image was showing same finding. The nail marks, contusion, laceration of the lips. The probable type of asphyxia. So it is not the case of throttling, because in throttling we see 6 penny mark. Okay. In ligature strangulation, we commonly see ligature mark. So, but in this picture or in this question, there was no ligature mark. It is not the case of hanging, because ligature mark is not there. Dribbling of saliva is not there. I know. So the answer is smothering is the correct answer. Smothering. The smothering is a type of suffocation where we see all these findings. The reference is K.S.N. Reddy, 35th edition, page number 281. Okay, Ashwini is telling, sir, choking was an option. Okay, fine. So choking is option C. Okay, fine. The answer is smothering only. Smothering. Fine. Rest all correct. Right. So what is smothering? That is the occlusion of the external air passages, mouth and nose. You will see CPC, cyanosis, petechial hemorrhages and congestion, and contusion aberrations of the lips as well. Right. Good. Second question. Which of the following, that is from toxicology, which of the following is contraindicated in iron overdosage or iron poisoning? The option given are BAL, deferoxamine, EDTA, and some other option. Okay, can you correct me? Yes, yes. Ryan, Brijesh. It's very simple question. BAL is contraindicated in case of cadmium poison and in case of iron poison. Also in case of peanut allergy. in selenium poison, organic mercury poison? Yes. So the answer is Ball is the correct answer. British anti-levisite. So this is dimercaprol, contraindicated in cadmium and iron poison. This we discussed many times in PW shorts as well. Contraindications of Ball. Mnemonic is PICO. Yes, second. Okay, fine. Shriya Sharma, fine. Okay, right. Okay. Now, the question about the postmortem change. Rigor mortis, order of appearance is the options: head to toe, toe to head, central to periphery, periphery to central. So what would be the correct, any correction in this? Shreya Sharma, Pradyot, Ryan. So rigor mortis, as you know, it follows Nisten rule, rule of 12, Shapiro rule, proximo-distal progression. According to standard textbook, rigor mortis, okay, it is from head to toe. So the answer is from head to toe. So it starts with the eyelids, then the face, finally the fingers and the toes. That is known as Nisten rule. According to K.S. and Reddy, page number 118. Head to toe is the correct answer. Okay. Aditya, fine. So this is what we discussed many times in our classes. Rigor mortis follows Nisten rule. The heart, eyelids, neck, face, chest, upper limb, abdomen, lower limb, finally fingers and toes. It disappears in the same way. Okay, question number 4 about the victim of rape examination or evidence in court of law. One more very, very important topic. In court proceeding, especially in recording evidence in victim of rape, sexual assault video had to be presented before court. So what it is known as? Options are open public proceeding, in-camera proceeding, media proceeding, closed proceeding. Can you correct me? Yes, anybody? Shriya Sharma, Aditya? Okay, so court proceeding should be in camera. So this is a simple question asked in your exam. As per 366(2) of BNSS or section 33 of POCSO Act. So the answer is B is the correct answer. The reference taken from K.S. and Reddy, page number 328. Yes, the question was in the, yes, fine. Not public, okay, fine. Finally, answer is in-camera proceeding. That is the correct answer, fine. Now, one favorite question of examiner, seminal stain, very commonly asked, repeat question in FMG as well. In a suspected case of sexual assault, anal swab was collected from the victim. It shows the formation of yellow needle-shaped crystals of spermine picrate. This test is classically known as. Options are Barberio, Florence, Teichmann, Takayama. So the best answer is Barberio. In Barberio, we use picric acid. The picric acid combines with the spermine. It forms spermine picrate crystals. So yellow needle-shaped crystals. So the answer is A. In Florence, you will see dark brown rhombic crystals. Teichmann and Takayama, they are done in case of blood stain. So it is a repeat question from previous year. Barberio is the correct answer. Karthikeyan Jagadishan. Okay. Question number 6. So this is what we discussed in our classes. Yellow needle-shaped crystals, they are seen in Barberio test. Dark brown rhombic crystals, they are formed in Florence test. Right? Next question. Next question. from toxicology. A patient had consumed some unknown fruit, came with the complaints of dryness of mouth, slurred speech, on examination, decreased bowel motility, loss of bowel sounds, delirium, dilated pupil, all go in favor of deliriant. The well-known deliriant is datura poisoning. So the answer is datura. Answer is datura is the correct answer. It is not cocaine. It is not alcohol. It is not cannabis. So datura correct answer because it consists of hyoscine, hyoscyamine, and some traces of atropine. Okay. Any correction in this question? Karthikeyan, Hamid, Ashwini Dokare. Fine. Question number 7. Question number 7 about the MTP Act. A pregnant woman who is a victim of rape came to you for MTP. MTP can be done up to dash weeks as per MTP Amendment Act 2021. Okay, it's a case of rape. So as you know, in case of rape, incest, minor, disabled woman, MTP can be done up to 24 weeks. 24 weeks. So the answer is 24 weeks is the correct answer. One more question asked. MTP Act. A pregnant woman with a 25 weeks of gestation with congenital abnormalities of fetus came for MTP, subjected to approval from medical board. All are the members of medical board except gynecologist, pediatrician, radiologist, and advocate. So we discussed in many times in our classes, radiologist, pediatrician, gynecologist, but it is a medical board, it is not a legal board. So answer is an advocate is the correct answer. Next question, question number 9. The question number 9, it was about the PCPNDT Act. A pregnant mother having 4 female children came to radiologist for USG scan as for determination of sex of the fetus. As you know, it is a punishable offense, determination of sex of the fetus as per PCPNDT Act, Preconceptional, Prenatal Diagnostic Techniques Act. What is the best approach in this case scenario? So refuse to do USG? No, not the best. Inform police? No. Do USG check fetal anomalies and tell sex of the baby? No. The best answer is C is the correct answer. Check anomalies, don't tell about the sex of the baby as per PCPNDT Act. Okay. One option was to do USG check anomaly, does not check this. Okay. Anyway, the answer is C is the correct answer. Question number 10, already discussed in psychiatry class. A male having desire to cross dress, that is wearing female dress, high heels, in order to be sexually aroused. It's a sexual perversion, the well-known sexual paraphilia that is known as transvestism. Transvestism, eonism, cross-dressing, all are very commonly asked question from sexual perversion in forensic medicine. Okay. Fetichism, that is by using inanimate object, not the answer. Proteurism, also known as Thatcherism, not the answer. Exhibitionism, that includes flashing, mooning, streaking, not the answer. The best answer is A. A is the correct answer. And the question number 11 about the age estimation. 18-year-old rape accused claims himself as 16 years of age. For accurate examination of age of the person using fusion of ossification centers, following X-rays joints are used. So knee and wrist, elbow and ankle, shoulder and skull, hip and ankle. Okay. So if this is the question asked, the best is knee and wrist joint. As you know, lower end of femur, lower end of radius and ulna fuses at 18 years. So the answer is A is the best answer. It is not the elbow, not the skull, not the ankle. Knee and wrist is the correct answer. Okay, skull was there, hip and elbow, fine. Fine, okay. So knee and wrist is the answer as per K.S. and Reddy, page number 55. And the last question. A child born after 8 months of father's death. Grandparents filed a case that baby might not their son's child. DNA was ordered. DNA came positive. That is VNTR positive. What do you call a child as? Options are posthumous, fabricated, superfecundation, or superfetation. So what would be the best answer? Amini Chaudhary, Karthikeyan, child born after the death of the father within 280 days. Your answer would be posthumous child. Posthumous child is the correct answer. It is not superfecundation, not the option C, not the fixed child. The answer is posthumous child. So this is about the forensic medicine. There were around 12 to 13 questions asked from forensic medicine, and all these questions from our PW shorts and PW videos. 12 out of 10, I can say the strike rate is 100% in forensic medicine. Thank you.
Thank you, sir. Okay, next will be Dr. Vinesh, and we're waiting for us to join us. Yes, sir.
Sir, ready? Shall I start, sir?
Yes, sir.
Okay, all audible and all. I'll start. Okay, so we'll be starting with the anesthesia questions. Dr. Nitin is asking if recall question PDF will be available. Yeah, we'll try to do that. But first, just finish off the recall. Anesthesia questions were fairly, I will say, average. There were about 6 to 7 questions that we gathered. I'll finish off them fast, right? If there are any questions or the changes in the questions, you guys need to let me know. Okay, so let's start with anesthesia. The first question was a simple one, which we've discussed every time in all the classes. Everyone has discussed this. So identify the adjoining image. And this was the image here. The options given were oropharyngeal airway, uncuffed endotracheal tube, nasopharyngeal airway, and �OA-sapien airway. So �OA-sapien airway is something which is used for intubation. It goes into the airway, and then it is used for that. So this is out of the way. Normally, it's not going to be asked to you otherwise. It's just given as one of the options. So here, what you get to see, the confusion was for people was between the uncuffed endotracheal tube and the nasopharyngeal airway. This was the problem. So this is not an oropharyngeal airway. So these options were, the confusion was between B and C. Remember, this end has no connector. This thing has no connector. So we are using this to prevent the backfall of tongue. This is the nasopharyngeal airway, right? If there are any changes, guys, in the questions or in the options, in the stem of the questions, do let me know so we can see that accordingly, right? So in this question, the correct answer was nasopharyngeal airway. It prevents the backfall of tongue. That's the point, right? So this was the first question from anesthesia, a very simple one. Next one. Okay. This was a question where I think options, these are options that I could gather. If there are any changes, you guys let me know. Plus, there are two ECGs that I've attached over here. And hopefully, the first people that normally said this was the ECG which came, the number one. Normally, some people did say the question number, the second ECG was there. Let's discuss the answers based on that. So a 2-year-old child is undergoing CPR with the adjoining rhythm that you're seeing. What is the next step? Give the shock and then check for pulse. First do CPR and then check for pulse. Continue CPR till the pulse is back. And or the fourth point was first shock and then continue CPR. So the rhythm that you see, if we go with the first rhythm which is there, which most of the students have told us, this is ventricular tachycardia. Okay. So if your patient is having pulseless ventricular tachycardia, the point is you have to defibrillate the patient, defibrillation, right? You have to defibrillate. On the other hand, if this was the option, asystole, right? Flat line. If there is a flat line, remember there is no shock to be given. So let's see the answers. Options were, option had give a shock of 2 joules, correct? Right. In a pediatric patient, normally when you give a shock, you start with 2 to 4 joules per kg. Absolutely correct. And you can go up to maximum 10 joules per kg, right? So this is what is given in pediatrics. Maximum up to 10, you start with 2 to 4. But this was in general, right? So asystole image was not given. So this is out, right? So first one was ECG for sure, right? That is fine. So everyone is saying it is pulseless ventricular tachycardia or ventricular tachycardia image was given. Simple, guys. Whenever there is tachycardia given, the point is you have to defibrillate ventricular tachycardia. So when we are discussing CPR, remember, guys, in the CPR, just give me a second. Okay, so in the CPR, the first step when you do is like first step would be check for the scene safety, right? Then is check. After that, you're ensuring that the scene is already safe. After that, what you have to do is then check for the response. Then you call for help, and after that, you check for pulse and breath, right? So these are the first 4 or 5 steps which you've done. Once you found the breath and the pulse which are absent, is when you're supposed to start with the CPR. You continue with your CPR 5 cycles of 30:2, right? It keeps on happening. Now, when you get a defibrillator, the first thing is to assess the rhythm. So you have assessed the rhythm, and in case the rhythm has come as ventricular tachycardia, you should give the shock. So the only option is between A and D. You will have to give the shock. But the next point is, as soon as you give the shock, remember there is no pulse check. There is no pulse check after you have given the shock. So after giving the shock, straight away continue CPR. So the correct answer is option D, right? ECG was different, says Dr. Ashwini. Synchronized cardioversion is defibrillator? No, synchronized cardioversion is not defibrillator. Synchronized cardioversion is when you are using the R waves and you synchronize your shock. You are synchronizing the shock with the R wave of the ECG pattern. Now, in case the R wave is not clearly visible, and anyways here it's ventricular, when you're saying a pulseless ventricular tachycardia or defibrillation, right? Here you need to defibrillate. You will not be doing a cardioversion. So I'm not very sure if the cardioversion was given the option or not. From what I gathered, the point was to first give shock and to check pulse or not to check pulse. So if you are getting an image of ventricular tachycardia, which is a pulseless ventricular tachycardia, or the next image, if this was not the image, you must have got ventricular fibrillation. So if it's a ventricular fibrillation, which almost looks like this, fibrillation of the heart, so again, in that case, you're supposed to give the shock to the patient, right? And it's not cardioversion ideally. It is supposed to be, if it's a defibrillation, in that case, you are supposed to be giving, it's a ventricular fibrillation, you'll be defibrillating and not cardioversion. So the correct answer is going to be give the shock and then continue for the CPR. That is my take on it. Dr. Nitin says it was fairly symmetric looking rhythm, not like this. So again, right? So this is a polymorphic ventricular tachycardia, guys. What you're seeing here is polymorphic ventricular tachycardia, which is more like ventricular fibrillation. I understand your point. So you are saying you must have got an ECG which looks something like this, right? It looks something like this, right? So this is what is called ventricular tachycardia. So the rhythm is similar. There is no polymorphic. This is what is polymorphic ventricular tachycardia. You are saying that all the waves are coming similar, which is called monomorphic, right? So this is what is called ventricular tachycardia. You must have got an image like this. Even in this kind of an image that you've got, if the CPR is going on, pulse is not felt. In this case, you have to give a shock and do not do a pulse check after giving the shock. Straight away continue CPR. So we stick to the same answer. First, give the shock and continue with CPR. right? Dr. Nitin says monomorphic VT was given. That's what. That's all. Answer remains the same, whether it is polymorphic or monomorphic. If it's a ventricular tachycardia, CPR is going on, you have to give the shock. After that, remember, there is no pulse check. This is the most important thing. Even in adults, forget about a child. This is a clinical thing that you people need to remember if you're doing a CPR anytime in your life. As soon as you give a shock to a patient, do not waste time on pulse check. Immediately continue with the CPR. It's a very good question which has been asked, right? Defibrillator was being used in the question. Atrial fibrillation kind of ECG. So Dr. Navik P says that. Same guys, whether it is fibrillation, ventricular fibrillation or ventricular tachycardia, the answer remains the same. First, give shock and continue with the CPR. So remember, this is exactly what you're going to do for ventricular fibrillation or pulseless ventricular tachycardia. In this, both the cases, you will give the shock and then continue for CPR. But if the rhythm would have been asystole or pulseless electrical activity, these two rhythms, you do not give the shock. So the dying rhythms are 4. There are 4 dying rhythms of a patient, which is ventricular tachycardia and ventricular fibrillation. In these 2 rhythms, you're going to give a shock. In the other 2 rhythms, which is asystole and pulseless electrical activity, you're not going to give a shock. So whether the answer was ventricular fibrillation or ventricular tachycardia, the answer remains the same for us if the image was the same. So it's first shock and continue with CPR, right? So Dr. Nitin says very important for emergencies. Nice question. Yeah, that's what I'm saying. It was a nice question. It was never been asked like this. It's a very nice question which has been asked this time around. Okay, I'm happy with anesthesia. There were a good number of questions from anesthesia, and we had to use our brains this time around, right? From what I know, I still don't know there's so many options what people have told. So you guys will let me know more options. Next question. So this was a question regarding EMLA cream, which they asked after a lot of time. I'm not very sure about all the options which were there. So there are 2 things. Whether they asked you which of the following is correct regarding EMLA cream or which of the following is incorrect regarding EMLA cream. So what students told me, a full form of EMLA was given. So if they've given as a full form as eutectic mixture of local anesthetics, it is a correct statement. Eutectic mixture. It's a mixture of 2 local anesthetics. So in that case, the next point was it's a combination of lignocaine and ropivacaine. No, that is the point incorrect according to me. Because normally what happens is it is 2.5% lignocaine and a combination with 2.5% prilocaine. That is the one which is used for EMLA cream. It is not ropivacaine. So if the question was which is the incorrect statement, in that case, if this option was given to you, which you people can confirm, right? So this is the incorrect statement, according to me. Another thing, it causes methemoglobinemia. Yes. And 1 mg contains 2%. No. So this was again not given. This was IBQ. Methemoglobinemia was given, which seemed correct. Yes, EMLA was not in the question. EMLA was there in the question, guys. EMLA to so many people told me. EMLA was there. So many students told me EMLA cream was there. And that's what I'm saying. About the options, I'm not very sure. So I linked up methemoglobinemia with it because yes, there were some students who said methemoglobinemia was also asked in the question. So remember, if you use large doses of EMLA cream, right? If we are using large doses of EMLA cream, one of the side effects can be methemoglobinemia. So, you know, there is a side effect of local anesthetics, which normally we forget. And that is seen normally with benzocaine and that is seen with prilocaine. So wherever you're using large doses of benzocaine and prilocaine, they are known to cause methemoglobinemia and the treatment for which is IV methylene blue or methyl blue, right? It can cause methemoglobinemia, yes. Now there's a confusion between everyone. So we'll come back with that later on, right? Question asked, pick the correct statement. Correct. So the question they have said, right now just Dr. Param is saying question was asked, pick the correct statement. Okay, so incorrect is out. So in that case, if there was pick the correct statement and if they have given you, it's a eutectic mixture of local anesthetics. In that case, ye dono bhi correct ho jayega, yaar. So one of the options has to be wrong over here, guys, right? One of the options has to be wrong. So if they have given you lignocaine and ropivacaine as one of the options, remember this is wrong. If it is written eutectic mixture of local anesthetics, that is correct. If it was given methemoglobinemia, that is correct, right? And another option, the last one which you people told me right now is 5% contains 50%, right? One second, just give me a second. Where's that gone? EMLA full form was equal and not eutectic. Correct. So if it was correct. Okay, so here I get if it was equal mixture of local anesthetics, right? So again, that becomes the wrong one, as you people said. In that case, the correct answer becomes methemoglobinemia, right? That is according to what Dr. Shuri has said, right? That's what I can see. Fine, guys. So this was one of the questions regarding EMLA cream. They have asked EMLA cream after a very long time. All of these questions have been covered in whatever we have taken the sessions. Everything, even our shorts that we have done, it's been covered, right? EMLA was in the option, not in question. Eutectic, not mentioned. That's what I said. Equal mixture of local anesthetics as one of the options that you people told me, right? So C will be the correct answer. Yes, it can cause methemoglobinemia. Then that becomes the correct answer because lignocaine and ropivacaine, that's again wrong. It's a combination of lignocaine with prilocaine. And that's the recall is all about, right? So we'll come with all those, correct points later on. So we are done with this question. Anything else, guys, put it in the comment box. We'll change the options and then come with a proper recall as we've always said, right? So according to me, the correct answer here is it can cause methemoglobinemia. That is the correct statement. Correct. Okay, right? Fine, going forward. Next one. Okay, so this again has been asked after a very long time regarding PEEP, which of the following is true? I mean, these are the two options which some students told me. So remember, PEEP is positive end expiratory pressure. Positive end expiratory pressure. So it is not a negative pressure. That question is out, right? The other two options, I don't know. But this is the correct answer, which a lot of students told me, and that is it prevents alveolar collapse. The point of PEEP is to, give a positive pressure at the end of expiration so that the alveoli don't collapse, because of which increased oxygenation can take place and more carbon dioxide can come back into the lungs when it has to move out. So therefore, this helps you to decrease the hypoxia by increasing oxygenation. At the same time, it increases gas exchange, right? By which more carbon dioxide will move out. So therefore, that is the importance of PEEP. It prevents the alveolar collapse, because of which hypoxia is prevented. More oxygen will enter inside and also more CO2 will move outside. Okay. So this was about the PEEP, right? Other two options, I'm not sure. So if whatever is there, guys, if you tell me, then we'll add it over here, right? So this was about PEEP. Next question. This was again, again, some students did tell me about this question. A COPD patient on mechanical ventilation suddenly develops hypoxia. On examination, there is a decrease in air entry on the left side of the chest. There's also increase in interthoracic pressure. Probable diagnosis. So I'm not sure about this statement, which was there or not, but a lot of students did confirm about the fact that a COPD patient on mechanical ventilation was asked, and the two options given were pneumothorax, acute exacerbation of COPD. So according to that, guys, the correct answer here would be if there's a decreased air entry on the left side and we don't have the other two options, right? A COPD patient is on ventilator and suddenly is developing hypoxia. It can be pneumothorax, right? If there's any connection, guys, correction in this options, please tell me so we can change it accordingly. But this was the question according to me. And if these are the points which were suggested to me by the students and from the recall that they had, and according to me, then the answer becomes pneumothorax. Yes, anyone? Okay, fine. This question was based on INI-CT also. The same question has been asked in INI-CT this time around, but it was asked for rocuronium, and this time it was asked for vecuronium, right? So instant reversal drug for vecuronium in a patient with normal kidney function. I'm not very sure this was given or not, but some students did confirm it was given, right? So the same question was asked for rocuronium in INI-CT. Here the answer is Sugamadex. If you want an instant reversal, difficult airway, unable to intubate a patient, you have given vecuronium or rocuronium. So remember, Sugamadex is a special reversal agent that was made for rocuronium, especially for rocuronium, but it can also be used for vecuronium. Of course, more for rocuronium, less for vecuronium, but it can be used for vecuronium also when it causes an instant reversal. So you don't have to give neostigmine, right? So this is an instant reversal drug for vecuronium. The answer is Sugamadex if these were the points. Other three options I did not get. So anyone can suggest the other three options? You can. Otherwise, let me take the last one, right? So some students did say about this question also that they had given a fluid image of an IV fluid, and most of them did say that it was Ringer's lactate. Some students also told me that it might be isolite P, which we have all covered in our classes. The complete video series of all these IV fluids also, all the discussions regarding to that, including the mechanical ventilator. If you people have gone through that, you know that ventilation we have discussed completely, PEEP we have discussed completely. We have discussed the ABG changes also in the videos. We have discussed the IV fluids also completely, right? Everything has been discussed, everything, right? But these are the things, which is a simple question. So if the question was regarding Ringer's lactate, guys, remember the sodium is 130 chloride is 109, lactate is 28. If the question given was plasma light, isolite, in that case, guys, the changes between the sodium and chloride will take place. More important, it's the acetate which is present, right? So ideally, most of the students have told me the answer was Ringer's lactate. They got an image of a RL, Ringer's lactate IV flow. So that was according to me in the first session, the questions which have been asked, right? So thank you to everyone and for cooperating, giving me the options. Thank you, sir. So you can take over. This was the anesthesia part from me. And thank you so much, everyone.
So hey guys, next will be Dr. Oshika.
Hi, friends. Thank you, Dr. Ranjit. So I'm sure you guys must be very tired and you want to go to sleep and you just quickly want to finish the recall. So we'll not go into explanations today. I'll just give you the answers. So obviously recall is very recall based. So I don't have exactly how the question was framed या फिर exact options क्या थे. So do tell me along the way if any of the options are incorrect or what the options were. One question that I was absolutely not able to get was there was a question on cervical erosions. So by the time I cover the rest of the questions, if somebody could tell me usme kya tha exactly, we can discuss that as well. So, okay. So the first question was 2 pictures were given and they had asked you the mode of delivery. Now, I believe there were 2 questions. One was where both the twins were cephalic and the second question was where the first twin was cephalic and the second one was transverse. The first one was breech and the second one was transverse or cephalic. Right. And as we have done in class, it does not matter what the second twin is. So T2 does not matter in mode of delivery. Right. So if it is monoamniotic, monochorionic, then we are anyway going for a cesarean. But if it is a diamniotic, dichorionic or diamniotic, monochorionic, then the position of T2 does not matter whether it is cephalic, breech or transverse. The only thing that matters is T1. So if T1 is cephalic, your answer will be a vaginal delivery. Breech, transverse, T2 jo bhi hai can be delivered vaginally. But if T2 is non-cephalic, which means it could be anything, breech or transverse, whatever, in that case, your answer will be a cesarean section. So the first image over here will deliver by vaginal delivery and the second image will deliver by cesarean section. And we have done this in class. Okay, so Dr. Pradyot is saying one was both cephalic and second was first one breech. So I believe this is what the question was and we have already done this in class, right? So first twin position is the one that matters. The next question I believe was a woman delivered 8 hours ago. What is the earliest time for IUCD insertion? So was this the question? So if this was given that she delivered 8 hours ago, what is the earliest time for IUCD insertion? Then the answer is going to be within the first 48 hours after delivery. But if they had just given a woman has just delivered, what is the earliest time for insertion? Then we know the earliest time of insertion is post-placental. This is the first time that you have the opportunity to put an IUD, which is within 10 minutes of placental delivery. Right. And if you miss that time period, then the next one is postpartum, which is within 48 hours. And if you miss even that, then the next opportunity will be an interval insertion, which will be after 6 weeks. After 6 weeks. Remember, there's no property insertion between 48 weeks to 48 hours to 6 weeks due to the simple reason there's a higher chances of infection and expulsion. Okay. So The next one was members of medical board are all except. We have already done this. We need a radiologist, gynecologist, and pediatrician. An advocate is not required. The reason the MTP 2021 Amendment Act came and introduced the medical board was to reduce the hassle of the patients. So definitely no going to the court for patients who have gross congenital anomalies. So this medical board is just for patients who have gross congenital anomalies. So this has also been discussed in class. Now, the next question was a very, very straightforward question. The question was carcinoma cervix extension up to lateral pelvic wall with hydroureteronephrosis. Very straightforward question. This is stage 3B. And we have done this in detail with diagrams in class. This is stage 3B. If it goes up to the lateral pelvic wall, the ureter is bound to get involved and there will be resulting hydroureteronephrosis. Yes, correct, Dr. Shubhraj. Next was, there's a little bit of confusion regarding this. Did they ask you about the parathormone levels in pregnancy, or did they ask you about a patient who was pregnant at 8 weeks and had hyperthyroidism and which drug was to be given? So in case they asked you about parathormone levels in pregnancy, it decreases in first trimester and then it increases. It increases in second and third. But if the question was 8 weeks with hyperparathyroidism, we know that the safest drug to give to avoid teratogenicity is what? Propyl thiouracil. After the first trimester, we can give methimazole, carbimazole, but they cross the placenta, so we cannot give it. We cannot give it in the first. Okay, so the second question is correct. Okay, so we have done this in class also. The drug of choice in first trimester is propyl thiouracil. Okay, moving on. There was another question, which was a para-1 living one lady comes to the clinic with secondary infertility and amenorrhea. Was it both or was it one of the two? Progesterone challenge test is given, that is negative, which means she does not have anovulation, PCOS ruled out, and E+T challenge test given, but that is also negative, right? Which means the endometrium is unreceptive, the endometrium is damaged, which means we are dealing with what? We are dealing with Asherman syndrome. So we know Asherman syndrome, two very common causes. One is multiple DNC and the other one is genital tuberculosis of the endometrium. So the answer will be tuberculosis. I believe a laparoscopic image was given to you just to trick you. So what we see over here is these small granular things that you see. These are TB tubercles. These are pathognomic image. In fact, if you see these tubercles on laparoscopy, you are clinically correct. You are well within your clinical judgment to start ATT for this patient without waiting for a microbiology report. Okay, so this is TB and this has also been done in class. Although it is expected they would give you a hysteroscopy image rather than a laparoscopy image, but the laparoscopy image was also discussed in class. These are the characteristic tubercles that you see in genital TB. Right. Now, I believe this was another question. This is a direct Google image, I would say. So this is endometriosis. And I believe the option that was given was chocolate cyst. So chocolate cyst is a form of ovarian endometriosis, and the chocolate color is due to the degradation of the blood products within the cyst that you can see oozing out over here. Yeah, correct. Okay, so this has also been discussed in class. I think there was another question in which they had asked, there was a patient who came with complaints of vaginal discharge with pain in abdomen, or she had painful vesicles, and one of the two pictures were given. So if anybody can tell me which picture was given and whether the pain was in the pelvis or the pain was in the genital region because of the lesions. Okay, so which picture was given, Dr. Karthikeyan? So this is typically HSV if this was the lesion given to you. So this is typically herpes simplex, HSV2. HSV2. So the first pic was given. Okay. Both images were in different questions. So if you could just frame the questions for me, we could come back to them after. Yeah, okay. So we have also done this in class already regarding the vesicles. Was this a question? POPQ classification is used for what? So POPQ classification is used for prolapse. It is used for prolapse. Was this a question? Okay, both pictures were given in the same question or in separate questions? Okay, so POPQ classification was used for prolapse. I believe there was another question which asked you that, which gave you a picture of the prolapse, and they asked you what are we looking at over here, and they asked you to grade the prolapse. So remember, when we grade the prolapse, the reference point, no matter what classification you are using, it is pretty much either the hymen or the introitus, right? So because it is beyond the introitus, this is going to be at least grade 3. Whether it is grade 3 or grade 4, I can only tell once I'm able to put my hands around the fundus and say, okay, the entire uterus is outside. But just by looking at it, I know this is at least grade 3, and I can see some rugae loss over the upper part. So this is grade 3 prolapse with cystocele. Yeah, so grade 4, not an option. So this is what I'm saying. This is at least grade 3. So the examiner was considerate and did not confuse you between grade 3 and grade 4. The difference between grade 3 and grade 4 can only be made out upon palpation. So what you see over here is it's outside the introitus. So it is at least grade 3. Okay, great. Okay, so this also has been covered in class. I think the next question was in occipito-posterior position, which pelvis is suitable for delivery. So some kids were saying diagrams of pelvis was given. Some kids were saying no diagrams were given. So you can let me know. In either case, the answer is anthropoid pelvis. And in case the diagram was given, this completely circular pelvis is a gynecoid pelvis. This heart-shaped pelvis is android. And this longitudinally oval pelvis is your anthropoid pelvis. So this was the answer. This was the answer. This is platyploid. Seen mostly with face and brow. Diagram was there? Okay. So the one that is longitudinally oval looks like an egg. Matlab, आपका y-axis में जो ज़्यादा लंबा है, that one is anthropoid. Right, android is typically heart-shaped. So face to pubes delivery is seen in anthropoid. OP mein, if we talk about the ones that get stuck and do not deliver, those are seen in android, like your deep transverse arrest and your persistent occipito-posterior, the ones that do not rotate or have incomplete rotation. Okay, so this has also been discussed in class with the demonstration with pelvis and skull. Right, so moving on, another question was face to pubes presentation was mentioned. Okay. Another question was, what is the point of insertion for ventus? This has also been discussed in class. This point is called flexion point. This point is called flexion point, and it is located 3 centimeter in front of the posterior fontanelle and 6 centimeter behind the anterior fontanelle. So I'm pretty sure this would have been in the options. So 6 centimeters behind anterior fontanelle and 3 centimeters in front of posterior fontanelle. All right. So this was also discussed in class when we talked about vacuum extraction. Now, I don't know if this was a question or not, because a lot of kids were confusing grid banaya hua tha, grid banaya hua tha. Was that grid for the POPQ system, or was this also a question which was grid system is used in which cancer? The second image, Dr. Prabjot, it looks like poilocytes, but a lot of viruses look the same. So it can be HSV also. The perinuclear halos, I think you're talking about. So because we study mostly HPV, that is what you recognize poilocytes with, but can be seen in HSV also. Grid and POPQ were the same question. So this was not a question, because I had a lot of kids telling me they were asking which cancer uses grid system. Okay. Now, the next question was, when will you stop magnesium sulfate? So the answer, this has again been discussed in class. Visual disturbance present means impending eclampsia. And this is actually an indication to start magnesium sulfate. So this is not the answer. Knee jerk, if it is absent, that is when we will stop magnesium sulfate. The answer is urine output 60 ml over the last 4 hours. Remember, we are monitoring 3 things for magnesium sulfate. One is the respiratory rate, one is the urine output, and one is the deep tendon reflex, right? And urine output needs to be at least equal to 30 ml per hour. So 60 ml over 4 hours means it is a output of 15 ml per hour, which is less. So magnesium is not getting excreted. This woman is moving towards magnesium toxicity. Respiratory depression, what was the respiratory rate mentioned? So if respiratory rate is high, so you guys are saying more than 18, this is not depression. So we have studied this in class. So respiratory rate needs to be at least 12 per minute for me to be reassured that magnesium is not causing toxicity. In respiratory depression, your respiratory rate will go down, it will not go up, right? So even if respiratory rate more than 18 was given, still our answer is urine output 60 ml over the last 4 hours. All right. Okay. Next question. So again, little bit confused. Some kids told me they had asked PPH agent, which one is contraindicated in hypertension? And there was another, which one is contraindicated in asthmatic patients? Either way, this is a very standard question, being covered multiple times in multiple classes everywhere. So if it is hypertension, it's going to be methyl ergometrin. Right, correct. So it was carboprost. So this was not a question, I believe. Okay, so contraindicated in asthma is carboprost because it causes bronchoconstriction. Either way, this was a simple question that I think most of you would have gotten right. All right. Next question was MTP Act. I think there was either the lady who had come, she was a pregnant minor or she was a rape survivor. Either way, this is a special category where the limit of termination is up to 24 weeks. It is up to 24 weeks. Remember, for gross congenital anomalies, there is no upper limit. For failure of contraception, the upper limit is 20 weeks. And for special categories like these, we can go up till 24 weeks. Correct. Achha, 22 weeks of age. 22 weeks of age. So she is well within the time limit to get an abortion. Correct. So this has also been covered in class. Next question was 30 weeks pregnant patient with tender calf. What will you give for prophylaxis? So what are they talking about? They are talking about a woman with deep venous thrombosis can happen because pregnancy, as we know, is a procoagulant state. So what do we give for prophylaxis? What did you guys mark? Did you mark warfarin or heparin? So some people may have thought that warfarin is safe in, this time period. So let's mark warfarin. But remember, warfarin takes around 5 days to come into effect. And in the beginning, the action of warfarin is procoagulant, right? We need immediate action with heparin, which acts, if it's unfractionated heparin, starts action almost immediately, low molecular weight also almost immediately, just a little later. So DVT is an urgent condition. It is an emergency condition. We can pulmonary thromboembolism ho jayega, tab aayega INR range में. We cannot wait for that. So the answer is heparin, whichever heparin had been given to you. All right. Yeah, correct. So heparin. No, the answer will be heparin. So in pregnancy, we are using either warfarin or heparin. Forget everything else. Just heparin or warfarin till now. Right. So I think the next question was either a 36-weeker or a 37-week pregnant woman who is on warfarin and she comes to you and the question was, what do you do? Do you continue warfarin? Do you change to heparin? Do you change to fondaparinux? So remember, forget everything else. Just remember heparin and warfarin in pregnancy. And anytime after 36 weeks, if this lady comes to you, the warfarin has to be stopped. And after stopping the warfarin, what do? You switch over to heparin. So you change to heparin. Okay, so she's on warfarin because she has a prosthetic valve. Anyway, near about delivery, we cannot have warfarin because this warfarin crosses the placenta. That's why it causes embryopathy, right? It crosses the placenta, causes, a pro-bleeding effect in the fetus also. And if this woman goes into labor or anything, the child is going to have intracerebral hemorrhage. So for that reason, we have to stop warfarin towards the end. Okay. So this has also been covered in class. I think this was also a question, very simple. So this is frog eye appearance seen in anencephaly. Correct? Okay. So this has also been covered in class. Now, a little bit of confusion in this. I think a diagram was given with the question. So what was the question like? A pregnant woman with a history of previous LSCS underwent cesarean for delivery, and intracesarean there was PPH and the placenta could not be removed, leading to a hysterectomy. What is the diagnosis? So was this the question? Was this the question? So Dr. Zuha, no matter what is given, if aortic stenosis was there, for that she went to prosthetic valve replacement. Whenever there is a prosthetic valve, this woman needs to be on anticoagulants. Varna uspe vegetations ban jayenge, clots ban jayega, and that can embolize anywhere, or even the valve can get stuck and cause catastrophic consequences. ठीक है, तो इसलिए हम warfarin देते हैं, but delivery के time थोड़े time के लिए switch over to heparin. ठीक है, तो ये वाला question. Placenta previa was an option. Accreta was another option. So remember, in placenta previa, the placenta separates. So if this was given to you, placenta could not be removed and it led to a hysterectomy, the answer is going to be placenta accreta spectrum. The reason I have put the other picture over here this one is actually cuvular uterus, which is seen in abruption. But a lot of kids were confused कि ये picture डालिए कि ये वाली picture डालिए. So just have a look at this picture. This is the picture of placenta accreta spectrum. What you can see over here is कि lower segment में the placenta is bulging out. The muscles are very thinned out. Right. So I believe it was placenta accreta spectrum, and this question was not given to you. Anyway, अगर आपको images नहीं भी दी होती, so this history is very much suggestive of a morbidly adherent placenta. Okay, so antepartum massive. Okay, during hysterectomy, there was massive hemorrhage. So this is placenta accreta spectrum. Right. So if the placenta could not be ruptured, uterus rupture was also an option. What had they given about the placenta? Placenta के बारे में कुछ बोला था? Had they said anything about the placenta? While removing placenta, she bleeds. So this is the key point. While removing placenta, she bleeds. So अगर uterine rupture होगा, she will present with hemoperitoneum. आपका कुछ placenta will probably be floating inside the abdomen. The placenta will be separated. Again, we need to do a hysterectomy. Remember, for placenta previa and abruption, the placenta separates easily. उसमें कोई दिक्कत नहीं आती है. Key points over here are previous LSES, which we know is a risk factor, for placenta accreta spectrum. Correct? Placenta did not remove and hysterectomy karni padi. Yeah, so this is placenta accreta spectrum for sure, 100%. So this is what it looks like, and this is why we cannot remove it. Aap dekh sakte ho ki the placenta is interdigitating into the myometrial fibers. Correct? Moving on to the next question. I think Manjunath sir has also discussed this. The question was that 4 girl children, this woman already has. She comes at 18 weeks and asks for an ultrasound. What do? So you do an ultrasound. You do not deny her an ultrasound. Aap sab kuch dekh lo, but there is no need to look at the sex, right? So what you do is you do ultrasound for POG anomalies, but not see sex. There is no need to see the sex. Okay, so sex determination is illegal. Okay, I think another question that was given to you was, no, there is no need to see the sex and tell the mother. There is no need to see the sex and tell the mother. We are not routinely looking at the sex in level 2 scans. What is the karyotype of this girl presenting with primary amenorrhea? What do we see over here? This is a bluish bulging membrane, which means what is this? Imperforate hymen. Yes, correct. Dr. Karthikeyan, the answer is, the karyotype is 46XX. 46XX. So this has also been done in class. Another very straightforward question. They had asked you, what is this? This was monosomy X, or XO, which is also known as Turner's syndrome. This was a very, very easy question. Okay. Moving on to the next one. I believe there was a question, what prevents polyspermy? What were the options given to you? Was this a question? See, Dr. Good Moment's antepartum hemorrhage can be present in placenta previa also, abruption also, in placenta accreta spectrum also, because placenta accreta spectrum के साथ invariably placenta previa होता है. All 3 are causes of your antepartum hemorrhage. So that does not change the answer. What changes the answer is कि placenta separate नहीं हो रहा था. Placenta previa में placenta easily separate हो जाता है. आपने देखा होगा, whenever we are doing management of placenta previa, we do LSES. We never write hysterectomy. But when we talk about placenta accreta spectrum, it almost invariably ends up in a hysterectomy because the placenta does not separate there. Right? Okay. Acrosome reaction. So acrosome reaction is a reaction at the level of the sperm that does not prevent polyspermy. There are only 2 things that prevent polyspermy, and we have done this in class. One is the zona pellucida. And once the sperm crosses the zona pellucida, then there is a cortical reaction. So it will be one of the 2, whichever was given to you in the options. Yes, correct. So this changes. Cortical was given and membrane potential of oocyst membrane, they are correct. So the cortical reaction is basically what is causing the depolarization of the oocyst membrane. So if this was in the options, this is the correct answer. Okay. So that brings us to the end of the recall. Just 1 minute, there was a question on cervical erosions. So I believe the question was, the patient presents with cervical erosions and what will you do next? So if she presents with cervical erosions, I think there were some options that said Hep B and Hep C and HSV. All of that is not to be done. So what do? We actually do a pap smear plus HPV, which is called co-testing, If they were Dr. Srihari, even if that is what I'm saying, antepartum hemorrhage means that after 20 weeks and before the delivery of the placenta, the patient is coming with bleeding, which can happen in placenta previa also, abruption also, and placenta accreta spectrum also. In all three, it can happen, right? So that is common between all three. But what is uncommon between these are that placenta will not separate in placenta accreta spectrum. When you try to separate it, there is no plane of separation. So there will be uncontrollable bleeding. And to save the life of the mother, there has to be a hysterectomy. So if you want, I can take a class on YouTube on morbidly adherent placenta later, right? But for the purpose of the discussion, the answer is this. With all the information that I have been given, I'm 100% sure that this is the answer. Okay. All right. So liquid-based cytology. Okay. So Dr. Nitin is saying there was a 46-year-old with spotting, and she has cervical erosions. And what were the options given? What were the options given? Dr. Scalpel, yeah, so 27-week MTP done for congenital anomalies means we are dealing with the medical board. Medical board has obstetrician, gynecologist, pediatrician, and radiologist. There is no need for anybody from the court. ये 2021 amendment लाया ही इसलिए गया था ताकि लोगों को they don't have to run around to the courts to get a termination. So medical board is present within the hospital. Within 1 or 2 days, they give the verdict whether this is to be conducted or not. Right. So there is no need for an advocate or a legal counsel. So liquid cytology, HPV plus PAP. Was there any question? Okay. So Hep C is not to be done. So PAP, HPV, cervical biopsy seems to be the most correct answer over here. Most correct answer over here. Ma'am, in the image, there was a uterus and the placenta was there at the lower end of the uterus, and it was completely separated from the uterus. Okay, so if you guys can just find, like the closest Google image and send it to me, then maybe, of course, this is a recall-based answer. Maybe obviously that the image that they gave may have been different from whatever I have put here. That is from my own clinical experience. Some of them. So just let me know whatever you find. And of course, if the question was different, then the answer could also have been different. But to the best of my abilities, I have given a recall. And if there have been any mistakes or any options have been missing or they need to be paraphrased, then do let me know so that I can come up with a better recall that has a better explanation and, is more nuanced. All right. So it was not completely separated. I believe that was what was given in the question. That's what most people said. So that's it for OBGY. Over to you, Dr. Ranjit. Thank you.
Thank you, Dr. Oshika. Next, we'll have Dr. Siraj. Yes, over to you.
Hello. Started, are you?
Yes, sir.
All right. Hi, guys. Since it's already very late, what are the important question of pharmacology that has been asked in our morning slot of this NEET PG 2024? Let us quickly see. And the very first question that I'm having for the day is about a pregnant female, 36-week gestation, was on warfarin therapy. And this is something that has been asked a couple of times already. This is not the first time they have asked. This question they have asked in the previous examinations as well. Like, for example, they have asked this similar kind of question in FMG examination as well, that in 36 weeks of pregnancy, what will you do? To switch back to heparin is something that you are going to do. There is no point of continuing warfarin, because warfarin, according to your American College of Cardiology guideline, according to this guideline, we are always going to utilize for 1 to 12 week, we are going to utilize heparin. We need stronger anticoagulant in the second trimester. So we will be starting from 13 to 35 week, we'll be continuing with the warfarin. And in around 36th week, we are going to switch back again to low molecular weight heparin or your unfractionated heparin. All right, so you are going to shift back again to heparin in this question that we have. Next is, which of the following SNRI is used in ADHD? Let me see this session so that I can have your comments as well. All right, now SNRI, they are asking here, which is the SNRI that is used. They have not asked which is the drug that can be used. Undoubtedly, we can use drugs like methylphenidate. Methylphenidate is the drug of choice, no? Modafinil is a CNS stimulant, but they are asking which is the SNRI that have got approval. Please remember, the SNRI that has got approval for the treatment of ADHD is going to be your atomoxetine. Reboxetine is something that is also having SNRI property, serotonin noradrenaline reuptake property. Reboxetine, it can be utilized in major depression. It can be utilized in the major depression. Atomoxetine is the correct answer for this one, not methylphenidate, because they are asking SNRI, serotonin noradrenaline reuptake inhibitor. Then there was another question, which of the following drug is used in the treatment of multiple myeloma can lead to reactivation of herpes zoster? In fact, reactivation of herpes zoster is very common with this drug that we are having, that is bortezomib, which is currently considered as the drug of choice in a patient with the multiple myeloma. Bortezomib is one of the proteasome inhibitor. It is one of the proteasome inhibitor. It is the drug of choice. And remember, it is going to interfere with the T cell activity. Because it is interfering with the T cell activity, it can actually lead to herpes zoster activation. And therefore, as a prophylactically, we are going to add valcyclovir whenever we want to start this drug. Whenever we want to start this drug, we are going to start. We are going to add valcyclovir as a prophylactic agent. Okay? Which of the following is the mechanism of action of clopidogrel? So clopidogrel is one of the P2Y12 inhibitor. या तो option में P2Y12 inhibitor होगा, which is one of the receptor for the ADP. So saying ADP inhibitor or P2Y12 inhibitor is same. Now other option here could be, let's say, thromboxane A2 inhibitor or any kind other option. But remember, P2Y12 is the correct answer that is going to be for this question. Which of the following is used in the treatment of opioid dependence? At any point of time, if you guys feel that questions were little different या question के option थोड़े अलग थे, तो you guys can actually message this. Which of the following drug is used in the treatment of opioid dependence in the maintenance phase? Opioid dependence के therapy के लिए always remember, first and foremost, we utilize methadone substitution therapy. Methadone substitution therapy. ठीक है, मेथाडोन सब्स्टिट्यूशन थेरेपी. और इसके बाद से वंस द एमएसटी मेथाडोन सब्स्टिट्यूशन थेरेपी इज डन, देन इन द आफ्टर दैट टू प्रिवेंट द रिलैप्स, we actually add the drug. To prevent the relapse, we actually add the drug that is known as your naltrexone. Do you guys know that naltrexone is one of the opioid receptor antagonist? It is one of the opioid antagonist, naltrexone. इसी का एक और drug है naloxone, which is a IV drug that is going to be given as an antidote of opioid poisoning. But यहाँ पे ये पूछ रहा है opioid dependence maintenance phase. Opioid dependence maintenance phase. So we are going to use a partial agonist of opioid that is known as your buprenorphine. Buprenorphine is one of the partial agonists that can be actually utilized in the opioid dependence के maintenance phase में. A child presented with the emergency with iron poisoning. This is something I believe has already been covered in forensic as well. But Examiner this time did not ask because iron poisoning तो बार बार पूछता है. इसके पहले पूछा था कि IV एक child है who has already let's say consumed 20 or 30 tablets of iron. What will you do? So in that case scenario we can use deferoxamine. अगले एग्जाम में पूछा there is a patient of recurrent blood transfusion and what is the oral drug that will be given. तो उसमें था आपका deferasirox या deferipron. But this time they have changed the same topic and different question. Deferasirox, deferipron, same. इसमें अब पूछा कौन सा नहीं देंगे. So see calcium carbonate, magnesium containing drug और calcium carbonate they can be utilized. They will inhibit the absorption. है ना? Antacid जो containing antacid that contain calcium carbonate or magnesium they can be utilized. In this case scenario, the one that is going to be avoided is going to be your BAL. British anti-leucite will be avoided in iron poisoning because they form a nephrotoxic compound. Loading dose is dependent on. Now loading dose किस factor पे dependent है? Always remember, loading dose is going to be dependent mainly on the volume of distribution. If the volume of distribution is high, loading dose will definitely be high. Always remember, volume of distribution कभी भी high होगा, so we always give loading dose. In that case scenario, loading dose is going to be required. So volume of distribution matlab the majority of the drug are going to the tissues. If the volume of distribution is going to be high, loading dose will be required. So the factor that is going to decide in this case scenario is going to be volume of distribution. First trimester pregnancy में what is the antithyroid drug of choice? I think antithyroid drug of choice in the first trimester pregnancy is actually going to be propylthiouracil. And previously also they have asked this second, third trimester में we can actually utilize methimazole. Remember, this will be actually avoided in the first trimester because in one of the 2021 INICT they have asked why it is avoided. They have given actually an image that which of the following condition it can lead to, or which this shown condition is caused by which drug. So they are actually associated with scalp defect, जिसको नाम दिया जाता है aplasia cutis. Scalp defect that is given the name as a aplasia cutis. ठीक है, aplasia cutis. What is the mechanism of action of aprepitant? Aprepitant, rolapitant, netopitant, P-ka antagonist. They are all P-ka antagonists. They are the drug of choice for chemotherapy-induced nausea and vomiting. That is known as your delayed nausea and vomiting. Chemotherapy-induced delayed nausea and vomiting के लिए this is the drug of choice. They are the substance P antagonist, also given the name as the NK1 antagonist. Substance P antagonist, NK1 antagonist. इसके पहले क्या पूछा? पूछा पेशेंट को कीमोथेरेपी दिया गया, आप कौन सा ड्रग यूज करोगे? तो यू विल बी यूजिंग ondansetron. फिर पूछा पेशेंट को कीमोथेरेपी दिया गया, व्हाट ऑल ड्रग्स कैन बी यूज? तो ऑप्शन में था NK1 एंटागनिस्ट, स्टेरॉइड एंड ondansetron. तो तीन ड्रग के ऑप्शन थे सेम टॉपिक पे. व्हाट आई एम ट्राइंग टू एक्सप्लेन हियर कि सेम टॉपिक पे क्वेश्चन एग्जामिनर आ रहा है. अब इसमें पूछ लिया कि ठीक है भाई एप्रेपिटेंट है, क्या मैकेनिज्म ऑफ एक्शन है? सो दे आर मेनली द NK1 एंटागनिस्ट. ठीक है, NK1 एंटागनिस्ट. अगर हाइपोथायरॉइड स्टेट का पेशेंट था तो विल कंटिन्यू टू गिव द थायरोक्सिन सप्लीमेंट जो हम जनरल पेशेंट को देते हैं. द ओनली थिंग दैट वी आर गोइंग टू डू, वी आर गोइंग टू इंक्रीज द डोज बाय 25%. नाउ कैफीन का मैकेनिज्म ऑफ एक्शन फॉर इंक्रीजिंग द wakefulness. कैफीन एक्चुअली इज एडेनोसिन A1 receptor antagonist that is maintaining the wakefulness. Now this question we could not get the option here. Mechanism prophylaxis of DVT. DVT का क्या क्या prophylaxis है? तो अगर इसके ऑप्शन अगर आप बता सकते हैं तो प्लीज लेट मी नो द ऑप्शन. वी कैन डेफिनेटली हैव अ डिस्कशन ऑन दैट DVT के लिए, बिकॉज व्हाट ऑल ड्रग्स दैट वी कैन यूज यूटिलाइज फॉर DVT विल बी एंटीकोगुलेंट्स लाइक लेट्स से ओरली. अगर हम प्रोफिलैक्सिस के लिए बोल रहे हैं तो वी कैन यूटिलाइज ड्रग्स लाइक वारफरिन. तो ऑप्शन में था कि नहीं वो आप देख लीजिए, एक बार बता दीजिएगा प्लीज. Which of the following drug inhibiting the conversion of plasminogen to plasmin? Now plasminogen to plasmin, student said कि सर लंबा फ्लो चार्ट था, but ultimately what they asked कि plasminogen to plasmin ये जो conversion हो रहा है plasminogen to plasmin, who is converting this plasminogen to plasmin? देखिए usually क्या होता है, this plasmin is going to do what? There is something called tissue plasminogen activator. I think plasminogen to plasmin will be done by your tissue plasminogen activator, right? Tissue plasminogen activator. So was this question like this? Plasminogen to plasmin इसको एक्टिवेट करता है टिश्यू प्लाज्मिनोजन एक्टिवेटर. TPA is going to activate, but पूछा इसमें कौन सा इनहिबिटर होगा? तो इनहिबिटर विल बी योर अमाइनो कैप्रोइक एसिड, इसको पूरा नाम होता है एप्सिलॉन अमाइनो कैप्रोइक एसिड, एप्सिलॉन अमाइनो कैप्रोइक एसिड। ऑलराइट, दे हैव ऑलरेडी आस्क्ड दिस क्वेश्चन इन प्रीवियसली एज वेल, प्रीवियस एग्जामिनेशंस में भी ये क्वेश्चन पूछा हुआ है, ठीक है। A preferred agent in a patient with the dementia and urinary incontinence. Dementia and urinary incontinence. Now यहाँ पे जो tricky है, dementia है, that means this is a case of Alzheimer's disease. Possibly this is going to be a case of Alzheimer's disease. और उसको urinary incontinence हो रहा है. तो urinary incontinence में we are going to use anticholinergic drug. We all know the anticholinergic drugs are going to be drugs like your solifenacin, oxybutynin, फ्लेवोक्सेट, फिसोटेरोडीन, ये सारे ड्रग हम यूज करते हैं। फ्लेवोक्सेट, फिसोटेरोडीन, बट डू रिमेंबर दे आर ऑल एंटीकोलिनर्जिक ड्रग। डोंट यू थिंक दैट दिस एंटीकोलिनर्जिक ड्रग कैन एक्चुअली वर्सन द अल्जाइमर डिजीज? इसलिए हमें यूज करना है ट्रोस्पियम, बिकॉज ट्रोस्पियम एक्चुअली इज अ क्वाटरनरी अमाउंट, इट्स एक्चुअली अ क्वाटरनरी कंपाउंड, and this quaternary compound actually a quaternary amine compound, this quaternary amine compound, it actually do not cross the blood brain barrier, it does not cross the blood brain barrier, and therefore trospium is something that is going to be safe in Alzheimer's disease patient. We have covered this previously in our classes as well multiple times. Which of the following is the diuretic of choice? Hypertensive patient with renal stone. See, calcium stone, we already know that loop diuretic actually cause loss of calcium. So loop diuretic is something that is going to be contraindicated in already calcium oxalate stone. Loop diuretic contraindicated because they themselves are promoting more and more loss of calcium. So excess calcium will be coming to the renal parenchyma and they can increase the renal stone. ठीक है? तो यहाँ पे the diuretic that we are going to prefer here is given the name that is thiazide diuretics because they will inhibit the calcium loss. Dr. Mimi is saying this is not prophylaxis, sir. Pregnant lady was diagnosed with DVT. Okay, so in that case scenario, I would like to have the options. Definitely we can comment on that. A drug contraindicated in asthma patient. Again, this is a PYQ previously asked question in NEET PG as well and FMG examination as well. And they have also asked this question in the previous AIMS examination. Drug contraindicated in asthma patient. We know that the drug that is contraindicated, carboprost, they are one of the PGF2 alpha analog. And they are also going to increase the bronchoconstriction. And they will also be causing smooth muscle contraction and that can also lead to your bronchoconstriction. Okay. Drug reducing mortality in chronic congestive heart failure. If this question was asked, I think I used to tell you that आपको 4-pack वाला apps बनाना है. 4-pack वाला apps का मतलब क्या हुआ? That we are going to use ACE inhibitor, 4-pack apps. ACE inhibitors, 4-pack apps रहेगा तभी तो mortality कम होगी है ना? Then we are also going to use ARBs. We are also going to utilize aldosterone receptor blocker like your spironolactone. We are going to utilize ARNI, which is a combination of ARB plus neprilysin inhibitor, ARB. And next is going to be beta blocker. Remember, cardioselective beta blocker we are going to utilize. तो cardioselective beta blocker, some students said कि सर propranolol था, कई बच्चे बोले सर bisoprolol था. तो in that case scenario, we'll be going ahead with the bisoprolol अगर option में था because that is the only one that is cardioselective beta blocker. SGLT2 inhibitor like empagliflozin. तो अगर bisoprolol और propranolol दोनों था तो I think we will go ahead with the cardioselective beta blocker that is known as your bisoprolol. तो 4-pack वाला apps, I think we already know this one. 4 packs यानी 4A then B and S. 4-pack वाला apps, they will reduce the mortality. तो अगर bisoprolol option में था तो I think we don't need to go anywhere else. We are going to see this one. अब इन सब में the best कौन सा है? Best outcome current study said अगर single best drug देखना है तो single best drug is going to be ACE inhibitors that are going to. But overall, because ARNI is a combination of ARB and neprilysin inhibitor, ARB and neprilysin inhibitor like sacubitril, so ARB like valsartan and neprilysin inhibitor. So इन दोनों का combination overall सबसे best result है. Although they are a combination of both drugs. लेकिन अगर एक कोई single drug देखना है तो that is going to be ACE inhibitors. बेटाक्विलिन का क्वेश्चन कितनी बार आ चुका है? बी फॉर बेटाक्विलिन. अब इसमें क्या क्वेश्चन आया था? आई एम नॉट वेरी श्योर, वी हैव नॉट गॉट आंसर, बट आई जस्ट गॉट कि सर बेटाक्विलिन वाला क्वेश्चन आया. तो देखिए इसमें या तो ये क्वेश्चन आया होगा मैकेनिज्म ऑफ एक्शन. एग्जामिनर के माइंडसेट को समझना। मैकेनिज्म ऑफ एक्शन का क्वेश्चन आया होगा, तो बी के बाद बी से पहले आता है ए, तो मैं बोलता हूँ इट इज वन ऑफ द एटीपी सिंथेज इनहिबिटर। या तो एग्जाम में वर्ड होगा एटीपी सिंथेज इनहिबिटर या होगा एडिनोसिन ट्राइफॉस्फेट सिंथेज, दोनों में से कोई एक होगा अगर इस पे पूछा है तो। अगला क्या पॉसिबल एमसीक्यू हो सकता है, इसके साइड इफेक्ट विच कैन कॉज क्यूटी प्रोलॉन्गेशन, इट कैन कॉज हेपेटोटॉक्सिटी, इट कैन इवन लीड टू इलेक्ट्रोलाइट imbalance. Next possible MCQ could be their important pharmacokinetic property. Remember, this is having one of the high volume of distribution, and because of that high volume distribution की वजह से इसका T half life is going to be relatively longer. Apart from that, कहाँ पे यूज करेंगे, तो बेडाक्विलिन बच्चे इसको हम यूज कर सकते हैं MDR ट्यूबरक्लोसिस के लिए, एंड वी कैन ऑल्सो यूटिलाइज देम इन XDR ट्यूबरक्लोसिस के लिए। ठीक है, MDR ट्यूबरक्लोसिस, XDR ट्यूबरक्लोसिस। तो बेडाक्विलिन के 4 क्वेश्चन क्या बनते हैं, एक एग्जाम में ये पूछा, एक एग्जाम में साइड इफेक्ट पूछा, एक एग्जाम में ये पूछा। ठीक है, अगले एग्जाम में क्या पूछेगा, बी पॉल रेजिमेन क्या होता है, ऑल द ड्रग्स आर पार्ट ऑफ बी पॉल रेजिमेन, बेडाक्विलिन प्रिडोमिनेंट लाइनोजोलिड। ट्राई टू अंडरस्टैंड द माइंडसेट ऑफ द एग्जामिनर। Patient consumes some unknown fruit, presented with dryness of mouth, dilated pupil, fruit, है ना। तो try to look for the 2023 NEET PG, उसमें सेम क्वेश्चन आया था कि एक बच्चा था, खेल रहा था, अननोन फ्रूट खाया, व्हाट इज द पॉइजनिंग एंड व्हाट इज द एंटीडोट। तो उसमें दो ऑप्शन में थे, उसमें भी था दतूरा, फाइजोस्टिगमिन वाज द करेक्ट आंसर। इस समय एंटीडोट को हटा दिया, सेम क्वेश्चन को दे सेड व्हाट इज द पॉसिबल डायग्नोसिस, सो दतूरा। एंड इसका ट्रीटमेंट क्या होगा, यूजुअली वी कैन यूटिलाइज फाइजोस्टिगमिन। See, organophosphate is not possible because organophosphate actually is an irreversible acetyl cholinesterase inhibitor. There will be too much cholinergic symptom, too much of the cholinergic symptom. Cocaine, ध्यान रखिएगा, cocaine, it is one of the inhibitor of the, again fruit का intake है, unknown fruit, है ना, it is one of the inhibitor of the norepinephrine transporter. There can be cardiac symptom, increase in the heart rate, increase in the blood pressure. There can be mydriasis as well, but again ड्रग ऑफ अब्यूज में आएगा, नॉट इन फॉर्म ऑफ फ्रूट। और एल्कोहल पॉइजनिंग तो अगेन इज नॉट अ फ्रूट, वो तो ऑटोमेटिकली रूल आउट हो गया। अगर फ्रूट नहीं भी मेंशन है, कंज्यूम सम अननोन प्लांट प्रोडक्ट होगा, फ्रूट नहीं था तो क्या वर्ड था, प्लांट प्रोडक्ट हो सकता है बच्चे, प्लांट प्रोडक्ट हो सकता है, दैट कुड बी द वन। ठीक है, but again the answer given these options, the answer is already mentioned here, datura poisoning for all of you. So these are the some of the important, I think 18-19 question I got from pharmacology from session 1. I hope I was able to do justice to this question, but remember we have to rush for this one. But in upcoming days, in the coming week, we will be having a more detailed and more detailed discussion of all the question with 4 option. ठीक है, I will see you guys in my upcoming class, or maybe tomorrow also we will have a part 2 का recall, उसमें भी we will meet each other. Thank you very much to all of you guys. Ranjit sir, over to you. बेटाक्विलिन इज यूटिलाइज इन मल्टी ड्रग रेजिस्टेंट टीबी। बच्चों ने बोला कि सर इसका इंडिकेशन अभी आपके ही फ्रेंड्स ने बताया कि कहां पे यूज करेंगे, तो मल्टी ड्रग रेजिस्टेंट टीबी, या तो एमडीआर टीबी या एक्सडीआर टीबी।
Hi, sir.
Hi, sir. Yes, I am done. I think the next faculty might be waiting.
Yeah, yes, sir. Thank you, sir.
Yes, sir. Thank you very
Next
much.
will be Dr. Sarath Balaji, sir. Sir, can you come online? Sarath, sir.
Ranjit, can I start? Or
Yes, sir.
okay, done. Right. Hi, everyone. So let me start about pediatric questions right now. Windswept deformity, tooth abscess, calcium normal, phosphorus normal, low PTH, alkaline phosphate high, and the picture given is windswept deformity. Remember, in all causes of rickets, parathyroid hormone will be very, very high. The only condition in which parathyroid hormone low is hypophosphatemic rickets, because parathyroid hormone will be secreted in response to low calcium and not low phosphorus. So this is a case of hypophosphatemic rickets. There is no doubt in that. Second question. So I could not get the stem or the choices. so far. But as far as the discussion is concerned, whenever you get multiple cystic spaces in one part of the lung and there is a mediastinal shift to the other side, particularly if it is an young infant with a persistent complicated pneumonia, you need to think in terms of CCAM, congenital cystic adenomatoid malformation, or congenital cystic pulmonary malformation. Whenever you have multiple cystic lesions which moves the mediastinum to the opposite side. I don't know what is the exact options given. This is the second one. And most often this question gets repeated again and again in the past 2 or 3 years. What is the following anomaly? But some of them are confusing with respect to omphalocele and gastroschisis. Remember, this is nothing but a case of bladder extrophy. There is poor formation of anterior abdominal wall. The next one, and what is this? Investigation of choice in a case of posterior urethral valve. Remember, majority of them have been opting for ultrasound. It is not so. The investigation of choice in any case of posterior urethral valve, particularly when a boy presenting with poor urinary stream, you need to suspect posterior urethral valve. The investigation of choice is, you can say, choice is micturating cystourethrogram or vesicocystourethrogram, and it is not ultrasound. Right. The next question, and this is often done and dusted. 6-week-old boy with repeated vomiting after feeds. You all know, whenever any boy child in and around 4-6 weeks of age, when presenting with multiple episodes of non-bilious vomiting along with hypochloremic, hypokalemic metabolic alkalosis, the only diagnostic option is hypertrophic pyloric stenosis. But for this surgical condition, ultrasound abdomen is more than enough, and the pathognomonic sign given is palpable oval mass. And but I could not get a proper picture regarding this. But as far as the discussion goes, whenever you have multiple tissue growths in a single picture, look at this. You have lymphoid growth, you have genital growth, you have neural growth, and you have skeletal growth. And each and every tissue differs with respect to the age and maturation. Whenever you have a graph with multiple growth components of the body depicting in a single graph, this is called Scamon's curve. This is called Scamon's curve. Right? Then comes ADHD. What is the treatment of option for ADHD? Remember, you all know that the treatment of choice for ADHD is methylphenidate, stimulants, amphetamines, methylphenidate. But make sure that the child is not having any underlying cardiac illness. In the presence of underlying cardiac illness, or methylphenidate resistant ADHD should be treated with atomoxetine, a norepinephrine reuptake inhibitor. And this question with regard to the timing of surgery of cleft lip, and I don't think they have asked a cleft palate. The timing of surgery of cleft lip is 3 months of age, and it is modified Millard's rotation advancement technique. And as far as the cleft palate treatment is concerned, the treatment is palatoplasty, and it should be done before 1 year of age. The exact months is not given even in the standard textbook Nelson. As far as cleft lip is concerned, 3 months is mentioned. Whereas cleft palate, it has to be done before the first birthday. And what is this? An 18-month-old infant with a hepatosplenomegaly, anemia, and WBC count of 50,000 along with petechiae. So 3 cell lines are involved along with hepatosplenomegaly, and unless otherwise proved, it is a case of acute lymphatic leukemia. As far as the treatment is concerned in acute lymphatic leukemia, the first 4 weeks mainly concerned with remission induction with the help of 4 drugs. The most common used drugs are vincristine and prednisolone. And at times you can use L-asparaginase. And in high-risk cases, such as T-cell, a WBC component is too much, CNS involvement, everything, you can add downomycin. So as far as the option goes, the combination of vincristine and prednisolone matters. So if I think the option contains a combination of vincristine plus prednisolone or dexamethasone, it should be the option of choice in a case of acute lymphatic leukemia for remission induction. Central adrenal insufficiency management. You all know that whenever you have adrenal insufficiency, you need to give both glucocorticoid and mineralocorticoid. Glucocorticoid, hydrocortisone. Mineralocorticoid is fludrocortisone. But this is a central adrenal insufficiency. For central adrenal insufficiency due to pituitary issues, most common cause septo-optic dysplasia. In this condition, the ACTH induced action on the glucocorticoid will not be there, as a result of which the only problem is cortisol deficiency and not aldosterone deficiency. So any child with central adrenal insufficiency should be managed with lifelong hydrocortisone. There is no need to give fludrocortisone. Dexamethasone is long acting, so we often avoid. Best investigation of choice for Wilson, even though the screening test is serum ceruloplasmin, the investigation of choice is hepatic copper content, more than 250 microgram per gram of dry weight of liver. What is this? Anemia, hepatosplenomegaly, bone pain, and one picture with the crumpled tissue paper appearance. You all know that it is a case of Gaucher's disease and due to glucocerebrosidase deficiency. Villus atrophy, crypt hyperplasia, skin rash. Remember, the most common cause for malabsorption or chronic diarrhea in children, particularly in India. Less than 5 years and more than 5 years. Less than 5 years, the most common cause is cow milk protein intolerance, which is characterized by the presence of eosinophils in the crypts. Whereas the most common cause for malabsorption or chronic diarrhea in children more than 5 years, particularly in North India, is celiac disease, in which it is caused, which is characterized by total villus atrophy along with the crypt hyperplasia. And the screening investigation of choice is IgA or IgG transglutaminase. And if it is negative, an anti-endomysial antibody can be done. Again, failure to thrive 2 kgs, weight loss, no parasite in biopsy, patient advised to gluten-free diet, and you all know that it is nothing but a case of celiac disease, no doubts in that. Which of the following is harmful immediately after delivery? Eye care, yes, you do give. Skin-to-skin contact, you do give. Breastfeeding, yes, immediately after birth, particularly within 30 minutes after birth when the child is active. All these things are mandatory, whereas bathing baby with the warm water immediately after delivery is not recommended. And with respect to this conjunctival suffusion, next question. Remember, bulbar conjunctivitis can take place in both dengue as well as leptospirosis, and also your retroorbital bone pain can happen in both dengue and leptospirosis. But if there is an associated myalgia along with an exposure to rice paddy field something, then the diagnosis of choice must be leptospirosis. And we would be happy to get what is a good stem with respect to each and every question, and what are all the good, what are all the options that is given in the paper. So thanks for the patient listening. I think it is over from my side, Ranjit. Thank you.
Thank you, sir. We'll be having Dr. Murugan for PSM next. Over to you, sir.
Hi, Ranjit. Am I audible?
Yes, sir. Yes, sir.
Okay, fine. So, hi, guys. Okay, so I think it's very late. Okay. So how many questions came from this subject? I think with overlap, we can say some around 15 to 18 questions. Okay, with other subjects. Okay. So with overlap, 15 to 18 questions with other subjects we may have. Now, so let's go quickly, guys. Okay, quickly. Okay, what is the answer for this? The following logo is associated with, okay, which program? Okay, it's a straightforward question. I think hope all of you have done this. What is the answer for this question? Yes. So you are saying is right. This is National Leprosy Eradication Program. Okay, fine. They initially started as control program, now eradication program. Okay, fine. What is this full form of JSSK program? Next question, guys. Okay, next question. What is the full form? Full form of JSSK. Yes. Okay, this is Janani Sishu Suraksha Karyakram. Who is the beneficiary here? Okay, so we have two people, pregnant women and women in and sick infants. So everything is free, is given to them, guys. Okay, so you're giving things free to them. Okay, right from transport, everything you're giving free. Okay, so hospital, OPD, okay, blood, everything you're giving free. This is JSSK, Janani Sishu Suraksha Karyakram. Fine. What is this instrument, guys? Okay, what is this instrument? What is the use of this instrument? Okay, fine. Yes. So this instrument is called as Carter's thermometer. Okay, Carter's thermometer. What is the use of it? Yes. Yes. So this instrument measures, basically it measures the cooling power of air. No, it measures the cooling power of air. Carter's thermometer. Okay. So all these three things together, okay, they join only form the cooling power of air, guys. Air velocity, humidity, air temperature, all these three things together. Okay, air velocity. What else was there? Okay, what else was there? The option, no problem. No problem. Anyway, answer is cooling power. Anyway, answer Carter's thermometer means answer is cooling power, guys. Okay, no issues. Air velocity. Actually, Carter thermometer measures low air velocity. It measures. Fine. Fine. What is the source of thiamine? I think already sir has discussed this. Okay, it overlaps with biochemistry also. So what is the session 1, guys? We are discussing session 1. What is the source of thiamine? This is B1. Okay. So thiamine, the main source is what? Okay, main source is rice and wheat, guys. Okay, rice and wheat. They are the main source. Okay, so to maintain the quality, we are doing this parboiling. Okay, parboiled. Parboiled rice maintains the thiamine content there. Okay, if we have deficiency, it goes to beriberi, guys. Beriberi, discussed in class. It's a straightforward question. Okay, find the median for the following numbers. What is the median? Median means what? Yes, middle value, guys. Okay, middle value. Okay, so you arrange the data in either ascending or descending order. So we have even numbers are there. Okay, 8 numbers are there. So we have to add the two middle values. So you are going to add the two middle values. Okay, it's there in the class notes also. It's very easy. Anybody can do it. Divided by 2. Answer is 4.5, guys. Okay, 4.5. 4.5. Okay, add the two middle values divided by 2, guys. Fine. Next question. What does the green line? Okay, maybe color would have given differently. Okay, the question is, the concept is same. What they are asking is, okay, in the demographic cycle, okay, this is the transition model. What does this line correspond to? Maybe other color they would have given. Okay, what does this correspond to? Okay, so the demographic cycle is based on crude birth rate and crude death rate. Okay, so what is this line? Yes, this line corresponds to death rate, guys, death rate. Okay, so death rate, high stationary, early expanding, It started declining. So late expanding, both are declining. Okay. Then later on, what happens? Okay, declining phase, death rate is more than that of birth rate. Okay, fine. Yes. What is this MCH indicator? Okay, the question was this. Maternal deaths by women in reproductive age group. What is this? Maternal deaths by women in reproductive age group. It's MMR, guys. Okay, maternal mortality rate. We can say this as maternal mortality rate. Okay. Okay, what is the denominator maternal mortality ratio? If it is a ratio, the denominator is live births. Okay, live births. Okay, this is women in the reproductive age group. This is women in the reproductive age group. This is maternal mortality rate, not ratio. I'm repeating again. This is the rate. Women in reproductive age group. Ratio means it is live births, guys. Okay, answer will be maternal mortality rate, actually. Rate, fine. This question may not be asked this way, okay? At least they were showing this, I think. The question they were focusing on this bats eating this fruits kind of thing was asked, okay? It may not be this life cycle, okay? Just to show you people, okay? Bats eating the fruit. Just bat was given probably, eating fruits, okay? And they were saying in terms of form they were saying, okay? Only bat. Yes, yes, I understood this. But the answer is that Nipah virus, okay? Nipah virus was asked. Okay, fine. Yes, life cycle was Nipah virus. Next. Early time for IUD placement, guys. Okay, early time. Madam has discussed this already. Okay, so the best time. Okay, so especially this following a pregnant woman. I think pregnant woman was given. Pregnant woman following delivery. Okay, after delivery. Okay, after delivery was given. Okay, after delivery was given. It's a very straightforward question. So before she leaves the hospital, we have to keep this IUCD. Okay, that is as early as possible. Okay, before she leaves the hospital. So we can do it after 6 weeks also. We are not sure whether she will come back or not. Okay, so the best time is following pregnancy is within 48 hours. Is within 48 hours, not 8 hours. Okay, within 48 hours. So question is okay. Question is okay. 8 hours after delivery means it's okay. Within 48 hours, we can give it. Fine. Next. Next question is, okay, in a study, 84 people are consuming, I don't know whether it's a hypocholesterol diet or drug. Probably this diet or drug, okay, for a period of time. So cholesterol levels were compared before and after. Okay, fine. So what is this data? This is quantitative data, cholesterol. Measurable. How many groups are there? Only one group is there. What is the answer? Answer is PAT-T test. Okay, answer is PAT-T test. Before and after. Okay, it's a straightforward question. We have discussed in the classes also. Okay, which among the following will not come in response phase? Okay, maybe this question, what I got the answer based on that I'm discussing. Which among the following will come or will not come? That is okay. Okay, mitigation measure will not come, guys. So following a disaster, impact phase will be there. Then you will respond, you will search, rescue, first aid will be there. Okay. So if it is will come means all will come. Okay. All these things will come. Okay. Will come means relief phase will be there. Rehabilitation phase will be there. Reconstruction will be there. Okay. So this will be there. Okay. Fine. Relief means all will come. So what will not come is mitigation and preparedness will not come. Okay, these two will not come. Okay, mitigation and preparedness. All other things will come. This relief phase, rehabilitation phase, reconstruction phase will be there. Okay, fine. Next question. Okay, guys. Okay, thank you. So patient admitted with elevated levels of coproporphyrin. Yes, it's a topic from this occupational health. So occupational health. Okay, so which one will have elevated coproporphyrin? Yes. So bicyanosis, no. Asbestosis, no. Silicosis, no. Answer is lead poisoning, guys. Okay, increased ALA. Preparedness was there. Okay, preparedness will not come. Preparedness will not come. Preparedness and mitigation, these two are done before the disaster, guys. These two are done before disaster. Fine, next. Components of human development. We are discussing the first session, guys. Second session we'll get tomorrow. We'll do it tomorrow. So components of human development index does not include. Okay, so components, so it does not include. Okay, does not include. So what will come here? So answer is what? It include life expectancy at birth will come, per capita income will come, mean years of schooling will come, IMR will not come. IMR, where it is in all, IMR comes in PQLA, guys. Okay, IMR comes in PQLA. Yes, IMR comes in PQLA. So in PQLA, we got a question that we will discuss tomorrow. Okay, so infant mortality rate, literacy rate, life expectancy, okay, at 1 year of age. Fine. Iceberg phenomenon is shown by which of the following condition? Okay, iceberg phenomenon. Answer was HD. Probably they asked in another way. Okay, other way. The question was asked in another way. So which one is the iceberg phenomena? Okay, somehow we are getting is maximum shown by. So rabies was there, an option was there, measles was there. All three will not show actually. Will not show. I think one option they are saying is chicken pox. Okay, maximum is okay. This is influenza, guys. Answer is influenza. Okay. What is iceberg phenomenon? Iceberg phenomenon is subclinical cases. Okay? There is no subclinical cases. Okay, rabies, tetanus. Okay, so all these three conditions will not show. Probably chicken pox was there. People are saying that chicken pox. Chicken pox also will show subclinical cases, but they use the term maximum. If they use the term maximum means, then influenza will be the answer, guys. Okay, influenza will be the answer. Chicken pox was there. Yes, I understood that. Chicken pox was there. Okay. Okay, all were given. HD was the answer. Yes, I understand that. Fine. In a study, medicines were selected based on the derivatives case. Okay, they are doing a research. Okay, medicines were selected based on the derivatives from animals, plants, and various minerals randomly. Okay, which are the following sampling method was used? Which are the following? Okay, so what you are doing is you have medicines. Okay, medicines, you are going to divide them into based on animals, plants, and minerals. Then you are putting a lot in this. You are selecting, making a lot, and you are selecting this. Yes, what is the answer? Yes, answer is stratified random sampling. You are stratifying it, guys. Okay, you're stratifying it. You are stratified random sampling. Okay, fine. So we got some good number of questions. Okay, I don't think it's any difficult question was there out there. So hope you have done the exam well. Okay, so thank you, guys. Okay, thanks for listening. It's already very late. Okay, thanks for listening. Okay, fine. Thank you.
Thank you, sir. And finally, we have the surgeon, Dr. Sandeep, coming here to finish the session. Over to you, Sandeep.
Can you guys hear me? Can you all see me?
Yep.
Yo, okay. So good morning. I think this is the second good morning that I'm doing for a session. I don't know how much you are left out with your energy. I am completely drained. I came center for all you guys, and then I've been here. So it's equal amount of time. So let's not waste much of our time. I know the question paper was quite tricky, quite difficult. We had a huge debate session 1, session 2, which was difficult. Guys, let me tell you, both of them are equal in their own standing points. Yes, sessions were slightly trickier, more, difficult questions were there. But yeah, more or less. Before we start, how was the whole question paper? Mota na, I felt it something like this. It's like OBG people having a tea party and making their own question paper, and some random department people started coming and they started taking one question from them and started to put together, and that's your NEET PG question paper. So having said all that, let's kick in with our discussion. We have, yeah, it's a, see, I'm not going to take overlapping questions. I've been following because I'm the last sessions. I'll try to keep precisely towards the surgery. We have the question number 1. I hope everybody has answered it quite easily. It's the 𝐒𝐄𝐈 classification for hydrated cyst. Water lily sign is described as, again, needless to tell you, we all know it. You have type 1 variety, which is a simple fluid cyst or simple fluid. Type 2 is your free-floating membrane, that is a water lily. Type 3 is your multiseptate. Type 4 is going to be complex heterogeneous with central calcification, peripheral septa. And the last one is calcified cyst. This is 1, this is 2, this is 3, this is 4, and this is 5. So what do we have? Water lily is your type 2 variety. You cannot afford to miss on that. It's a simple question. Moving forward. Second question, identify the pressure sore given in the image. Right. When you talk about grade 1 pressure sore, it is going to be presence of erythema, which is non-blanching. Grade 2 pressure sore is partial thickness skin loss. Grade 3 is complete thickness skin loss, where the skin and the subcutaneous fat is exposed. And when you talk about grade 4, you have underlying structure which is involved, which is going to be a vessel, a tendon, a nerve, any structure. If it's all grade 4, there's a new grade that is unstageable. If it is covered with slough and necrosis, it is not covered with slough and necrosis. People told bone is clearly visible and exposed. In that context, it is going to be grade 4. Is there anything? Yes, bone involvement, grade 4. Right, so that is going to be with respect to your pressure sore component. There was an overlapping question. I think this was taken in your medicine / your radiology as well. If you see, there is hyperinflated, all this dark black color. That indicates that it is air. It is going to be pneumothorax. I did not get enough amount of options. If pneumothorax was given absent breath sounds, then obviously it makes sense. There was an overlapping question where people said, sir, there is a question which is there, if having a flail chest or a paradoxical breathing, where you're during inspiration, the ribs are being drawn inwards. If that's the question there, then the answer for paradoxical breathing, during inspiration, the flail segment drawn inwards, is going to be your flail chest. Again, taking that into consideration, moving into the next question. Now, the stent given in the image is done with the or inserted with the help of, you see, this is your DJ. DJ is your double J stent. Double J stent does not require a ureteroscope or a nephroscope. You take a cystoscope. When you do a cystoscope, you go into the bladder, you see the ureter, and you push the DJ stent directly into it. You don't need a ureteroscope. So if the option was cystoscope, I would prefer this. If cysto-ureteroscope was given, again, that could be a better option as well. Okay. What was it? They asked, what will you hear over this area? With the chest X-ray, you will hear absolutely nothing. There'll be no breath sounds. Absence of breath sounds is what you're gonna hear if there is going to be your pneumothorax. Yes, if the cysto-ureteroscope was given in the option, I would say that would be a better one than the cystoscope. A cysto-ureteroscope. If that is the option, then I would prefer option D. But if it's cystoscope is only given, then you have to prefer option A. Okay? That's about your DJ stent. Post-gastrectomy, supplementation of which vitamin is required? We all know that you have we have the parietal cells which are present in the stomach. Parietal cells produce two important components. One is hydrochloric acid, other is Castle intrinsic factor. The Castle intrinsic factor is responsible to transport B12. It's a B12 transporting agent. You do not have parietal cells. You do not have B12. If you do not have B12, there's B12 deficiency. It is what we call it as pernicious anemia. It's a known fact. Absolutely correct. Pneumothorax in shift 2. I didn't get you, Ryan. What is your question, beta? You're saying pneumothorax in shift. But if there's a pneumothorax, there will always be a mediastinal shift. If it is going to be having a left-sided pneumothorax, the mediastinal will have a right shift. If there's a right-sided pneumothorax, then mediastinal shift will be left. There will be shift of the apex beat of the heart as well. That is also an auscultatory finding. When you do a percussion, there will be a hyper-resonant node. Because of pneumothorax, positive pressure builds up. It compresses the head and neck veins. There are distended, dilated head and neck veins. There's dyspnea, which is going to be present. There's tachypnea, which is going to be present. All these are classical. We have done multiple number of times. Now, another question, complication associated total parenteral nutrition. Remember, the most common complication is associated with feeding is going to be your hyperglycemia. That is feeding related. But if you're talking about line related, it is going to be line sepsis. Repeat question, nothing tricky about it. Now, this question, they said if there's a carcinoma breast or phylloids, that is what I want you guys to tell me, whether it's a phylloids or carcinoma breast. Ulcerated skin lesion, liver mets. If the liver mets are there, it's a malignant lesion. For a malignant lesion with metastasis, it's only palliative management. Now, in the palliative management, what you can do? See, when talk about palliative management, you can try a neoadjuvant chemotherapy, look for response. If it is responding, I would do toilet mastectomy. The ideal option should be there for toilet mastectomy. If anybody is listening down there, I want you to tell me, was toilet mastectomy given in the option or not? If not, You'll do a neoadjuvant chemotherapy down. It's not about downstaging. It's looking for response. And because the ulcer is present, I want the patient to get some benefit. So yes, if toilet mastectomy was not given, then the answer here is going to be neoadjuvant chemotherapy followed by surgery. I'll not do a radical surgery. Simple mastectomy will not help. Okay? So here the goal is to reduce. So adjuvant followed by surgery, and that surgery will still be toilet mastectomy. Okay? Option D will be correct here. Sorted? Okay. Chalo, moving to the next question. You have history of renal tuberculosis, sterile pyuria, presented cystoscopic findings. Cystoscopic finding, if it is given something like this, the small hole ureter, it's a golf hole ureter. We know the findings which are there in the renal tuberculosis, or I guess a genitourinary TB. You start with the kidney. In the kidney, you have putty kidney, you have cement kidney. Then you have going into the ureter, you have golf hole ureter. Then you come to bladder, there's a thimble bladder. You go to the prostate, it is hard indurated prostate. You get into vas deferens, beaded vas deferens. You go into scrotum, discharging scrotal sinuses. All of them are there. Okay, was an option. Okay, golf hole ureter. Yes, the answer here is going to be golf hole ureter, A for Ahmedabad. Can you help me with other options? What were the other options given? Anything that you can think about? I know you're tired. If you are able to type, please do it. If not, it's cool. I'm not going to torture you much. Okay? But mota, this is what the answer is. Okay? Ulcer, unlikely beta, it cannot be a bladder ulcer. Bladder ulcer will have erosions. It will have component. Linear ulcer was given, cannot be an answer. Diverticula, yes. Now this is getting trickier. But then renal tuberculosis, sterile pyuria, diverticula, it is not going to have any component. If the patient had urethral stricture, and then a cystoscopic image, which you're having a nice inverted component, it can be a bladder diverticula. Can't think now. It's okay, cool, no problem. Okay, umbilical swelling. Actually, there was a lot of questions about umbilical swelling. Somebody is talking about patent urachus. See, if urine was leaking, it is patent urachus. If a stool was leaking, it is patent vitalointestinal duct. Urine, patent urachus. If fecal matter was going, it is patent vitalointestinal duct. The anatomy sir has already discussed it. The pediatricians has also discussed it. I am also telling you the same component. We will look into it. Okay, so don't worry about it. I am not confusing beta. If history of TB is given, sterile pyuria is given, bladder was shown, cystoscopic image was given, a small hole was shown to you, the answer has to be a golf hole ureter. There is no if and but. There's no confusion. Monu Singh, do not get confused. I am saying absolutely clean in your head. History of TB, renal tuberculosis, sterile pyuria, cystoscopic image, ureter, which is going to be pinpoint. It is golf hole. Characteristic. Okay? Yeah. So I'll try to find out what are the umbilical questions are there. One was about umbilical hernia, one was about patent urachus, and one was about your patent vitalointestinal duct. We'll try to reconstruct all of them together, right? So don't worry about it. Identify the condition again here. There was a question whether it's a pilonidal sinus or a fistula in ano. Remember, if you saw the image with a lot of hair around it in a gluteal cleft, hirsute with gluteal cleft and a sinus, it is pilonidal sinus. But if you can see the perianal region with discharging sinus, it is going to be fistula in ano. Now you have to tell me and decide, what did you see? Was there a lot of hair, a dark skinned person, or a lot of hair with a hirsute, and then you have a sinus right in between the gluteal cleft? The answer will be pilonidal sinus, or else it is going to be fistula in ano. The lesion wasn't in the midline. Beta, it is not necessary. It is always in the midline. It can be in that gluteal cleft region, in and around. That is also possible. Pilonidal sinus pakka image tha. Fistula in ano, sir, because it was present in the perianal region. Okay, if the perianal region, if you're able to see the anal opening and there was an opening around this area, it is going to be your fistula in ano. It cannot be your pilonidal sinus. A lot of hair was present. See, that is what, if in this perianal region, you will not have much amount of hair. Okay? So if the hair was present in a gluteal cleft region, then it is going to be pilonidal sinus. Skin tag was also there. Okay, darker skin definitely in the perianal region. I'll let you decide. See, if the anus was not visible, then I would go with pilonidal sinus. If the anus was visible and in the perianal region you see this opening, then the answer is going to be fistula in ano. There is no component. Okay? बेटा I'll give you one very important suggestion. अपने दिल को तसल्ली देने के लिए जो मर्जी बोलना है बोल लो. एग्जाम में जो सवाल आया था वही आया था, एग्जाम में जो आंसर था वही था. अब मैं आपको ये बता रहा हूं कि जो पॉसिबिलिटी है आंख बंद करके सोच लेना, you'll get the answer, don't worry about it. ठीक है. बहुत सारा हेयर था and then it is in the gluteal cleft region. अगर anus is not visible, the answer is going to be pilonodal sinus. I'm not going to talk about it. Okay, then you have penile cancer. We had a patient who had a penile cancer, stage 3 was given, I think, no palpable lymph nodes. Now, here is a very interesting thing. Now, in terms of management of penile cancers, we've been telling about in a very simple context that if it is present on the prepuce, if it is an early malignancy, we'll go ahead, do a circumcision. In glans, it is glans. We are going to remove the glans penis. That is going to be your glans excision. If it is on the shaft of the penis, you will see the stump length. If the stump is more than 2 centimeters, it is partial amputation of penis. If it is less than 2 centimeters, complete penile amputation was the treatment that we used to give. The latest edition also says you that you can do a Mohs surgery, which is removing 1 millimeter of margin until you get a tumor-free margin. About the lymph nodes, if it is palpable, not palpable. If it is palpable, you'll wait for 3 weeks, give antibiotics, and then see if they regress, because that can be because of infection. If they do not regress, then you will go ahead with bilateral inguinal block dissection. But if it is a palpable lymph node, you do a sentinel lymph node biopsy. This is what we've been talking about. तो क्या है? So for breast cancer, the image was bossulated surface with ulcer with liver mets. Even then the answer remains same. Yes, even then the answer remains same. It is a malignant lesion. See, phylloids, if it is not having mets and if it is a benign lesion, then the answer for the phylloids I can give you as simple mastectomy. Remember, even if it is, see, if phylloids benign is there, wide local excision, phylloids malignancy without mets, it is simple mastectomy. Phylloids malignant with liver mets, it has to be treated as breast cancer with metastasis. As simple as that. No if and but. Okay. Okay. Inguinal nodes removed and more preference in penile cancer or ilioinguinal nodes. Beta, it has to be inguinal block dissection. Okay. That's the answer that you're looking for. Penile cancer was given, T3 stage was given. So T3 is going to involve the urethra. I've given you completely. See, it doesn't matter if you're talking about the nodal dissection. The component depends on whether it's a palpable or a non-palpable node. So if it is non-palpable, you have to do a sentinel lymph node biopsy. You have spoken about the node of Cabana in the same context. Okay? But there is no need for orchidectomy. If the orchidectomy is the option, there's no need for orchidectomy. If penilectomy was given with sentinel, see, if there is no palpable lymph nodes, no, look for an option with penile amputation with sentinel lymph node biopsy. Was there an option there? Was there an option? Tha, nahi tha. Yeah, there was a question with split skin flap or a skin graft. Okay. If only penilectomy is there, then you will go with penilectomy. Don't worry about it. Don't worry. Agar sirf penilectomy option mein tha, you don't need to do an inguinal lymph node dissection. That's what I'm trying to tell you. Okay? Non-palpable lymph nodes in penile cancer, without confirming on a sentinel lymph node biopsy, I will not do an inguinal block dissection. Simple. Khatam. Okay? Right. Got it. Chalo. Now, we have a 6 weeks old child with vomiting. Ultrasound image was given. This is a clear-cut case of CHPS. It cannot be duodenal atresia. It cannot be annular pancreas. It cannot be jejunal atresia. Why? Q. I've been telling you again and again. All the other disorders will present to you on day 0 or day 1 of life. The only one which presents to you between 3rd to 6th week of life is going to be congenital hypertrophic pyloric stenosis. End of discussion. Nothing further than this. Cleft lip, cleft palate, ideal time of management. You have to see how are the options given. See, if it is a unilateral cleft lip, if there is a unilateral cleft lip, you can repair between 5 to 6 months of age. If there is a bilateral cleft lip, then it is between 4 to 5 months of age. If you have soft palate, the soft palate should be repaired in 6 months. And if there is a hard palate, it should be repaired between the age of 15 to 18 months. Look for this table. This is what we are supposed to know. Nothing more or nothing beyond than that. Okay? Chalo. Okay, unilateral cleft lip, it is going to be 5 to 6 months is the earliest. Bilateral is 4 to 5 months. Okay. Earliest, then it will be, if your option is 3, 6, 12, and 8, the answer is going to be 6. Okay. If the earliest was given, if they were asking earliest, if they were asking for earliest, then the answer is going to be 6 months. Okay. End of discussion. Sorted? Absolutely. Okay. Identify the image given in upper GI endoscopy. This cannot be a Barrett's esophagus. We'll have a red velvety mucosa. It for sure is going to be an esophageal varices. It is not a gastric erosion. The fourth option is not known. Clear? Chalo. So these were the questions which were purely of surgery. I've given around 15 questions. Yes, there were 3 umbilical questions. There was 1 question on skin grafting, which I wanted you to tell me. Apart from that, see, there are session 2 questions also, which I've gotten, but then I'll do a comparative question discussion tomorrow, so don't worry about it. Tomorrow, when we do a surgery discussion, we will do surgery, that is session 1, in comparison to session 2, and let's see who got a better chunk of question. So with that, so a child was there in an umbilical hernia. Okay. नहीं था किसी भी ऑप्शन में. अच्छा, ठीक है, we'll look into it. ठीक है, अभी के लिए let's rest it down. I know you had a very long day. It's not even a day. Like you've passed a day. You have worked really hard. अभी अपने आप पे थोड़ा तरस खाएंगे. Herniorrhaphy and umbilectomy was there. देखो, umbilical hernia, if the age of the child is mentioned and if it is less than 2 to 4 years, we will not do a plasty. It will always be a primary repair. Agar it is more than that of age, then you can go with the plasty. In fact, less than 4 years, I will not operate as well. I'll wait for conservative management. Okay? So don't worry about it. We'll try to figure that out. Not it was the older child, no age was there, only image. If there is no age given, if it is okay, then it becomes trickier. We have to see. Umbilical hernia का treatment actually age related होता है. अगर baby की age less than 2 to 4 years है, you can go with a conservative management. अगर the age is more than 4 years, then I will do a tissue repair. If it is an elderly patient, that is adult, I will do an IPOM, that is intraperitoneal only mesh repair. As simple as that. ठीक है? So let's decide on the competence of that. Amputation का सवाल, I think ortho में मैम ने लिखा हुआ है. I think the stump given was below knee amputation. It is called as BK amputation. ठीक है? क्योंकि how do you know if the tibia and fibula both of them are exposed? It has to be below knee. No, above knee में एक ही bone दिखेगी ना, below knee में 2 bone दिखेगी. खत्म बात. Aortic dissection का some question. अच्छा, ये radiology में discuss हुआ था कि was it an aneurysm or a dissection? ठीक है? So again, the image, Rishabh sir has discussed it. I would request you to go and look back it. It was more of a radiological question because only image was given. If the sac-like presentation is aneurysm, for a dissection, the split and the entire extension has to be present. Okay? I know in dissection, we have 2 classifications. One is your Stanford classification. I hope everybody remembers. Another one is 𝐷-Bakes classification. Currently, we follow your 𝐷-Bakes classification. No reducible and the color change in the umbilical. It's an irreducible umbilical hernia, then you have to operate. Irreducible umbilical hernia के लिए only tissue repair. Answer for irreducible. देख, अगर umbilical swelling is there, it is showing irreducible. If there's a color change, if the skin color of the umbilical skin is darker compared to the surrounding region, it indicates congestion also. For that, you have to go with tissue repair. Sir, how DJ stent will be introduced in the place? Ureteroscope or cysto-ureteroscope? See, DJ stent insertion is done with the help of cystoscope. If not cysto-ureteroscope, ureteroscope से नहीं डालते हैं. You see, DJ stent कैसे insert करते हैं? हम bladder के अंदर जाते हैं, ureter को identify करते हैं. We take the DJ stent and we push into the ureter and allow it to go all the way to pelviureteric junction. ठीक है? तो ureteroscope अगर घुसा देगा तो stent घुसाने की जगह नहीं होगी. It has to be cystoscope or cysto-ureteroscope is the answer. ठीक है? Skin grafting का जो question है, I did not get a proper stem of the question, but whatever I've gotten, it looks like either it has to be post-burn or it is going to be a post-degloving injury. For a superficial erosions or if there's a huge skin loss, it is grafting. If the muscle is gone, we'll go with flap. Otherwise, no need. ठीक है? Okay, fine. Chalo. So with that, let's call the session for today. I can't bear the energy. You guys are still pumping in with a lot of, interactive questions. I would want to continue, but then we'll hold it down here today. Tomorrow we'll come back. There'll be a comparative question between the session 1 and session 2. We'll answer every single bit of it. Ranjit sir is also here. So
Hey
over to you,
guys,
sir.
thank you every student who has been patiently listening to the entire lecture for almost 6 hours, right? And thank you to all the faculties who have put in efforts to create the recall as much as possible with the options which you have got. And the entire team, we have to thank the management, Raman, Dr. Manish, Aditya, who's handling the studio, and entire people who's working in the studio team, because they are also staying till 1 a.m. for us. Kanchan, who's helped to coordinate all the teachers, the timetable and everything. Dr. Ashad, Dr. Anto, Dr. Jigar, and every student who has helped us to give us a recall, right? So it has been an amazing thing. And we've been saying this for quite some time now. This batch has showed so much of resilience with all the things they have gotten into, be it things which is not controllable, be it the natural climate, everything has been a thing for you guys. Yes, there's been a confusion about which is better, which is not better, the first morning batch or the evening batch. It's always subjective. You can't draw a line that this is better, this is not better. The normalization scores, how it works, will definitely come up with an beautiful, because NBA has released a beautiful PDF on that. We'll come up with a video of how exactly normalization works, so that you'll have a well-informed idea. And like Dr. Sandeep said, we'll have the paper 2 recall tomorrow in the same YouTube channel, and hope to see you guys. So all the very best. So you deserve a well-deserved rest. So go, just sleep and come tomorrow morning, right? See you. Bye.
All right, guys. Thank you. Bye. Good night. Good night. Take care.